So high fasting blood glucose, that is the basal issue. PP is postprandial, maybe due to the postprandial dysfunction. When both are elevated, neither of them are controlled, it may be due to the advanced disease. Then it may be due to the consider steroid effects or infections may be there. So we have to exclude the secondary causes. A patient coming to you, the most commonest cause may be the UTI or infection at the time, injury at the time. It may be due to tuberculosis, may be associated with the hypothyroidism, Cushing syndrome, chronic liver disease, or LADA in lean individuals. So lifestyle optimization, again, advise your patient for 150 minutes per day, but always better that you ask your patient, walk for 45 minutes every day. That's the best thing. Resistant exercise, that has also very become important. Earlier we used to say that only fine aerobic chal jayega, walking chal jayega, but nowadays you have to give some emphasis that some sort of resistant exercise should be there, and our goal should be 5 to 10% weight reduction, reduced refined carbs, increased fiber and protein. So pharmacological optimization, metformin maximal dose, then you can add SGLT2, then you can add GLP-1 receptor agonist, DPP-4 inhibitors, but be cautious with the sulfonylurea use, especially in elderly patient. But in our country, sulfonylurea has to use due to our poor socioeconomic condition. We don't have any other option. So when to start injectables? Whenever HbA1c is more than 9%, or there is failure to triple oral therapy, there is some sort of catabolic symptoms, fasting is more than 250, especially if someone is going to surgery, there is no option, you have to give injectables. If blood sugar is more than 250, you should try to keep less than 180 milligram of blood sugar at the time of surgery. GLP receptor agonist preferred if patient is overweight. Nowadays, all drugs are in fashion. All of drugs are, doctors are using even the person not obese in overweight. Whatever the BMI is concerned, they are not concerned. BMI fine, patient thoda mota jhota hai, laga do. Well hai, laga do. This is not the way. It should be used at the proper time. So what should be the insulin strategy? You have to give 10 units per day, or say 0.1 to 2 units per kg body weight. Tighter dose every 3 to 4 weeks. Add prandial insulin if required, and consider premix in selected patients. So managing postprandial hyperglycemia is very important. Common due to high carb Indian, हम लोग बहुत ज़्यादा चावल वावल खाते हैं. Carbohydrate portion diet का बहुत ज़्यादा है. So in this case, the alpha glucosidase is less used by us. All of the physicians, I used to see prescriptions because it's not being promoted by the pharmaceutical house. So we use less alpha glucosidase inhibitors. GLP-1 receptor agonist and rapid insulin is also choice. So technology, we have to give emphasis. Self-monitoring, continuous monitoring, time while you are doing CGMC, time in range. Nowadays we are giving very emphasis on this, giving importance to this. At what time in range of blood sugar level is there in a patient. So ultimately HbA1c is the 3-month reassessment cycle. So what you have to do? You have to see the patient is coming to you, whether is suffering from, you have to see that what is the complication, why you are not able to control our HbA1c. You have to see the conditions, whether patient is coming to you with RBC survival like hemolytic anemia, acute or chronic blood loss, hyperesphenilism after blood transfusion, treatment with erythropoietin and CKD. If blood glucose level look high, but HbA1c appears surprisingly low, then better alternatives like fructosamine or continuous glucose monitoring should be done in such type of cases. Second, if again there was the reduced blood glucose, RBC survival. Here, when RBC survival is prolonged, if RBC survival is longer, then usual glycosylation continues for longer, giving falsely high HbA1c, like iron deficiency anemia, vitamin B12 deficiency, folate deficiency. And what is the clinical clue? Glucose readings are near normal, but HbA1c is unexpectedly high. And the most important thing that if someone is coming to us with polycythemia vera, again the HbA1c value will be very high. Presence of hemoglobin variant. We said that glucose is being glycosylated on the hemoglobin, so any abnormality in the hemoglobin like sickle cell or HBC, HBE or HBED, all these things will affect HbA1c. In these cases, this is the common method, which HLP-LC, which is the most common preferred method of doing HbA1c. Boronate affinity chromatography or capillary electrophoresis should be done, but it's very difficult to get these things done. Sometimes this LAL lab and all the low labs, they are preferring, but it's still not always. So in chronic kidney diseases also, due to reduced RBC survival, carbamylated hemoglobin, and erythropoietin therapy, HbA1c may underestimate glycemia. So rapid changes in glycemia may also affect HbA1c. Whenever someone is taking insulin and he has started insulin recently, or his diabetes has deteriorated due to any other reason, then again HbA1c may be affected. And here short-term markers like 1,5-N-hydroglucositol or for fructosamine are helpful. These are the guideline references from which I have made the slides. That's all. Thank you.
Thank you, sir, for your wonderful and elaborative talk. So, any questions we will take at last of the session. So, you may kindly take your seat, sir.
Okay, thank you.
For the next talk, may I invite consultant physician from Ranchi, Dr. Himalaya Jha, sir. He needs no introduction, and he will be talking on atherogenic diabetes dyslipidemia, newer perspectives.
Hello.
So over to Dr. Himalaya Jha, sir.
ठीक है 2 मिनट रहिए ठीक है गुड मॉर्निंग रिस्पेक्टेड our patron N.K. Rai sir, respected chairperson, distinguished faculty members and dear friends. I am deeply honored to be here, given opportunity to speak on a burning topic of atherogenic diabetic dyslipidemia, newer perspectives. I will all know that diabetes is a chronic complex condition requiring a regular follow-up, regular care with transformation of multiple risk factors beyond glycemic management. So I will discuss this topic on following objective: atherogenic diabetic dyslipidemia and its clinical relevance, pathophysiology, current management strategy, and role of non-statin therapy. I am going to throw data of ICMR, and it was shown that there is a prevalence of prevalence of metabolic condition in India. The bar diagram showed that 101 million people are living with diabetes. It means 11.4% of Indian population are living with diabetes, and about 15.3% of the Indian population are in pre-diabetic stage. But what is pattern? Pattern in Indian population is low HDL cholesterol, high triglyceride, but normal LDL cholesterol could be high, small, dense LDL cholesterol. And prevalence is 81.2% of Indian adults have dyslipidemia, with low HDL and high TG, and this is a data of ICMR 2023. Now I'm going through a case, hypothetical case, a 55-year-old male having BMI of 20 kg per meter square. It means he is overweight and had a history of type 2 diabetes for last 10 years with one of the ASCVD risk factor hypertension, and current medication is on metformin, Impa, Atorva and telmisartan. But see the lipid pattern. HDL cholesterol is very low, triglyceride is high, LDL is almost normal. But what happens when there is high triglyceride? There may be high non-HDL cholesterol, and ApoB should be elevated. So already discussed that atherogenic diabetic dyslipidemia have three triad: low HDL, high triglyceride, high small density LDL cholesterol. So what is the pathophysiology of this atherogenic diabetic dyslipidemia? I will discuss on the next slide, but there is a increased atherogenicity and highly atherogenic LDL cholesterol, means a small dense LDL cholesterol. See, when there is diabetes, long diabetic, or even at the beginning of the diabetes, there is a increased insulin resistance. When there is insulin resistance, there is increased flux of fatty acid from abdominal obesity for visceral fat. So what happens when visceral fat flux increase? There is increased transfer of free fatty acid in the liver, and there leads to increased production of VLDL. But if VLDL is high, there is a transfer of triglyceride to LDL cholesterol and HDL cholesterol by CCT cholesterol ester transfer protein CETP, and this mechanism leads to high burden of triglyceride on LDL cholesterol, at the same time on HDL cholesterol. When there is transfer of triglyceride in the LDL cholesterol, there is a increased activity of lipase. This hepatic lipase enzyme reduces the size of LDL cholesterol, that is called a small dense LDL cholesterol. At the same time, transfer of triglyceride to HDL cholesterol leads to fragmentation of HDL cholesterol, and A1 is excreted through the kidney, so there is low HDL cholesterol. I am going through a very important slide, that monitoring of conventional LDL cholesterol may be misleading in diabetic. The level of LDL cholesterol is not necessarily proportional to number of lipoprotein particles. I am going through the two patients, patient 1 with 130 milligram of LDL cholesterol, second patient also have 130 milligram of the LDL cholesterol, but who is more atherogenic? One side, to the left side, there is a bigger LDL particle, and on the right side, there is a smaller LDL particles. So these smaller LDL particles remain in the circulation for the long time, and it has a capacity to penetrate the endothelium and having capacity to oxidize, so their is increased atherogenicity with a small LDL particles rather than by larger LDL particles. So, there should be a LDL P number. P value is usually not estimated because it is estimated by NMR spectroscopy, which is very costly affair. So it is not feasible in day-to-day practice. So what is, when there is more LDL particles, more ApoB100. More ApoB100 means ApoB is a part of most of the cholesterol endogenous pathway of lipoprotein like VLDL, IDL, LDL, and SDL. Now, what is remedies for these high LDL particles? And before going to my first hypothetical case, who was a person who is diabetic since last 10 years, age was 55, so he fall in the category of people between 40 to 75 years of age. So, if there is one ASCVD risk factor, that is hypertension, so we use high intensity statin in person with one or more ASCVD risk factor with LDL cholesterol goal should be less than 70. If goal is not achieved, it is reasonable to add ezetimibe or anti-PCSK9 therapy, inhibitor therapy with proven cardiovascular benefit to maximum tolerated statin therapy if LDL goal is not achieved. Next slide, I will discuss why ADA recommended treatment of secondary prevention of ASCVD in diabetic patient with target of less than 55 milligram per dl of LDL cholesterol. If target is not achieved, you use alternative lipid lowering therapy like PCSK9 monoclonal antibody, bempedoic acid if patient will not tolerate a statin. And other is PCSK9 inhibition with SI, a small interfering RNA, that is inclisiran. Residual risk always remain when there is a high triglyceride, more VLDL. Then we can see through two trials, HPS and CARTS trial. There is a 22% risk reduction, but still there is 78% residual CVD risk. In CARTS study also, there is 68% residual CVD risk in spite of 32% risk reduction. Same, it means residual CVD risk of 70 to 80% remain even after intensive statin therapy. So what if target of LDL is not achieved, then what we should do? We should add ezetimibe. Ezetimibe reduced 20% further LDL reduction compared to statin alone. AHS suggests that adding ezetimibe to maximally tolerated statin therapy to reduce LDL cholesterol by more than 50% in people with diabetes and 10-year ASCVD risk of more than 20%. Other effect will be a small increase in HDL cholesterol, reduction in triglyceride, and have neutral effect in glucose metabolism. I am going through a very important trial, improve IT trial. What was the primary result? I am going through a Kaplan-Meier curve on the right side. Hazard ratio is 0.936, means there is a 6.4% relative risk reduction. And see the graph at the very beginning. There is no separation of graph at the beginning, I mean in time since 1 or 2 years. But after 1 year, there is a separation of the curve. What it shows, the person who is taking statin with ezetimibe had better cardiovascular outcome. And it is persist through 6 years. What is NNT? NNT was also significant, but it was not very significant. It is just 50. So, adding the ezetimibe to statin is beneficial and showed risk reduction in this. So, non-statin therapy for intensification PCSK9 inhibitor. It is a monoclonal antibody which binds to PCSK protein released from the liver. So, there is a increased LDL receptor recycling. And what is effect? It has been seen that LDL cholesterol could be reduced up to 30 milligram per DL, going through 2 important trials. Fourier trial, evolocumab in presence of statin therapy reduced LDL cholesterol level to median of 30 milligram per DL, in addition to fall in the risk of the cardiovascular events. Again, I am going through the Kaplan-Meier curves on the left side, and what was the primary efficacy endpoint? Patient who is taking evolocumab, there is a 2% risk reduction, 2% absolute risk reduction, and hazard ratio is 0.85, means 15% relative risk reduction. And benefit started after 6 months of therapy. And the separation between the curve was seen till 3 years. So, there is a significant risk reduction in the Fourier trial.
Sir, please summarize in next 1 minute.
Then we should go through Odyssey outcome trial, that is the PC inhibition in post-ACS patient. And secondary endpoint was very significant. Death, MI or ischemic stroke was reduced 10.30 in alirocumab compared to placebo, and p-value was significant. Now, fibrates, there is no cardiovascular benefit in field study also, but a small but significant 20% risk reduction seen in secondary CV index. Accordingly, fenofibrate is not helpful in reducing CV event. Omega-3 fatty acid reduced IT trial, it also showed.
Sir, time is over. Please summarize.
Conclude.
Next 1 minute.
Due to South Asian phenotype, most common type of dyslipidemia in India is high triglyceride following low HDL cholesterol. Insulin resistance is the primary root cause of multiple metabolic disorder like type 2 diabetes and high TG. Lifestyle intervention like weight loss, increased physical activity, reduction of saturated fat, and smoking cessation. Pharmacotherapy are statin first line of primary and secondary therapy, prevention strategy. Add-on therapy is ezetimibe, PCSK9, IPE, and others are due to paucity of time, I will not discuss CETP inhibitors, NGPTLs inhibitors, and last not mostly siRNA and this antisense therapy. Thank you.
Thank you, sir, for a nice presentation. Next speaker is not available. That's why I call up to Dr. Visul Gupta for topic of role of environmental pollutions and endocrine disrupts in diabetes.
So over to you, sir.
So good morning, friends. At the onset, I must congratulate the organizers of CCDSI Bihar and Jharkhand chapter, especially Dr. Gunjan and Dr. K Singh, for such a great scientific program, and especially including this topic, role of environmental pollutants and endocrine disruptors in diabetes. Because pollution, climate change is coming up as a big risk factor in almost all the diseases adversely affecting the human health. So before I start the lecture, I must pay tributes to my late father, Comrade Ved Prakash Gupta, and appreciation, thanks, and I am indebted to Dr. Gurpreet Singh Wander and Dr. Paramjit Singh Olak for polishing my academic skills so that I am speaking here in front of you. So with the chapter, starting the lecture, India is often referred to as the diabetes capital of the world, and recent ICMR in-depth study has shown how the prevalence of diabetes has increased and what is the extent of the prevalence now. So diabetes mellitus is one of the most significant global health challenges in 21st century that we all know. And moving to the ominous octet of diabetes from traditionally attributed to genetic predisposition, sedentary lifestyle and dietary factors. When we were students, we used to think that these are the risk factors, and now we have moved on to the ominous octet for causation of diabetes. But recently, evidence highlights an under-recognized contributor of environmental pollutants and endocrine disruptors in pathogenesis of diabetes, and this is being prominently in you can say focus in this century. So what are the environmental pollutants? These are the chemical substances or mixtures released into the environment. They include persistent organic pollutants, heavy metals, air pollutants, agrochemicals, and plastics and additives. And major sources include industrial factors, transportation, agriculture, household activities, and burning of fossil fuel. So environmental pollutants are classified by the medium they are in, that is air, water, land. Other types, noise pollution, thermal pollution, light pollution, and they can be categorized as the nature, that is biological, chemical, or depending upon whether they are concerned with radiation. So what are the endocrine disrupting chemicals? The Endocrine Society defines these things as exogenous, that is non-natural chemical or mixture of chemicals that interfere with any aspect of hormone action, and that includes synthesis, secretion, transport, binding, or elimination of natural hormones in the body that are responsible for maintenance of homeostasis, reproduction, development, and behavior. And you can very well gauge that every aspect of hormonal biosynthesis is being affected by endocrine disrupting chemicals, and they can play havoc with our homeostasis of the body. So if you see this, they are prevalent all over. Making of polycarbonate plastics in plastics. Plastics is integral part of our life today. Cosmetics and fragrance in agriculture, electrical equipments, lubricants, flame retardants, non-static coatings, antimicrobial agents, and byproduct of industrial processes, waste incineration, and paper bleaching. So they are present, affecting each and every aspect of our life. And this is classification of chemical types. I will not go into detail. So this is based on the sources, that is drugs, household and industrial chemicals, and byproduct of operations. So common endocrine disrupting chemicals and their use. From this slide, it again sensitizes us that even kid products, food products, pesticides, contraceptives, textiles, personal hygiene, medicine, and electronics include these endocrine disrupting chemicals. So the United Nations Environmental Program defines pollution. It is the direct or indirect alteration of biological, thermal, physical, or radioactive properties of any medium in such a way as to create a hazard or potential hazard. Mark these lines: to create a hazard or potential hazard that is in future to human health or to the health, safety, or welfare of all living species on earth, whether they are bacteria, plants, animals, anyone is being affected by pollution. Air pollution in India, WHO reports 9 out of 10 people worldwide breathe polluted air, and in India, pollution is a significant public health issue. So this slide again sensitizes us that 63 Indian cities are among the top 100 cities of the most polluted cities in the world. So that shows us the extent of air pollution we are confronted with. So Earth's health and health of Earth's inhabitants is greatly linked to each other. So there is growing interest in contribution of non-traditional risk factors such as environmental chemicals, micronutrients, or gut microbiome. Yesterday I heard a lecture on gut microbiome. It is again a very, very sensitive and important issue to the etiology of several adverse effects on human beings, including, most important, the metabolic health. Most representatives of endocrine disruptive chemicals show well-known causal relationship with obesity and diabetes. Again, I will not go into details or bore you with detailed studies, but this statement is important that now ample evidence exists to show that these chemicals are affecting our health, most importantly, the metabolic health. And this slide also shows that plastics, the flame retardants, environmental pollutants, surfactants, various names are there. So how they are associated with obesity, insulin resistance, with diabetes or liver abnormality. To talk about that matter, it is adversely affecting all the systems of the body. And these chemicals are more dangerous because they are resistant to degradation. So they are there for whole of the earth's life. They possess low solubility in water, high solubility in lipids. That is how they can affect and reach the distant parts of our body. Tends to accumulate in adipose tissue. They have longer half-lives. Several longitudinal studies have investigated the potential role of persistence of endocrine disruptive chemicals and non-persistent endocrine disruptive chemicals. Special concern is for phthalates and bisphenol A, because more than 95% of all people worldwide have BPA in their bodies. So that is how they are regulating our body's mechanisms. So EDCs are present ubiquitously in environment, and human exposure occurs through intake of water, food, via inhalation, and through skin. So this again slide is a very crowded slide, and it shows every aspect, every activity, every commercial or agriculture activity is not free from endocrine disruptive chemicals, and numerous studies link the exposure to endocrine metabolic disorders. Indian research indicate that phthalates common in plastics epigenetically increase risk of diabetes. The pollution studies by the National Health and Nutrition Examination Service suggest that diagnosis of self-reported diabetes was strongly associated with exposure to these chemicals. studies report that is suggestive of strong association between diabetes and pre-diabetes with the endocrine disruptive chemicals. Exposure to these chemicals during pregnancy is another critical and very important issue. So again, this shows that how these chemicals are affecting obesity, type 2 diabetes, and even type 1 diabetes also. The sources of exposure to environmental metabolic disruptive chemicals, they are affecting the prenatal life, the natal life, during infancy, prepubertal, adult, and old age. So everybody at every stage of life is being influenced or affected, adversely affected by these chemicals. Again, to stress that metabolic disorders, male reproductive abnormalities, cancer, and female reproductive abnormalities are being influenced by these chemicals. So this is how these environmental pollutants are affecting our nervous system. It is causing carcinogenesis, hepatotoxicity, neurotoxicity, nephrotoxicity. For that matter, to summarize, each and every system of our body is affected, and this is how the metabolic pathway is leading to diabetes. Various type of studies can provide evidence to identify these chemicals, yet a systemic method is needed to integrate these data to help identify such headers and key characteristics. That is what we call cases. 12 cases are devised, and these are the list of 12 cases. Out of that, 4 are important, which alter the function of endocrine pancreas, impair the function of adipose tissue, disrupt metabolic signals, and promote insulin resistance. So EDs can induce cellular damage by mimicking or interfering with hormones, what we have discussed in the previous slides. Every aspect of hormone, you can say effect, is being influenced by these chemicals. And mainly the representation of mode of action, again, it is just to sensitize that there is ample evidence existing that these chemicals are affecting each and every step, each and every system of our body, and impact is great. You name the system, it is being affected. And we have published a book that is Pollution and Health. This is a unique book in the world with 34 chapters, including each and every system, how the system is affected by the environmental pollution. And we are distributing it free of cost. It is available at our website www.apimalwa.com. You can download the book and read the book for sensitization and importance of pollution in India. This is next book we are going to publish in a few months, Climate Cardio Nexus, Mechanism, Evidence, and Global Impact. So this is going to sensitize how metabolic and cardio nexus exist with climate change. So if we talk about mechanism, it is prenatal exposure, epigenetics, immunology, oxidative stress through airways or alveoli is initiating the mechanism for these chemicals to act. So that is the physiological pathway. Again, this is a crowded slide, but just to sensitize everybody that this is affecting again every aspect of human organs. So impact of air pollution and metabolic health, impact is again great. It is due to oxidative stress, triggers, etc. Again, this is going to stress the same things, how it is being affected. So my dear friends, the research and gaps of future direction include, there should be longitudinal studies, we should identify biomarkers, gene environmental action should be investigated, gut microbiome alteration, again, it was very well depicted in yesterday's lecture. Healthcare cost of pollution related diabetes should be estimated. So vulnerable populations include children, elderly, low income group, and pregnancy. Preventive and mitigation strategies, most importantly, is at public health level, chemical level, individual level. And to conclude, my dear friends, India is often referred, or what might I say, that it is being branded now as diabetes capital of the world. Environmental pollutants and endocrine disruptors represent a new frontier in diabetology, not only diabetology, but human health. Interplay of industrialization, environmental exposure, and metabolic health requires urgent attention. Their mechanisms range from insulin resistance, beta cell toxicity, oxidative stress, inflammation, mitochondrial dysfunction, and epigenetic changes. Addressing these exposures to policy, public health interventions, and clinical practice is essential, and it is time of the hour. So this book is available, as I have already told, and thank you very much. With this, I invite you all to 13th Annual Conference of Association of Physicians of India, Malwa branch in Bathinda, MAPICON 2026 from 17th to 20th September. And we have included CCDSI session in the last conference, and invite Dr. A.N. Rai to please suggest me 3 speakers from national and 2 speakers we will get from our state for CCDSI session in 2026. Thank you very much.
Thank you, sir, for your timely completion of this session, and you are supposed to be the torch bearer for the society as far as pollution and metabolic disease are concerned. So now may I invite the last speaker of the session, Dr. Rajiv Kumar Jha, and he will be talking on nephron to myocyte redefining diabetes. So Dr. Rajiv Kumar Jha, the dais is yours now.
Respected Chairperson, Honorable Member of Organizing Committee, and my dear colleague. First of all, I would like to thank the Organizing Committee for giving me this platform to share my thought. And with permission of Chair, I'll be speaking on from nephron to myocyte, redefining treatment of diabetes. So traditionally we categorize diabetes complication into microvascular and macrovascular. But in reality, vascular damage starts from very small vessels or capillaries of an organ, like functional unit of kidney, that is nephron, to larger arteries supplying myocyte of heart. So thinking in terms of nephron to myocyte is a better way to understand diabetes. This nephron myocyte axis is central to understanding of modern diabetes as cardiorenal metabolic disease rather than an isolated glucose disorder. So various stressors like hyperglycemia, insulin resistance, hyperlipidemia, oxidative stress causes endothelial damage throughout the vascular system. And in kidney, there is glomerular hyperfiltration, basement membrane thickening, podocyte loss, mesangial expansion that causes albuminuria and progressive glomerular injury. In this, together with systemic vascular damage, burdens heart and causes inflammation, oxidative stress, and promotes atherosclerosis, heart failure, myocardial ischemia, etc. So, early microvascular injury, this suggests, often precedes and contributes to the macrovascular damage of heart or other complications. So we need an early and broad-based protection to that can direct a therapy for diabetes. Reduced nephron mass leads to fluid overload and uremic toxin accumulation that causes remodeling, that accelerates cardiac remodeling. And conversely, heart failure causes decreased renal perfusion, venous congestion, and leads to progression of diabetic kidney disease. So, clinically, we observe that kidney disease and heart failure coexist in a patient of diabetes, and making them high-risk cardiac renal phenotype patient, and increasing hospitalization and mortality and morbidity. What lesson we have learned from the past? Before insulin, treatment was extremely carbohydrate restricted diet. After insulin, longevity and lifespan of diabetic patient increased, but there was still microvascular and macrovascular complication was there. In 1990s, several large clinical trials were published, which shows despite glucose control, there is improvement in microvascular complication, but there is no benefit in macrovascular complication. In fact, strict glycemic control can be detrimental to cardiovascular effect. So early and moderate glucose control is good. Too aggressive control in high-risk patient may be harmful, and glucose control alone is not sufficient for cardiovascular protection. In 2007, Stephen E. Nissen's meta-analysis raised a serious concern about cardiovascular safety of rosiglitazone, after which US FDA imposed a strict criteria for newer diabetic drug to ensure cardiovascular safety. It requires a longer duration of trial with inclusion of high-risk patients like renal impairment and cardiovascular disease. Over several years, many CVOT were conducted with DPP-4, SGLT2, GLP-1 and insulin. Although all these drugs was indicated non-inferiority regarding MACE, but GLP-1 and SGLT2 inhibitor shows unexpected benefit in terms of cardiovascular outcome. IMPA-REG outcome is the first CVOT trial with SGLT2 inhibitor, which shows significant reduction in all-cause mortality, especially reduction in hospitalization for heart failure. This consistent result with all these trials prompted investigation in patient of heart failure with reduced, mild and preserved ejection fraction, which is a common condition in elderly with diabetes and CKD patient. All conclusion of this trial was, regardless of ejection fraction, regardless of glycemic status, they have beneficial effect. Also, they have benefits in terms of kidney events, as shown by Credence, DAPA, CKD, and IMPA kidney trial. They reduce composite risk of composite outcome of in terms of decrease in EGFR, decline of 50%, progression to ESRD, and cause of death from renal cardiovascular causes. Coming to GLP-1 receptor agonist, liraglutide was the first GLP-1 receptor agonist which shows cardiovascular benefit. In SUSTAIN 6, once weekly semaglutide shows improvement in major adverse cardiac event. While in FLOW trial, once weekly semaglutide shows benefit in major kidney event. The mechanism, the summary of this trial shows mechanism of GLP-1 receptor agonist as anti-atherosclerotic, while SGLT2, the effect of SGLT2 is change in hemodynamics and metabolism. Though these two molecules have different mechanism of action, they exert complementary benefits in terms of cardiovascular and renal benefit. Non-steroidal mineralocorticoid receptor antagonist, Finrenone, they add a further layer of protection in terms by reducing fibrosis and inflammation, especially in albumin-uric patient and diabetic kidney disease. So, all these drugs redefines treatment of diabetes by protecting organ. Now, algorithm of diabetes management has changed from priority first approach. First priority is to protect the organ, cardiovascular and kidney risk reduction. If atherosclerotic cardiovascular disease or high risk cardiovascular disease there, prefer SGLT2 or GLP-1 receptor agonist. If heart failure is there and CKD is there, prefer SGLT2 inhibitor. And in case of higher glycemia, you can combine both of them. Weight management is the next goal, which is clearly stated by ADA as a therapeutic goal of diabetes. We have dedicated a very efficacious drug, GLP-1 receptor agonist and dual agonist. And third is achieve glycemic control. New focus is on metabolic liver disease, and it has dedicated pathway already discussed. If atherosclerotic cardiovascular disease and risk of cardiovascular disease there, prefer GLP or SGLT2. If glycemic goal is not achieved, you can combine both of drug. And in heart failure and CKD, start SGLT2. And if goal is not achieved, combine GLP-1 receptor agonist. Weight management, for weight management, we have very high efficacious drug like semaglutide and tirzepatide. And for metabolic liver disease, GLP-1 receptor agonist, dual agonist, pioglitazone is there. Apart from medication, healthy lifestyle behavior is very important. Diabetes self-management, education and support is very important, and social determinant of health is very important. Reassess every 3 to 6 months and evaluate barrier, risk of hypoglycemia, cost, affordability, etc. Apart from these medication, fundamental treatment of blood pressure control with ACE inhibitor or ARB is important. Aggressive management of dyslipidemia is also important. Key shift in diabetes treatment goal in 2026. This is holistic organ protective care. Primary goal is prevention of cardiovascular disease and chronic kidney disease. Medication prioritization with GLP-1 receptor agonist or SGLT2 inhibitor or both. Organ protective therapies should be selected which have multi-organ benefit. Individualized glycemic targets, the previous one-size-fits-all approach is out. Goals are now tailored to the individual's health, status, age, risk of hypoglycemia and comorbidities. For older adults, HbA1c target should be less stringent. Time in range concept has introduced new use CGM data alongside HbA1c. Emphasis on weight management and lifestyle. Lifestyle intervention remains foundational but is more specifically defined. Now, diabetes is recognized as a remission as a goal is now recognized and achievable goal. Specific lifestyle recommendation, wider integration of technology, use of automated insulin delivery. In spite of all these robust data, all clinical evidence, we are suboptimally using these drugs because of cost effect, therapeutic inertia, or difficulty or problem in coordination between different specialties, making our patient more cardiorenal, high-risk cardiorenal phenotype. These are emerging therapies, endothelin A receptor antagonist, and gene therapy, which are in a pipeline. Thank you.
Thank you, Dr. Rajiv, for your illustrative talk. Now, we are at the end of the session. We have 4 speakers in the session, Dr. K Singh sir, Dr. Visul Gupta sir, Dr. Rajiv and Dr. Himalay Jha sir. So we need small comments or questions from the audience if any comment or question is there. 1 or 2 comment or question.
Good morning. So all these speakers have done justice to their talks.
Yes.
And I think with the time constraints, no question should be allowed at this moment. If you get more time in the next speaker,
yes,
then
yes,
we can
yes,
do it. Thank you.
So we conclude the session. Thank you all speakers and chairpersons, co-chairpersons. Thank you, sir.
I would like to request all our speakers and chairpersons to move to the photo booth for felicitation program.
Good morning, all of you. As we move on to the next session, I would like to invite Dr. K Singh, who is also the organizing chairman of this 10th CCDSI conference today. In this session, we have chairpersons as Dr. K Singh, Dr. Rajiv Kumar Jha, and Dr. Syam Narayan. I request the chairpersons to come on the dais. Dr. Rajiv Jha, please come on the dais. I request Dr. K Singh. Sir, introduce.
Straight away, I invite Dr. K Singh to deliver his talk. Obviously, he needs no introduction. He is the man behind this all this show. Go on, K Singh.
Thank you, sir. If you are in Bihar Sharif, you are in the Chhatra Chaya of Dr. Sam Bose. So I request all of you to give a big round of applause to the Bihar Sharif team. And thank you very much for your kind introduction, and Chairperson Rajiv and Dr. K Singh. And first of all, I convey my regards and pranam to Dr. A.N. Rai sir and all the seniors present, Dr. Hemda, Dr. P.K. Sinha and Madhukarji, for giving me opportunity, and Gagan also giving me opportunity to speak on this platform. My topic is slightly different in that respect. Okay, this is assessing adolescent NCD risk behavior in Bihar. Actually, this is a program of API Bihar chapter supported by many of the organizations, including the ICMR and the RMRI. And probably this is the first research program of the API Bihar chapter, and I presented this in the CCDSI platform because I want to adopt this program by the CCDSI also, so that we have a national coverage on this particular topic. The adolescents are the main target organ, and if you can see the data, the root of adult premature mortality, you all know that the NCD is increasing in India by day, and only the 70 million people have diabetic, and it crossed the 101 millions and supposed to be crossed to the 200 millions also. And similarly, the NCD risk is increased from the 37% to the 64 or 65% in just 20 to 30 years of the time. And the basic fundamental of this presentation or this is that the NCD currently account for 74 to 75% of the global death, and up to 70% of the premature adult deaths are directly linked to the health-related behavior adopted during childhood and adolescence. That is the most important factor, is that the 70% of this NCD risk can be minimized if you can give an adaptation to the adult in the adolescent and early childhood program. You all know the dietary habit, the screen time, that is, or the substance abuse, and even the lack of sleep and the lack of sedentary behavior. This all contributed to the very high risk of premature cardiac death and the NCD risk in future. So with this background, we thought this is the principal investigator of this survey program is by the Dr. Modi. He is not present here. R.K. Modi is the past chairman of CCDSI and presently the chairman of API Bihar chapter. So he is the principal investigator and we are all contributor. While there is a threat in global, effective intervention requires to localize data. And suppose the Bihar, the data from the Bihar is very lacking and not specific or not validated. So we thought that we can have our own Bihar data, and that data can be spread out to the other part of the country. So adopting what we seek, that we have to formulate a certain type of tool so that we can communicate to the adolescents, and we have adopted a global standard for the local context. And we accepted the WHO GHSS framework standardized document. That is the project leverage the gold standard WHO gold school-based student health survey program. So we adopted a WHO accepted questionnaire, and we have made it in both the English and Hindi. And the contextualized tool, the resulting in the questionnaire is a specific centralized for the adolescent in the standard of 6th and the 10th standard of the students. And this questionnaire is to be validated by this pilot project. We are in the evolving phase. It just a pilot project is completed 15 days back, and we have a preliminary data of this particular we will discuss in later on. And this transitioning from theory in the field testing, and this is the behavior of the statewide deployment of a rigorous pilot mission was executed to validate the localized tool. So this questionnaire is adopted from the WHO program, and this is to be validated in our pilot project. And the primary object of the pilot was to assess the questionnaires feasibility, clarity, comparison, and overall acceptability in the real world school setting. You know, the demography of the pilot testing is that the two districts of Bihar, that is the Purnia and the Patna, was first selected, and all together is the 580 total students of class 7 to class 9 was screened in this particular project. And the total sample size till that now is the 500 students successfully participated, and we have analyzed the preliminary data. And ensuring this 580 students across the 3 schools, and 3 schools is from the 2 schools selected, one of the government school and one is the private school. And the 2 government school, one has the CBC curriculum and one has the Bihar State Education Board curriculum, and another private student for the CBC curriculum. And the pilot deliberately target the educational environment to ensure wide accessibility. The government school was also selected, and the one to compare the data from the government school to the private school and the in-government school between the CBC curriculum to the Bihar State Education Board curriculum. So high comprehension legally achieved. What we found that the 90% of the participants confirmed the language was appropriate for their age. 90% of the students participants confirmed the language of appropriate of their school, and the student constantly reported that the question was easy to understand, and instruction for the self-administration survey were found to be exceptionally clear. So we have moved forward from one step, that is the 90% of the students clearly say that there is no problem in assessing the linguisticity. So the tool integrates seamlessly into the school environment. The length of questionnaire were deemed acceptable by both the student and the student administrator. And response option provided in the survey were adequate for the student to accurately reflect their behavior. The consent protocol effectively implemented, and the overall process was highly acceptable within the school setting. In this particular project, we have incorporated the volunteers also, and one person from the ICMR RMRI was present at that school, and they have facilitated the whole process during the questionnaire process, and we have clearly taken the consent from the school, and if the students are more than 18 years of the age, then we have taken consent from the student also. So there is a acceptable length, adequate response, and effective consent was taken from the school authority and the person who was involved. So the navigating the sensitive around the substance abuse tracking, we have questionnaire is formulated like how is your dietary habit, what you are taking of substance abuse, how much there is screen timing, how do you understand that whether there is NCD risk, and how can you tackle carry with this particular questionnaire. So the methodology behind the reliability testing, the preliminary assessment was deliberately not conducted during the filing phase. A pilot was acceptably limited in scope except feasibility, clarity, and acceptability. The instrument comprising multiple behavior specific domain like the diet, physical activity, substance abuse, the emotional behavior, sleep pattern, and how they are aware to the NCD risk. So reliability analysis is reserved for the fully powered sample, and the comprehensive reliability test including calculating the Cronbach alpha across key individual domain is planned in the PN study, and this approach ensures the analysis utilization a larger adequately powered data set yielding statistically significant and acceptability result. You can see that there's the main data, the Perege pilot product in the left side, and the right side the main data study. If there is, we had planned that 8 to 10 district we had selected nearly in the having the total target area is 6,800. The pilot testing successfully validated. WHO in Bihar, the tool is currently centralized, and the research team is prepared to transition from pilot validation to full state implementation. You can see in the map of the Bihar, the total 6,800 will be scaling up the adolescent health across 8 districts. The district selected was the Purnia, Katihar, Bhagalpur, Gayaji, Aurangabad, Patna, Muzaffarpur, and Sitamarhi. These are going to be, the temple size will be 6,800, and this sample ensure the study is adequately powered to assess the common and less prevalent nutrition and behavior risk factor. And the district selected randomly, and we will selected the school also randomly. So this is the beauty of this project, and the generating evidence to shape statewide health policy. The validated tool will uncover vital socio-demographic determinants of the NDC risk. Finding will directly inform adolescent-focused health promotion strategy, and data will empower the state stakeholder to integrate NCD prevention into the ongoing initiative like the Rashtriya Kishore Swasthya Kalyan and the Ayushman Bharat School Health and Wellness Program. So adolescent data, health outcome, and the policy making, these are the triangle. And we have preliminary private, this is not the specific data, but you can see that there is in pilot project what we have analyzed in this particular theory, you can see the latent class analysis, healthy lifestyle, 46%, the population are risk behavior, the low vegetarian fruit 32.8%, soft drink and fast food 9.2%, and the high risk behavior is 12%. Nearly 12% of our adolescents are at the risk of developing the NCD in near future. So there is a high risk of dietary and soft tissue focus. The physical inactivity is 28%. The out of 128 school going children are in Bihar is physical inactive. And the fruit intake and vegetable intake 2 serving per day Bihar 44%, and inadequate is around 34%. So psychological interplay, mental health and NCD risk, you can see that there is a mental health literacy gap in 52% in knowledge of help seeking, and the 46% in this comparing to the other people, US. So to conclusion and the take away is that the high prevention risk burden, the 3.2% of the adult and obesity, that is exceeding the national average in urban Bihar. There is a 28% physical inactivity, significantly gender gap, boys are more boys to girls in rural area, and the premature adult death attributable to behavior initiated in adolescence. And if you can compare this, the health awareness to the US, the 46% of the adolescent adolescent students are aware to the NCD risks. So there is a gap of nearly 58% in that area. So immediate scaling of the Rashtriya Kishore Swasthya Kalyan and integrative prophylaxis study are essential to protect the Bihar youth from the impending NCD crisis. So these are the institutions who are participators in our program, the API Bihar and the ICMR RMR, which is an organization of ICMR at Patna, and the on-ground partners are the participating school in Patna and Purnia, and the incredible teacher and students who gave their time to the honest feedbacks. So thank you very much for giving me opportunity, and this is one of the message I want to give at this platform, is that the risk usually starts at the embryo. That is a pre-planning when the patient, when the child, before the child born, there is a planning of, there is a genetic or epigenetic risk, which is may be modifiable or may not be modifiable, but definitely the adolescents, the obesity, the inactivity, the substance abuse, the screen time, and the sleep behavior pattern is definitely a modifiable factor which can decrease the premature death and other NCD risk in future if you can target this particular group of populations. So with these words, thank you once again. Okay, sir. Yes, sir. Yes, sir. Yes. Yes.
At the very outset, let me congratulate and thank you, Dr. B. K. Singh, for selecting such a wonderful topic. This is probably the topic of the day, and you have meticulously elaborated all the points and why this is important. Thank you very much.
Sir, I must comment and compliment your initiative. That is what India needs today. And I request you to please share the things with Punjab API. I am Secretary of Punjab API and CCDSI Punjab chapter. We will like to contribute to generation of data if you permit us, or if we can independently use your validated performa for Punjab also?
We are in the ongoing stage. First, we have to analyze the whole data, 6,800. Let the things should be completed. Then we will incorporate the whole the country, national level, and definitely we will share our data to you also.
Well done. Next, आपको प्लेटफॉर्म मिलेगा अभी. प्लेटफॉर्म मिलेगा, 1 मिनट बोल दीजिएगा.
No, that's a wonderful achievement as far as Dr. B.K. Singh's presentation is concerned and API and ICMR activities are concerned. I must tell you that this project was discussed with me and Dr. Modi when I was the chairman, and unfortunately because of my personal issues I was just out of this project. So I'm very happy to see these things coming into the light of the academic part. Now, you must be knowing that I fought elections, the last general elections, and things which came to me up front needs to be added to this project as well. Now, what I mean to say is that majority of students, adolescents are going to school. But we have a good number of adolescents who are out of the school. These out of the school students are engulfed in all sorts of dry addictions that we have in our society. So what we call in common parlance, what Punjab has already seen, the Urta Punjab. So we are seeing, Sukha Nasha. So we need to incorporate this in future. This project is ongoing. So we need to incorporate the out of school adolescents to seek their behavior and what are the reasons of their going into that addiction cascade. So that is my just input.
Yes, definitely. I acknowledge when the Dr. A.K. Das was the chairman, and this project was initiated by Dr. R.K. Modi, and there is a very big discussion on that, and there is a UN cry how to get this ethical clearance from and fortunately we got the clearance from the RMRI, and Dr. Amit is also the part of this program of the Muzaffarpur, what the district was selected. And definitely we, first of all, this is the one project, and there is a continuation of the all project is there. The other person, how we can achieve this target to the other people who are not going to school. So how we can take the other NGOs, the non-government organization, or some political party or some party to have achieved this the group, so that we can screen that particular group. There is some ethical problem also. So how can you take the consent, or there are many problems. So first of all, you have selected those schools. Yes, sir.
Sir, so this is what
that's very true. You have picked up the schools, and the point raised was also very valid. We have got very comprehensive network pan-India, and that is Anganwadi. And I think that's what I'm saying.
For infants.
The gap is 6th class and before. And I can tell you the Anganwadi workers are so dedicated, and they could give you a lot of inputs on the anthropometric data, child behavior, parents' behavior. And I'm just throwing up an idea that if this could be incorporated, you will get a very early kickoff. That what exactly, and this is pan-India, and wonderful field operatives are there. You can go to the parents also and know how many parents are tested for diabetes and metabolic syndromes and other things. And that could also be incorporated. And that will make the data very, very valid.
Excellent point, sir. Excellent point, and we will take and definitely incorporate in when we will first finish our first project, and then we will incorporate other projects.
Sir, so, this is one topic which can continue and go on with hours together. So due to paucity of time and discipline, I close this
Thank you,
your
sir.
talk here. Thank you very much.
Thank you, sir.
And straight away call on the second learned speaker, the dynamic one. He again needs no introduction. You can see his smiling face. I will telling us something new and updated. Amit, please.
Thank you, sir. If you are visiting Bihar and if you're not visiting Rajgir, your visit to Bihar is unsuccessful. And if you're visiting Rajgir, if you do not meet Dr. Shyam Narayan, your visit to Rajgir is incomplete. Thank you, sir. Respected chairpersons and dignitaries in this August gathering, after the wonderful research project regarding the NCD behavior pattern in the adolescents, I'm going to throw some light, rather newer lights, on established research. So what is already in textbooks and what is already on paper. On a very small aspect of diabetes management, but rather it has become very important of late. So management of diabetes in liver disease. So you have two partners coming together, the diabetes conundrum and the liver story. Now let me begin this presentation with a simple case, a very often seen case in your OPDs. A 58-year-old male presents in your chamber with recurrent episodes of dizziness and sweating, especially at night, early morning, 3 a.m. Now he is a diabetic since last 10 years and he is already on medications which are 1 gram of metformin BD and 4 milligram of glimepiride. On the workup, his labs showed a low albumin level, a slightly raised bilirubin, mild ascites, creat and renal functions normal, and ultrasound shows a coarse liver with dilated portal veins, ascites and splenomegaly, and ECG is not there, ECG is normal. His HbA1c interestingly is 6.2, which is down from 7.8% 6 months back. So this is a patient of hypoglycemia. So possibly we are dealing with cirrhosis of liver with hypoglycemia, and as is well understood, the culprit would be sulfonylurea. As hepatic functions decline, the half-life of this secretagogues increases significantly. So what would you do? You will stop glimepiride, reduce metformin as per the child PUG B status, and initiate a safe, hepatic safe drug. And if possible, you would monitor a 14-day CGM to visualize the nocturnal hypoglycemic values. Now the trap in this case was the HbA1c trap, because HbA1c came down from 7.8 to 6.2. So this is not a very good sign, rather it's a red flag, because in cirrhosis of liver, a dropping HbA1c will often reflect a decreased RBC lifespan or a worsening hypersplenism, masking frequent hypoglycemia. So in a cirrhotic patient, if you are seeing a rapid drop of HbA1c, you need to be very cautious, because that is not indicating a good control, rather that is indicating a rapidly deteriorating liver function. Tragedies. So with this case, let the flow of the talk go on. Tragedies do not come alone, as is well said, and with the advent of diabetes and the world getting into the pandemic of diabetes, the liver diseases are not lagging behind. So the tragedies are hand in glove, and we all know that there are different types of liver diseases, and you can classify it by acute liver disease, chronic liver disease, by etiology, infectious, autoimmune, by pathology, steatosis, hepatitis, classification by anatomical site. So these are the different diseases, types of liver diseases that you are going to have. And we, as far as diabetes is concerned, there is a bidirectional interaction or relationship between diabetes and liver cirrhosis. And hereditary type 2 diabetes is another entity which is caused because of cirrhosis of liver. And diabetes, and we all know that this is the common soil hypothesis based on the insulin resistance and chronic low-grade inflammation. The common soil not only generates type 2 diabetes, the cardiovascular disease, the obesity, but it also affects liver. And this common soil hypothesis is causing cirrhosis of liver, what we now know as MASLD or MSLD, and then it goes into cirrhosis of liver. So this is the, and if the patient is having cirrhosis without diabetes, this cirrhosis will lead to impaired hepatic clearance and shunting. It will cause hyperinsulinemia, systemic insulin resistance, and what I was just talking about, hepatogenous diabetes. So diabetes will lead to progressive decline in liver functions, and our established cirrhosis will lead to of late hepatogenous diabetes. Now what is hepatogenous diabetes? I'll just let you know. So if we just see the epidemiology, up to 30 to 50% of patients with liver disease, liver cirrhosis, have overt diabetes, and 80% of them have glucose intolerance. Diabetes is associated with increased risk of hepatic encephalopathy, portal hypertension, and mortality in cirrhotic patients. And what I was just referring to was hepatogenous diabetes, which is slightly different from type 2 diabetes, because hepatogenous diabetes is subclinical and characterized only by high postprandial glucose and many times normal fasting glucose. These are usually less frequently associated with microvascular complications like retinopathy. So this is a different entity, cirrhosis causing diabetes, and diabetes itself causing cirrhosis. So these are bidirectional relationship. And if you have a cirrhosis and if you have diabetes going together, diabetes has a negative impact on the survival of cirrhotic patients. And why is this? Because diabetic patients with cirrhosis live short, because their death is because mainly of the liver related causes. They are also associated with cardiovascular complications. Coexistence of diabetes and cirrhosis will lead to declining immunocompetence, leading to increased risk of infections, and most common is spontaneous bacterial peritonitis. And with these infections, the patients may go on to liver failure and hepatorenal syndrome. So patients with diabetes and cirrhosis live short, they have shorter lifespan, and patients who are only diabetics go on to develop pre-diabetes, MSLD, and other complications, as already told you. And let me just take this opportunity to define the various conundrum of liver diseases associated with diabetes, and what we label it as steatotic liver disease, which is an umbrella term encompassing different disease subcategories characterized predominantly by hepatic macrovascular steatosis. Now the latest term is metabolic dysfunction associated steatotic liver disease, which is called MASLD. Now presence of steatotic liver disease with at least one metabolic risk factor, that is overweight or obesity or waist circumference, pre-diabetes or type 2 diabetes, elevated triglycerides or low HDL, and either no alcohol consumption or consumption in amounts not likely to directly lead to liver outcomes, which is less than 30 grams per male. Metabolic dysfunction associated steatotic liver disease, MASL, is steatosis with either no or minimal lobular inflammation and without ballooning and alcohol consumption below the thresholds. And MASH is presence of steatohepatitis and at least one metabolic risk factor. And at risk MASH is steatohepatitis and
fibrosis score of more than F2, the people who are at risk of future cirrhosis. So these are the different terminologies which you must be aware of. Because this is an update, I thought I would just include this. So the story starts from normal liver to MASL to MASH to fibrosis to cirrhosis and liver failure. So this is the overall story of liver. And how do we monitor? So to monitor, we have new things coming up, and these are the APRI scoring. APRI includes the AST by AST of the upper normal limit divided by platelet counts into 100. And we have FIB4 score, which again uses the age, AST, ALT and platelet counts. Normal, and then we have the FibroScan, which uses the shear wave generated by vibration through tissue shears. This is the FibroScan. So these are the latest in non-invasive tests which are frequently being used in assessment of diabetic patients with liver disease. And the algorithm, I'll just show you the algorithm. But before that, let me tell you another score, which is the ELF score, which is the Enhanced Liver Fibrosis Test, ELF test. This is another non-invasive blood test that measures 3 direct markers of fibrosis: the hyaluronic acid, the pro-collagen 3 amino terminal peptide, and the tissue inhibitor of matrix metalloproteinase. And the ELF score is this. And I'm sure you would not like to remember this formula. What you would like to remember is the slide on the right part of this. So the score, if it is less than 7.7, which is none to mild, and if it is more than 11.3, it's cirrhosis. Moderate 7.7 to 9.8. So the figure which you must remember in ELF is 9.8. So 9.8 is the cutoff of your red flags. So if it is more than 9.8, these patients are at high risk of significant fibrosis. So you need to upscale your treatment with drug modifications, and I'll just be dealing to the pharmacotherapy. Now this is how we are guided by the ADA. The 2025 guidelines say that irrespective of status of the blood sugar, if the patient is type 2 or pre-diabetes or obesity with more than one cardiovascular risk factor, rule out secondary causes of ALT if you are seeing an ALT, and do a FIB4 scale. If the FIB4 is greater than 1.3, if the patient is at risk of future cirrhosis, go for a liver shear testing, and this is which is the FibroScan, and this is how we go. So irrespective of the blood sugar status, if the patient is obese, or even if the patient is pre-diabetes, you need to look for your patient's liver health now. Small nuances in monitoring as far as sugar is concerned. I already depicted in my first slide that HbA1c typically underestimates glycemia and cirrhosis. Last night, Dr. Sudhir highlighted on this point. I am going to take slightly more time because the main part is still left. Nuances is HbA1c is not going to give you the real picture. So you need to be using other things to assess the glycemic targets. Fructosamine and glycated albumin may be more accurate, but these are not frequently available. And moreover, in cirrhotic patients, hypoalbuminemia again can give you false figures. The gold standard is continuous glucose monitoring. So it is available across the country now. It's not cheap. It's not very costly. You need to be technically sound to assess. It's not very technological demanding test also. A CGM is the gold standard for patients of type 2 diabetes with cirrhosis. And for targets in advanced cirrhosis, the HbA1c is 7.5 to 8, and the TIR should be less than 50%. So targets are also fixed for slightly relaxed. So these are small nuances. And if you are going to assess the cirrhotic part only, the liver part only, you have the Child-Pugh-Turcot scoring, which uses serum albumin, serum bilirubin, prothrombin time, ascites, and hepatic encephalopathy, and you give points. Class A is points between 5 to 6, Class B is 7 to 9, and Class C is more than 10. So if the patient is having more than 10 Child-Pugh-Turgot scoring, you need to stop most of your medicines. MELD scoring is another way of assessing the liver health, and MELD score is basically done for candidature of liver transplantation. So non-pharmacological management includes diet, exercise and weight loss. Remember, weight loss needs to be very, very cautious. A small point of alcohol, assess intake at every visit, recommended minimizing alcohol intake, behavioral health and other aspects have to be taken care of. Now, there have been multiple studies on pharmacological management of type 2 diabetes. Almost all drugs have been tested for use in liver disease, and these are the small table which incorporates the latest drugs starting from GLP-1 analog semaglutide to GLP-GIP tirzepatide and pioglitazone. So these are the top 3 drugs are of beneficial use in cirrhotic patients. SGLT2 inhibitors are potential benefits. Metformin basically is neutral, but it has some advantages in liver management. DPP-4 is neutral. Insulin has a potential benefit. Sulfonylureas are neutral with questionable evidences in use in steatohepatitis, fibrosis and reduction of fibrosis. So metformin generally safe in compensated case. You have to use it cautiously if the risk of lactic acidosis is there. Pioglitazone is effective for MASLD and MASH, but you need to monitor for fluid retention. SGLT2 emerging data suggest benefit in MSLD, but requires monitoring for renal functions. Sulfonylureas are generally avoided due to the high risk of prolonged hypoglycemia, as was the case. Insulin is the gold standard. It's the safest and most effective option for patients with advanced or decompensated liver disease. You need to adjust requirements because the requirements often fluctuate and dosages must be closely monitored. There is the insulin paradox where because of despite a normal or low pancreatic insulin production, impaired hepatic degradation results in elevated systemic insulin levels, exacerbating systemic insulin resistance and paradoxically increasing hypoglycemia risk with exogenous. So this is the insulin paradox because of the poor hepatic clearance, and hence you need to be careful about this insulin paradox also. Now, acarbose liver toxicity is low, but you need to be careful in stage C. Metformin induces NAFLD remissions, has effective on hepatic fibrosis, cirrhosis and hepatocellular carcinoma and drug-induced liver injuries, but you need to be very careful in not using metformin in Child-Pugh C stage. Child-Pugh A, no dose adjustments. Child-Pugh B, reduced dose by 50%, maximum 1 gram per day, and you need to be very closely watching for lactic acidosis. So metformin, as I told you, is actually associated with reduced risk of hepatocellular carcinomas. I will just skip these. Linagliptin is one DPP-4 inhibitors which are particularly useful in liver and kidney disease, so no dose adjustment is required. SGLT2 inhibitors should be used with caution, especially in patients who are on diuretics, because they may potentiate acute kidney injury. Thiazolidine dienes are drugs which are approved in F1, F0 and F2 to F3 MASLDs. So we can use this. The drugs which are of the highest potential are GLP-1 receptor agonists, which have strong HbA1c reducing potential. So they are very well helpful in managing diabetes, strong weight losing potential. They are very well helpful in managing obesity, and they are of utmost benefits in the liver disease. They are magic pills rather, and 29 to 30% reduction in major adverse liver outcomes, specifically hepatic decompensation has seen. So it will prevent hepatic decompensation, lower the risk of hepatocellular carcinoma and liver transplantation, and significant reduction in all-cause mortality. The ESSENCE trial is looking into semaglutide's potential in liver disease. The early studies have shown that it has beneficial advantage in resolution of steatohepatitis, enhancing the liver fibrosis score, enhancing the liver stiffness, decreasing the liver stiffness, and decreasing the mean change in ALT. So all parameters are addressed in this by semaglutide in the ESSENCE trial. Well, tirzepatide is not lagging behind. It's also one of the strongest molecule, and the head-to-head trial has not been seen, but they have, in some small studies, they have been found to decrease steatohepatitis, decrease the AST-ALT, decrease fibrosis. And the study which is being done for tirzepatide, which is looking into liver disease, is the Synergy NASH trial, and it's the phase 2 trial. There are other agents also, survodutide, retatrutide, and lanifibranor, which are drugs which are going to help in the management of type 2 diabetes.
You should conclude.
Type 2 diabetes. So management algorithm, this is the final slide. Child PUG, compensated, standard type 2 diabetes apply. Metformin remains first line. Child PUG B, dose reduction for most orals. You should prioritize GLP-1 RAs or DPP-4 inhibitors. Child PUG C, which is decompensated, discontinue most oral agents. Transition to cautious, low-dose insulin regimens with frequent monitoring. This is the final slide. Thank you very much. Not to go in details. Thank you very much.
We should conclude. Thank you.
Thank you, sir.
Things were very good, but you're trying to get all the things.
Two chapters, sir.
Next time. So, next speaker is? Dr. Mahendra Pratap. May I request Dr. Mahendra Pratap to talk on when type 2 diabetes is the precision diagnostic and personalized management of atypical diabetes forms. 21st type.
Thank you, Chairperson, sir, for inviting me to talk on this topic. First of all, I thank the organizing committee of CCDSI 2026 Bihar and Jharkhand chapter for giving me this opportunity to talk on this topic here. My topic is MODI, LADA and beyond when type 2 isn't type 2 diabetes. We in our clinical practice regularly classify the patients generally as type 1 or type 2 diabetes. But beyond type 1 and type 2 classification, there are many other type of diabetes which occur in patients. So this classification of type 1 and type 2, which we have dichotomized, is actually a paradox, because we also have type 3C diabetes and other causes of diabetes such as monogenic diabetes, mitochondrial diabetes, gestational diabetes. So a significant cohort which is labeled as type 2 diabetes actually presents with atypical features and distinct pathophysiologies. And we can see here that almost 1 to 12% of the patient which we have diagnosed as type 2 diabetes are actually not type 2 diabetes patients. So coming to monogenic defects of beta cell function, which causes the maturity onset diabetes of the young, and it is also known as MODI, and it represents a heterogeneous group of monogenic disorders which is actually characterized by a primary defect in the pancreatic beta cell function. Unlike polygenic type 2 diabetes, MODY is caused by a single gene mutation. Diagnosis is critical as it shifts management from a generic approach to a precise genetically defined strategy, often enabling the cessation of insulin in favor of oral agents. The key characteristics of MODY patients are, it is basically autosomal dominant, so genetic in nature, 50% of risk. The affected parent, if he is heterozygous and the second parent is unaffected, the unaffected and affected child both have the probability of 50% occurrence of MODY. The common causative genes in MODY are the glucokinase gene GCK, then hepatocyte nuclear factor 1 alpha, then HNF4A and HNF1B. Then the genetic heterogeneity of different types of MODY. We can see here, first is the GCK gene, which is generally MODY2, and it has the highest prevalence of almost 30 to, it has the prevalence of 30 to 50%. And here the pathophysiology is that the glucokinase sensor defect rises glucose set point for insulin secretion. So the clinical feature of these patients, these patients are stable. They have mild fasting hyperglycemia from birth, and they present with minimal symptoms. So the management is not to give drugs here. Basic lifestyle management, if done, is sufficient for these patients. Second class is HNF1A, which has MODY3, 30 to 65% of the patients, and these have HNF1 alpha transcription factor defect and impairs beta cell development and function. The young onset people, these are almost less than 25 years of age or less than 30 years of age. There is progressive hyperglycemia and risk of complications. The management is still the very low dose of sulfonylureas, and these are very highly sensitive drugs and can control this type of patients. Then next one is HNF4A gene, which has 5 to 10% of total patients of MODY, and this transcription factor has dysfunction whose mechanism is similar to the MODY3 type. Here the onset is slightly earlier and there is progressive failure of beta cell function. Here also low dose sulfonylureas are indicated. The last one is HNF1B, which is MODY5, and the prevalence of patients is less than 5%. Here the defect causes pancreatic hypoplasia and structural abnormalities. These patients present with diabetes along with renal cyst and genitourinary abnormalities, and typically here insulin therapy is required in these patients. Now coming to the diagnostic approach to MODY. We have to first clinically create a clinical suspicion about the patient. If a young patient comes to us with diabetes, he is very lean and thin, and after taking the proper history of those patients, if we get a family history of 1 to 2 generations of diabetes, then we should think of MODY in these patients. Before proceeding towards MODY, we have to exclude the type 1 diabetes, just the GAD and pancreatic autoantibodies like IA2 and ZNT8, and then we also have various calculators to identify the risk of MODY, which are based upon the age, BMI, HbA1c, and the history of the patients. The last approach in this is genetic testing and sequencing of the genetic sequencing panel, which can be done if suspected. So the broadened criteria for diagnosis of MODY patients may be covered, like they should have onset typically less than 35 years of age, and they should have a multi-generational family history. There should be absence of pancreatic autoantibodies, and at presentation they will be non-ketotic in nature. They have C-peptide levels preserved for less than or more than 3 years. Now coming to the latent autoimmune diabetes in adults, also called as LADA, and this has blurring traditional boundaries between type 1 and type 2. As type 1 is very fulminant in nature, we can see in this graph the red one is type 1 diabetes, where the decline in the secretion of the insulin is very fast, and in type 2 diabetes it is very progressive. But in case of LADA, it is faster than type 1 diabetes, and the patient requires insulin earlier than type 2 diabetes patients. So this is a slow motion type of destruction of pancreatic beta cells, and because of its adult onset and initial response to the oral hypoglycemic agents, it is frequently misdiagnosed as type 2 diabetes and leading to delays in appropriate insulin therapy. Now coming to the pathophysiology of LADA and clinical presentation, it is characterized by autoimmune mediated destruction of pancreatic beta cells, which is similar to type 1. The key distinction is slower, more indolent progression of the autoimmunity. This slow motion destructions allows for a period of residual beta cell function, often mimicking type 2 diabetes initially. Here The age of, coming to the clinical features, the age of onset typically is less than 30 years of age in classical type 1 diabetes, whereas in LADA it is almost more than 30 years to 35 years of age, whereas in type 2 diabetes it is more than 40 years of age. The BMI in classic type 1 diabetes, the patient will be lean or normal, whereas in LADA the patient may be lean, normal or overweight. Whereas in type 2 diabetes, obesity is a classical criteria. In case of autoantibodies, the type 1 patients may have GAD positive. LADA also have GAD positive patients, and type 2 diabetes does not possess the pancreatic autoantibody positivity. When we come to the dependence on the insulin, there is immediate dependence on insulin in the classic type 1 type, whereas it is delayed. It may be less than 6 months to it goes to years, whereas in type 2 diabetes is a very long term, and it is a there is variability or late requirement of insulin. So the Immunology of Diabetes Society criteria for early insulin therapy preserve the beta cell function. First, the age of onset more than 30 years. It distinguishes from classic juvenile type 1 diabetes. Second point is the positive islet autoantibodies, the presence of GAD, which is most common in LADA. And third is the insulin independence for more than 6 months at the time of diagnosis. So the goal is to preserve the beta cell function. So primary objective is to halt the autoimmune destruction and preserve the residual insulin secretion capacity. So we have to go for early insulin initiation. Paradoxically, early insulin therapy reduces the glucotoxicity and beta cell exhaustion, potentially extending the period of endogenous insulin production. So here we have to take caution with start of the oral hypoglycemic agents like sulfonylureas, which may accelerate the beta cell burnout, and these should generally be avoided once LADA is confirmed. Now, apart from these two types, MODY and LADA, there are also pancreatogenic diabetes, which is type 3C diabetes, neonatal diabetes, and PCOS associated diabetes. We will come to all these one by one. So type 3C diabetes, or the diabetes of pancreatogenic origin. It is an exocrine disease leading to endocrine failure. The common etiologies are chronic pancreatitis, pancreatic cancer, cystic fibrosis, hemochromatosis. The pathophysiology behind is the concurrent destruction of islet cells, that is the endocrine part, and the acinar cells, the exocrine part of the pancreas. How we will diagnose these patients? These patients, when present with diabetes, will also have a history of pancreatic disease. They will have history of steatoria, malabsorption, and history of weight loss. And it can be confirmed by the pathological imaging like CT scan of the abdomen or MRI. The management requires dual therapy. The approach should be to cover endocrine as well as the exocrine part. For the endocrine management, insulin therapy is typically required, but there is high risk of hypoglycemia due to loss of glucagon, as alpha cells are also destroyed. In exocrine management, pancreatic enzyme replacement therapy or PERT is given to correct the malabsorption. So if we have brittle diabetes with digestive symptom, we should suspect of type 3C diabetes in those patients. Now coming to the neonatal diabetes and monogenic forms. The genetic testing basically reveals the treatable causes in adults. The neonatal diabetes typically presents within the first 6 months of life. However, milder mutations in the same genes can present later in adulthood, leading to misclassification as type 2 diabetes in these patients. Recognizing these forms is critical because the underlying defect, often in the potassium ATP channel, renders the condition highly responsive to sulfonylurea, allowing patients to transition off insulin. So the key causative agents are defects in the KCNJ11 gene and ABCC8 genes. The mutation of these genes impair the ATP sensitive potassium channel, preventing insulin secretion. Sulfonylureas close these channels, restoring the secretion. So just giving sulfonylurea might be sufficient in these patients. So the standard therapy is the part which we can give just by giving sulfonylurea to these patients. Now, coming to diabetes and polycystic ovarian syndrome, the complex pathophysiology beyond simple insulin resistance. The PCOS is strongly associated with insulin resistance, yet a distinct subset of patients exhibits a more complex pathophysiology. These individuals face a double hit of peripheral resistance combined with a primary defect in insulin secretion. Not all PCOS patients associated diabetes is type 2. There should be careful evaluation, and it is required to distinguish primary beta cell defects from secondary exhaustion. Management consideration, we should give insulin sensitizers like metformin, thiazolidinediones, and we have to give advices about lifestyle interventions like weight loss, exercise. We have to maintain reproductive health integration, and we have also to screen for metabolic abnormalities. The management depend upon the pathology, where peripheral insulin resistance, primary beta cell dysfunction, and hormonal dysregulation persists. So now, diagnosing the other types of diabetes apart from type 1 and type 2. If MODY is suspected, it will be young age of onset, less than 35 years. There will be a strong multi-generational family history, more than 2 generations. The patient may be non-obese, absence of metabolic syndrome features, and negative pancreatic autoantibodies. In LADA, we will suspect if it is adult onset, more than 30 years of age, the patient will be lean or normal weight phenotype, rapid progression to insulin requirement, inadequate response to oral agents, and personal or family history of other autoimmune diseases. If we suspect of type 3C or pancreatogenic, there will be history of pancreatic disease, evidence of exocrine insufficiency, and there should be a pancreatic structural abnormality causing brittle diabetes. If the patient is suspect of PCOS associated diabetes, the woman will be of reproductive age, there will be clinical or biochemical hyperandrogenism, polycystic ovarian morphology will be found on imaging, there will be history of irregular menstruation or anovulation, and the complex metabolic phenotype presenting with insulin resistance plus beta cell defect. Sir, I will take 1 more minute. Okay, sir, thank you. So, how to approach these patients? First, we have to do the phenotypic and serological evaluation by evaluating the pancreatic autoantibodies, measuring the C-peptide levels and the metabolic profile of the patient. And secondly, we will have to go for molecular genetic confirmation by various prediction models, targeted NGS panel test, and family segregation. So, clinical implications. If we have the diagnosis of HNF1A MODY, so traditional approach is to go for insulin or multiple oral agents, but precise approach will be just low dose sulfonyl urea monotherapy, and it gives excellent glycemic control and patient have improved quality of life. If we suspect of LADA, earlier it was oral agents which was given until failure, but precise approach will be early insulin initiation, which preserves the beta cell function, and prevention of metabolic decompensation is also achieved. In type 3C, earlier a standard diabetes therapy was given. The new approach is insulin plus pancreatic enzyme replacement, which addresses the dual endocrine and exocrine defects at the time and improves the nutritional status of the patient. And if it is PCOS associated, then instead of a standard type 2 approach, we give insulin sensitizer along with reproductive management, which is a comprehensive metabolic reproductive health approach. So, fitting one size to all is not proper in these cases, and precision approach will lead to reduction of long-term complications. Thank you.
Thank you, Dr. Mehnder. And now we close the session.
Thank you.
Thank you, speakers and chairpersons. Moving ahead, we will be starting the third session of the day. And to chair this session, I would request Dr. Hemshankar Sharma sir, Dr. Visul Gupta sir, and Dr. Himalaya Jha to come up on the dais. I would once again request all the speakers to maintain the timeline and to finish up within the stipulated time, because we are already running a bit late. Thank you.
Good morning to everyone. At the outset, I will have two lucrative offers I will tell you. If you finish your talk within 15 minutes, then thank you very much. If you finish your talk 2 minutes earlier, I will ask one question, allow one question to the House. If you finish it within 12 minutes, I will just give you 2 questions to the House. Okay? But you have the questionnaire, should not discuss the topics. You should straightaway point the questions. Right? And the answers will be delivered. But it is up to the speaker. Okay, thank you. Over to my sir, mentor, CCDSI National President, Founder President, who has shaped the lives of many like us. Thank you, sir. Over to Professor.
Thank you, Chairperson. Dear August audience, I am not going to take much time. I am going to present interesting clinical cases. And this is here the full participation must. So we both are, the speaker as well as the audience will equally participate. My first case is middle-aged lady presenting with severe chest pain and feature of shock since 2 hours. What is the diagnosis and what is the most likely culprit vessel? Just look after this. This is the ECG. Hello. Hello. उसका जो पैसा है उसको माफ कर दो आप.
Yeah, anyone can raise the hand and answer. Yes, please, Sudhir. Just MI with? Okay, next. Hey, Sudhir has raised the hand. Can you elaborate into that? Everybody is looking 2-3 AVF. Okay, over to the speaker. Anything else you would like to add? Pardon?
Just see the history. Patient is having shock. So, inferior MI with shock. What else is there? Yes. So, whenever the patient, this is an acute inferior STEMI, but when the patient has acute inferior STEMI presenting with a shock, always go for right ventricular. And the right changes in the right ventricular leads are very short-living. So, you must do. They disappear in 8 to 24 hours, maximum 24 hours. So, we did the right side chest lead. And you can see the ST elevation. So, this is important because you see what happened, right ventricular patient with shock, especially with the right when they always search for right ventricular infarction. And if you do not manage, these patients are going to die. This is a very important case. So, the lesson is that if any patient present with acute inferior STEMI with the feature of shock, always do right ventricular lead. We do not do right ventricular, but in these cases, we must do right ventricular lead.
Sir, one thing more, sir. Look at V1 and V2. So, that also suggests right side.
Yes, that is there.
So, if in VA wall MI with V1 and V2 changes and shock, this is one diagnosis.
Sir, one thing I would like to share. ST elevation in lead 3 is bigger than lead 2. It is more supportive of RV involvement.
You see, ST elevation in lead 2 suggests circumflex, lead 3 suggests it is the right coronary artery. That's all. But it does not suggest that there is a right ventricular infarction. Changes in V1, V2 and the right ventricular leads. That is very important. Why it is not moving? Oh. So, this is there. Now, my second case, I am going. This is a 50 years old diabetic female presented with a chest pain and dyspnea for 24 hours. Patient had history of bee sting 6 hours prior to the chest pain. Her initial vital signs were temperature 98 degree Fahrenheit, low BP 90 by 60, pulse 90 per minute, and this is the ECG. What do you find? This is a classical VT. So, a patient presenting with a chest pain and classical VT, most likely this patient has acute coronary syndrome presenting in the VT, and the patient was given DC shock. Oh, sorry. It has revealed my diagnosis. This is a case. So, VT and acute coronary syndrome with VT, and there is history of bee sting. Is there any correlation? I have presented this case because of bee sting.
Myocarditis is one very important aspect.
Myocarditis one, but वही आ गया ना उसको. My diagnosis was revealed. I think, you see what happened? Bee stings and allergic reaction can cause coronary vasospasm and coronary artery disease. And they can present as either due to vasospasm. There are 3 types. I will just go in detail later on. So this patient had this condition: acute endoscopy, post-bee sting, allergic acute coronary syndrome, which is known as Coney syndrome. Have you heard the name? Coney syndrome. Oh, yes. That was there. London mein. This was the Coney syndrome. Coney syndrome. This is a very, so this is, I present this case. These are the features. Findings are suggestive of acute coronary syndrome. This is post-DC shock. You can see. I am going fast. Allergic coronary syndrome, you can see. This is a type. Allergic coronary syndrome can present 3 types. This is there. So, final diagnosis, post-bee sting. This is a rare, but that's why I am presenting this case. This is not so common. Bee sting. And one mind does not know, the eye cannot see. अगर हम इसको जानते नहीं तो हमेशा ये नहीं कर. I have presented this case, but I am several times, but I am presenting again. 45, because audience may be new. 45 years old female presented to the emergency department with recurrent seizures since one day. She was diagnosed to have seizures disorder since 6 years and was sodium valproate 300 mg BD, but still not being controlled. These were her clinical findings. This is the ECG. What do you find? Prolonged QT. With T wave slightly prolonged QT. You see, any condition, there are 2 prolonged QT with muscle weakness suggests hypokalemia. And prolonged QT with convulsions suggests what? Hypocalcemia. So basically this patient had hypocalcemia, that was the reason for the recurrent seizure. And chronic hypocalcemia can occur in which condition? Hypoparathyroidism. Eventually we could diagnose that this patient has got primary hypoparathyroidism just because of the ECG. This is why I am saying the significance of the ECG. ECG is not absolute. The significance of ECG is still there. So with this just one ECG, you could see that this patient might have prolonged hypocalcemia. And characteristics of hypoparathyroidism is bilateral basal ganglia calcification, which was there in CT scan. I am going fast. You can see serum parathyroid hormone was low. I am not going because time is there. I have present 2 more cases. So this is the case of primary parathyroid. We did the parathyroid was low and calcium was low, and this is the confirmation about parathyroid hormone. So how now see the management? Patient did not require. Patient was given acute phase. We gave the calcium, and later on just vitamin D3 60,000 once a week. After 3 months, she required no antiepileptic drugs. She was free of seizure. So this is the importance of diagnosis. हाँ वो तो है, वो तो आ गया, लेकिन आप अगर नहीं अवेलेबल है, जो 2 पेशेंट हु कैन नॉट अफोर्ड, जस्ट सी आप देंगे, निगम पीछे तो है ही है, क्योंकि नेचुरली स्पेसिफिक है, बिकॉज देयर इज अ डिफिशिएंसी, आपको रिप्लेसमेंट थेरेपी करना है, लेकिन अगर पेशेंट नहीं अफोर्ड कर सकता, रूरल पेशेंट कहाँ से अफोर्ड करेगा, देन विटामिन D3. And this patient was, he said that he could not afford, just on vitamin D3, the seizure was controlled. I'll go fast now because our time. I've got several cases, but I'm not going. This is a case. Middle-aged lady pregnant with palpitations. What is this? Fast, very fast tachycardia with wide coronary complex and irregularity, so-called FBI. Fast, broad, irregular tachycardia. FBI. FBI characteristic of what? It is atrial fibrillation in a case of pre-excited syndrome. This is very important, occurring in the pre-excitation syndrome. And what post-DC shock showed? The differential diagnosis is there. I am going fast because the time is not there. So this is just this is differential diagnosis, and just after DC shock, you can see WPW syndrome. So fast, broad, irregular tachycardia, pre-excited syndrome. So you have to manage it.
Where is the rhythm in the last slot?
You want to go last slide?
No, no, the last line that doesn't suggest atrial fibrillation.
No, ये नहीं atrial fibrillation, ये तो WPW syndrome. Post DC shock.
अच्छा.
हाँ, आप इसको देखिए. नीचे rhythm. Why? वो तो sinus rhythm है, WPW syndrome. वो तो post DC shock है. ये है atrial fibrillation. FBI, fast, broad, irregular. The conduction is through accessory path. Atrial fibrillation, the focus is in atrium. Normally, if it comes to AV node, there is checkpoint. But it comes to accessory node, it crosses all. And that's why the rate is very fast. Differential diagnosis is VT, polymorphic VT. But, so, this is the post-DC shock. Post-DC shock, WPW syndrome. Next. This I have presented also, but I am presenting it. 35-year-old diabetic male was admitted with the history of weakness and giddiness since morning. Pulse 40 per minute. ECG is given below. It's characteristic. What is the ECG finding? What is the ECG? Very characteristic. Hyperkalemia. All the three features: absence, tall T wave, absence of P wave and bradycardia. Classical hyperkalemia. This you can see. Patient was managed conservatively, but patient did not improve. Advised dialysis. Initially, patient relatively improved. Patient condition deteriorated, and then the patient next ECG is this. What is this? I have already told several times. What is this? A patient of hyperkalemia presents this type of VT. What we call it? Sine wave. Sine wave. It is due to merger of wide coronary complex and widening T wave, Sine wave. And if you do not do the dialysis at this, it says patient is going to die. After this, patient agreed for dialysis, and post dialysis, you can see the patient improved. This is the post dialysis, and the potassium 5 milliequivalent. So dialysis saved the patient. Otherwise, you would have died. Last. If the time person, I will present a spot case. घंटी बजेगा तो बोल दीजिए भाई, हम नहीं टाइम लेना चाहते हैं. ज़्यादा टाइम spot diagnosis. This is spot diagnosis. Two cases, similar ECG, but different diagnosis. A young adult, I will present only last 2 cases. Young adult presenting with the breathlessness on insertion. This is the ECG. What is characteristic? You can see infralaterally there is a deep inversion T wave. This is a classical apical hypertrophic cardiomyopathy. Apical. Inferolateral is apical. And it was confirmed by echo. So I am not presenting. With this reference, I am going to present the second case, which is important. Second case. This patient presented with tachycardia. Young boy presented with recurrent tachycardia. This is the ECG. Actually, this is atrial flutter. If you see the V2, there are 2 P wave, and patient was given DC shock, and post DC shock, this was the finding. So again, infralateral, you can see. So what is the diagnosis? Again, our diagnosis was this patient was a case of apicolateral hypertrophic cardiomyopathy, but our diagnosis was put wrong on echo. Echo was normal. So what is the diagnosis? I present the first case for this case. Then what is the diagnosis? Anyone? This is very important. Do you remember myocardial memory sign? Have you heard the memory sign? Post-tachycardia TV inversion may occur in some with a normal and it is cardiac memory. And this disappears after 1 to 2 weeks. And this ECG you can see after 1 week it disappears. So memory sign, cardiac memory, this is very important, memory sign. You may not be remembered, but this is very important. I think with this I conclude my session. Thank you very much.
Thank you, sir. After any episode of acute injuries and all that, you can have this cardiac memory sign, which persists for up to 1 week or maybe even be more. So that is one thing.
Thank you.
So we all heard and enjoyed, I suppose. So clap to banta hai yaar, kya? ECG is also known as the poor man's echo, and never miss the ECG, because most of the modern intervention cardiologists who are all DM, they always look for the echo. But I must tell you that echo will not give you any RWMA unless there is a acute onslaught. Remember this. So our next speaker is none else than my student and the present day chairman of the API Bihar and the ex-CCDSI chairman, Dr. Ravindra Kumar Modi, who was just, BK Singh is missing, I am not missing BK Singh. BK Singh has introduced you already as the lead speaker and the lead person who has done all the non-communicable disease programs and all that. He has given all the outsides, and we had got very good discussion onto that. So over to you.
Thank you, sir. Thank you for your kind words. And at the outset, I congratulate Dr. Gagan Gunjan for organizing this scientific program. And I also pay my regards to Dr. Professor Ian Rai, who is founder president CCDSI, who has created a group of all learned persons. So thank you, sir. With this, I start my presentation. Yeah. So there is a paradigm shift in heart failure management. Heart failure is one of the most prevalent cardiovascular disease responsible for hospitalization, reduced quality of life, and mortality among both a person living with diabetes and without diabetes. Affects 22% diabetics and causes 2 to 5-fold higher mortality as compared with non-diabetics. Despite advancement in conventional treatment, disease progression remained inadequate, and SGLT2 inhibitor represent most promising therapeutic agent with benefits in heart failure management in past decade. And emerging data support the concept of quadruple therapy, that is concurrent use of AC inhibitor, ARNIs, beta blocker, MRAs, and SGLT2 inhibitor as a new standard for heart failure management, and this combination provides maximum survival benefit and represents a true disease modifying strategy. So we know the definition of heart failure is a clinical syndrome characterized by symptoms of effort intolerance and signs of fluid retention. And in other words, we say that it is the inability of the heart to meet metabolic demands of the body, or if it do so, only at the cost of elevated filling pressure. We know the various stages of heart failure. Stage A, without any sign symptoms, but patients with hypertension, CVD, diabetes, obesity, they are at risk of developing heart failure. Stage B, here again there is no sign symptoms of heart failure, but they have evidence of a structural heart disease, and they have documented this biomarkers elevated. And in stage 3, symptoms begins, and stage D is advanced heart failure with marked heart failure symptoms that interferes with daily life and with recurrent hospitalization despite attempts to optimize from GDMT. So now coming to the pathophysiology, the primary cardiac insult is the main story that reduces ventricular performance, stroke volume, and that leads to neurohormonal activation, nervous system stimulation, then chemical messengers, RAS activation, and ADH release. And all leads to ventricular remodeling in the form of fibrosis, dilatation, reduction in the systolic and impaired diastolic function. That all leads to increased filling pressure, and that results in end organ hypoperfusion and congestion. And you can see here in kidney, similar things occurring, and we can see the common cardiorenal connections. We see the drivers are same: RAS activation, oxidative stress, inflammation, and sympathetic nervous stimulation, all affecting heart and all affecting kidney, giving rise to cardiorenal syndrome. So this is a RAS system. Now, what is the effect? The effect of ventricular remodeling in the form of LV dilatation, myocyte hypertrophy, systolic and diastolic dysfunction, and ultimately fibrosis. It is a viscous cycle. SGLT2 inhibitor, ARNIs, beta blocker, MRAs, they reverse this remodeling. Now, when we talk about heart failure in a diabetic, there are additional things that induces damage, like hyperglycemia induces damage because of increased reactive oxygen species and increase in the glycated products. There is direct effect of insulin resistance that leads to metabolic shift to fatty acid uptake, resulting in increased myocardial oxygen demand, lipotoxicity, causing further cellular injury, and impaired calcium handling in cardiomyocytic, and finally mitochondrial inflexibility, causing less ATP production. Diabetic cardiomyopathy is a distinct entity independent of coronary artery disease or hypertension that is characterized by structural and functional abnormalities, including left ventricular hypertrophy, diastolic dysfunction, and eventual systolic impairment and heart failure. So this is the similar slide showing the different pathophysiological mechanisms leading to heart failure. Now coming to the SGLT2 inhibitor, which is really a wonderful molecule. But before we talk about this inhibition, we should know the function of SGLT2. This SGLT2 receptor has two important functions. That filtered glucose is reabsorbed by SGLT2. And in heart failure, this SGLT2 receptors, they contributes to sodium and water retention, endothelial dysfunction, and abnormal myocardial metabolism and impaired calcium handling. And this SGLT2 blocks all these effects, resulting in increased glucose excretion from kidneys, glycosuria, and thus it reduces blood sugar and blood glucose level. So this is the most important mechanism, but with this there are so many other beneficiary effects that was observed later. So if we go to see the history, there is a story of SGLT2. In 1835, two scientists isolated a natural compound called florogene from root bark of apple tree. They observed that they can induce glycosuria, but they had severe gastrointestinal side effects. Later research was based on the fact how kidney reabsorbs glucose by SGLT1 and SGLT2 receptors. It was seen that in familial renal glycosuria, people lack functional SGLT2 and excrete excess glucose without major health problem, and this suggested that selective SGLT2 inhibition could be safe. Researchers further developed synthetic orally active derivatives of florogene that were potent and selective for SGLT2, leading to the development of canagliflozin in March 2013, dapagliflozin in January 2014, and empagliflozin in August 2014. The initial goal of all this medication was solely to improve glycemic control in type 2 diabetes. But the major turning point came unexpectedly from the large cardiovascular outcome trial, IMPA-REG outcome trial in 2015, showing significant and surprising 35% reduction in hospitalization for heart failure and 38% reduction in cardiovascular death in patients with type 2 diabetes and established cardiovascular disease. And subsequent trials, CANAVAS, DECLARE-TIMI, DAPA heart failure, imperial reduced, DAPA CKD, all confirmed this remarkable benefit across the entire SGLT2 inhibitor class, even in patients without diabetes. And these findings caused a paradigm shift leading to SGLT2 inhibitor becoming a foundational therapy in the treatment of heart failure, in the treatment of cardiology and nephrology guidelines. And today, SGLT2 inhibitors are core component of therapy for type 2 diabetes. So let us see the mechanism of action of SGLT2. The primary mechanisms being it blocks renal glucose reabsorption, causes osmotic diuresis and natriuresis, decreases cardiac preload and afterload, and it also causes metabolic shift, enhanced myocardial ketone body utilization, improving cardiac energetics and ATP production up to 30%. But beyond glucose control, it has got cardioprotection, renal protection, metabolic effects, weight loss, helpful in muscle, hemodynamic effects, anti-inflammatory factor, and of course, vascular improves endothelial dysfunction and reduces arterial stiffness. So these benefits are beyond glucose control. So similar things is being shown here, and overall downstream effects are reduction in the blood pressure, reduction in the glycemic acid hemoglobin, reduction in CV event, reduction in the renal disease, and reduction in the body weight. Now coming to the evolution of SGLT2 inhibitor from glycemic control to cardiorenal protection. In 2013, it was initially approved by FDA. In 2015, IMPA-REG trial came, and it was the first CVOT demonstrating 38% reduction in CV death and 35% reduction in heart failure hospitalization, shifting focus beyond glycemia. In 2019, DAPA heart failure came. In 2021, imperial preserved came, and it showed that empagliflozin reduces heart failure hospitalization in heart failure with preserved ejection fraction, and becoming the first agent with proven efficacy across the entire ejection fraction spectrum. And 2023, all guideline adopted, they advised to add this gliflozin in their guidelines. So this is an overview of all landmark trials. We can see IMPA-REG, CANAVAS, DECLARE-TIMI, DAPA heart failure, imperial reduced, and imperial preserved. We can see the drugs they used and the population where the trial was carried out. And collectively, we can say these trials established SGLT2 inhibitor as the foundational therapy across the heart failure spectrum with consistent benefit irrespective of diabetic status or ejection fraction. Now we should know the safety and we should know the precaution when we prescribe this drug. It has got favorable safety and tolerability profile. The standard dose for cardiorenal benefit is 10 milligram for IMPA and DAPA. Genital mycotic infection is common, 3 to 5%, that is glycosuria induced due to local candidiasis, but it is not a contraindication to stop the treatment. UTI is not so common, but if there is recurrent UTI, it is an indication to stop SGLT2 inhibitor. Volume depletion is common due to osmotic diuresis, and it may lead to hypotension, so precaution should be taken, especially in elderly population. Euglycemic diabetic ketoacidosis is rare, but the risk increases when there is carbohydrate deprivation. Avoid using this molecule when effective GFR is less than 20, and there must be temporary discontinuation before surgery, during acute illness, and during fasting. It should not be started in a dialysis patient which is dependent on dialysis in end-stage renal disease, and of course it is not recommended in type 1 diabetes because again the risk of euglycemic diabetic ketoacidosis. Now, which gliflozin is best? This is a very, very important question. But this slide is showing the comparative efficacy. When we talk about the pharmacokinetic variability, all gliflozins exhibit minor difference in selectivity for SGLT2 or SGLT1, renal clearance and half-life, and meta-analysis confer robust class effect, and it is our choice which molecule we start. So this is the ADA guideline. We can see the importance of SGLT2 inhibitor in different classes of diabetic patient. And finally, the key lessons: benefits is independent of glycemic status, from glucose control to holistic multisystem organ protection, and universal benefit in all heart failure phenotype. Earlier the initiation, greater is the benefit. The ADA 26 recommends SGLT2 inhibitor for all patients of type 2 diabetes with established heart failure, any ejection fraction, CKD with ejection fraction more than 20, and there is high atherosclerotic cardiovascular risk. European Society, they say first line therapy in all patients with heart failure with reduced ejection fraction, when ejection fraction is less than 40, with or without diabetes. That is class 1 level A recommendation, but for preserved ejection fraction, IMPA receives a class 2A recommendation to reduce heart failure hospitalization risk. But there are few unanswered questions about its role in acute heart failure, but the trials are going on, IMPULSE, DAPA acute heart failure trial, and the results are, I say, very promising. Its role in right heart failure, pulmonary hypertension, post-myocardial remodeling prevention, but still trials are ongoing. SGLT1 and 2, that is dual inhibitions. So there is another trial, sotagliflozin heart failure trial is going on, and results are here also very promising. There is another subgroup of heart failure patient, that is amyloid cardiomyopathy, genetic hypertrophic or obstructive cardiomyopathy, primary uncorrected valvular disease or severe kidney disease. They should be further investigated for the beneficial effect of SGLT2. So here I end, and thank you very much for your patience listening.
Thank you, sir, for insightful and thought-provoking lecture. Now, I would like to start, sir, new lecture, and thanks for your wonderful session.
Thank you very much, sir. Thank you.
Next session is redefine the peak, setting new expectation for type 2 diabetes management with tirzepatide. For this, I would like to invite on the dash Dr. Gyan Prakash.
Thank you, sir. Thank you, organizer, for giving me this opportunity. Now, respected seniors, chairpersons, and dear friends. Now, I am going to talk about the redefining the peak, the molecule of interest is tirzepatide. Earlier, we used to manage diabetes with the agent which primarily target blood sugar level only, and there is modest reduction in weight and not much benefit. But now we all know diabetes is not only the blood sugar control, the obesity, insulin resistance, all these are a major driver of diabetes. This is the disclaimer. The program is sponsored by CIPLA, and during this meeting the topic covered will be exclusively within the scope of indication provided in the approved prescribing information in India only. Your peak is registered trademark of Eli Lilly and promoted and distributed by CIPLA in India. The speaker is contracted by CIPLA for this talk. Now moving towards the scientific program. Let us start first with the problem what we are facing. We can see, in spite of availability of so many oral anti-diabetic drug and insulin, still the A1C target is uncontrolled in majority part of the world, ranging from the 36% to 74% in spite of all the management available. And at the same time, in Western population, we can see the obesity population is also high. That means the diabetes is now diabesity, it's not only diabetes. And the study done by WHO published in 2023, it shows that the new onset diabetes and the obesity is accountable for the 65% to 80% in many of the cases. The ADA and ASD focus on 2 points. The first one, the impact of weight loss in diabetes. Even the 5 to 10% weight loss yield metabolic improvement, and the higher weight loss to 15% may lead to reversal of diabetes. Second point is that before the diagnosis of type 2 diabetes mellitus, the complication started, we should act early because damage is already started. Early intervention in type 2 diabetes mellitus is critical, and management of obesity is equally important. Now we are going to discuss about the molecule of interest, that is your pick, that is the tirzepatide, the dual agonist of GIP and GLP-1 receptor. Start with the pathophysiology of incretin. As soon as we take the food in intestine, 2 hormones secreted. First one is the GIP and second one is the GLP-1. And these 2 hormones reaches to pancreas and stimulate beta cell to release the insulin. And it has been seen that the GIP contribution is 67%, whereas GLP-1 is the 33%, that is the 1/3. And it is also called an incretin effect. In people with type 2 diabetes mellitus, the total incretin effect is diminished. Now what it does with the body? Started with the brain, it improved the satiety and reduced the food craving. In the subcutaneous white adipose tissue, increase the insulin sensitivity. Pancreas, there is increased release of insulin by GIP-1 and GLP-1. Also there is reduction in glucagon with the GLP-1 activity. And in the stomach, there is a reduction in the gastric emptying. That means it acts on the gut, brain and pancreas axis. Now we talk about the molecule. This is the single molecule which target both the hormone like GIP-1 receptor and GLP-1. Initially it was GIP-1 and modification done to act on the GLP-1 also. The GIP-1 receptor action is almost similar to native one, and GLP-1 is little bit inferior than the native GLP-1 hormone. Mean half-life is 5 days. Making once weekly dose is very much practical, and even in the hepatic and renal dysfunction, the dose adjustment is not usually required. Now what this drug does, as we have seen in the pathophysiology of GIP-1 and GLP-1 receptor, we can see the started with the brain, there is decreased food intake, in the stomach slow gastric empty, in pancreas increased insulin sensitivity and increased insulin secretion through pancreas, and they enhance first and second phase insulin secretion, and it also act on the adipose tissue to improve the insulin sensitivity. Now moving toward some study data. We started with the SURPASS-2 trial, which compare tirzepatide with the semaglutide 1 milligram. That is the approved dose for the measurement of type 2 diabetes mellitus. This is the study design. The sample size is 1879. All the patients who were diabetic uncontrolled on metformin were randomized in 4 groups. And semaglutide 1 milligram as far as tolerated compared with the tirzepatide 5 milligram, 10 milligram and 15 milligram, and the study duration is 40 weeks. The primary endpoint is the change in A1C. Overall base mean A1C level was 8.3%, that is uncontrolled. Mean duration of diabetes was 8.6 years and baseline BMI was 34 milligram 34 kg per meter square. What we got that all dosage of tirzepatide starting from 5 to 15 or to score semaglutide as far as the A1C reduction is the concern. What about the target level less than 7%? We can see 9 out of 10 patients achieved the less than 7% of A1C target. Whereas when we look for less than 5.7%, that is near normal glycemia, 51% patient taking tirzepatide of 15 milligram can achieve this target compared with 20% on the semaglutide. When we look for the weight loss, initial weight loss was 93.7 kg. With 15 milligram of tirzepatide, the loss was 13.1%. Compared to semaglutide has 6.7%. That means weight loss is also much more with the tirzepatide. And as early as 4 weeks, the weight loss started and it continues going on till the 40 week of a study. The further it takes, the benefit must be going on before, after this study also, and it takes 70 weeks to give plateau. The benefit continued to occur. When we look for the amount of weight loss, because we need minimum 5% of weight loss to get meaningful benefit, and 86% 15 milligram tirzepatide group got the 5% weight loss compared to 58% in SEMA arm only. And when we look for more than 15% of weight loss, 40% in tirzepatide 15 milligram compared with the 1 milligram SEMA, that is only 9. Now we will looking for the composite endpoint. It combines 6.5% of A1C, weight loss of more than 10%, and no clinically significant or severe hypoglycemia. What we see that the 5 milligram of your peak, that is tirzepatide, had 32% compared with the SEMA, that is only 22%. With tirzepatide of 15 milligram, we can give this comprehensive benefit up to 60%. That is the quite encouraging feature. There is also improvement in BMI and waist circumference with tirzepatide more than SEMA. We also get benefit in the lipid profile. We can get 25% reduction of triglyceride with 15 milligram of tirzepatide. We also get improvement in the VLDL and LDL parameter. That means overall lipid profile got better, both with the Terze and SEMA, more with the Terze. We also got there is improvement in blood pressure also, both systolic and diastolic, although it was not a significant, but there is just some data is favorable, at least in numerical base, mainly because of weight loss and increased insulin sensitivity. Now coming with the safety, GI side effects were more prominent but easily manageable. The discontinuation only needing in the 4.1% in SEMA arm and 6% in tirzepatide 5, 8.5% in 15 milligram. All the side effects are minimal and it can be easily managed. When we look for the nausea over time, we can see in initial part the symptom is more, but as soon as the drug is continued, so it got better. That means this can be managed easily by proper counseling. We have to more careful during initial phase when dose titration is done. When we look for hypoglycemia due to unique nature, the hypoglycemia is very much less. It also with SEMA and Terze, but when we compare with the degludec insulin, that is the SURPASS-3 trial, the hypoglycemia is much less compared to degludec. The efficacy is more and the side effect is less. Now looking for other SURPASS study, there are 5 SURPASS studies. Started with SURPASS-1 that compared with placebo. 2 with semaglutide already discussed, 3rd one with degludec, 4th one with glargine, and 5th one was addition to insulin. The trial design is almost similar. We compare with the placebo or other drug as comparator, and all three drug dose tested 5, 10 and 15. A1C reduction is across all trial is prominent compared to other drug. Even addition to insulin, it ought score. And similarly, when we talk of the target of less than 7% across all the trial, tirzepatide auto score is comparator or placebo. The weight loss is also there with the use of tirzepatide compared to placebo and other drug. And in the summary, we can see the first and only approved single molecule, that is the GIP and GLP-1 receptor agonist, getting the A1C reduction up to 2.6%. None of the other drugs reached this. At the same time, it also got the weight loss of 12.9 kg, that means the 13.6%, that is quite encouraging, and the drug is very much efficacious, safe, and it tackles both the glycemia and metabolic component. Thank you.
Thank you for wonderful lecture. Sir, I would like to share my one clinical case related to diabetes. One of my patient, he was around 40 to 50 years old. He was on sitagliptin, full dose metformin, and Rajgir BD dose. But his glycemic control was very poor. He has a recurrent UTI, so SGLT inhibitor was stopped. Even after controlling the UTI at the same time, a recurrence happened due to uncontrolled diabetes. Then I started semaglutide 3 milligram OD and stopped sitagliptin. But after stopping sitagliptin, glycemia, sugar control worsened. Then patient complained to me that मेरा symptom जो है डॉक्टर साहब और ख़राब हो गया. तो मैंने क्या किया, I changed the dose after 7 days, 3 milligram to 7 milligram. Within a week, the patient improved. Is it a real practice? It should be happen to change 3 milligram to 7 milligram in a week.
Sir, usual practice is to dose the titration for oral to 15 days to 1 month. But
So,
in a special circumstances, it can be done.
How when sitagliptin should not be combined with semaglutide?
Yes, sir, because it's,
So
similar
if sugar is not controlled, even it worsen, how could we handle this situation?
We can
when patient is on 3 milligram semaglutide.
We can use other drug in the
Which,
meantime.
he is on every OHA with optimum dose.
Sir, in oral case, we can even in some cases a start of 7 milligram also. But these all are outside the recommendation.
Okay.
These are depending on the clinical experience and comfort of the patient. But as far as the guideline is concerned, start with low dose, titrate in oral for 2 weeks, and for injectable, it should be titrated at the interval of 4 weeks. And if there is a symptom of GI is more, the titration may be delayed as far as the guideline are concerned. But in practical, we can do without any problem.
Thank you very much, Gyan Prakash. I think the point to just what he raised was acute conditions, stop this, switch to insulin.
Yes.
That is the best thing,
Best.
right? So in all cases of chronic management and all that, then you should start slowly.
Yes, sir.
You should start slowly, give them ample of time, at least 3 weeks to 6 weeks.
Yes, sir.
And then after you can escalate the dose, unless there is some warranted request from the patient's problems or comorbidities existing. That's why I said at the outset that if any acute problem, then just stop oral hypoglycemics, shift to the insulin. That is the best thing available. So I think we had a good discussion. Now we come down to the next speaker. Thank you very much, Gyan Prakash. Dr. Sajjad Hassan. Dr. Sajjad Hassan, introducing your pick for weight management. specific points. Sajjad will just, I think, utilize some of these slides what his preceding speakers has been there. Thank you. Over to Sajjad.
Thank you, chairpersons, honorable chairpersons. First of all, I extend my warm gratitude and regards to the honorable National President of the CCDI, Dr. Raj sir, and all the dignitaries, and a special thanks to Dr. Shaibal sir and Dr. Gagan Gunjan for inviting me for this wonderful scientific feast. So as the Dr. Gagan has talked about the one aspect of this tirzepatide, and he has shown all the good data about the wonderful A1C reduction of this tirzepatide. But if you talk about in this GLP era, and if you see the timeline of the evolution of the GLP from the short-acting GLPs to these long-acting. So before going ahead, this is the disclosure for this talk. And we know that if you see the timeline of the GLPs, we started with the short-acting GLPs, lixisenatide, then we go to the dulaglutide, liraglutide, and you see all these GLP was primarily designed and meant for the A1C reduction, but additionally the data we got in terms of benefit of the weight loss, and later on the first GLP which was primarily approved, that was the semaglutide for the obesity indication, and later on we are in this journey, we are going through and having some more drugs like tirzepatide, and few more drugs are in the pipeline like rutatrutide, and one of the previous speaker was talking about Dr. Amit Kumar Das was survoglutide. So we are in an era, we are working more on the GLP, GIP and the glucagon. So why we are so much concerned about the obesity? Because if you look at all the guideline writing societies, whether it's a World Obesity Federation, Royal College of Physicians, they are not taking obesity as an isolation, but rather they are telling that obesity is a chronic, relapsing and progressive disorder that needs an immediate call of action, not from the diabetologist or endocrinologist, rather the all parts of the specialties, because it has a huge impact on all cardiovascular aspects. If you look the prevalence of the HFpEF, I will show you one data that in HFpEF patients, which is a quite so common conditions, and if you will try to measure obesity just by a BMI alone, you will miss most of the cases. So obesity is so much important, and that is why we have shifted our focus in terms of definition of obesity, just not by calling it a BMI of more than 30, because if you look at our population, not from the Caucasian population, Asian population, we are having a lower cutoff of obesity, that is 27, and we define for Asian population that is 23. So it's a complex disease that is just not only excess deposition of the body fat, rather it's an, we change this terminology, because obesity sometimes we call obese to someone, this is a stigma. So this is a new terminology, that is adiposity based chronic disease, which defines obesity as a abnormalities in terms of distribution of adipose tissue in terms of mass, distribution as well as function. So how you see the changes in terms of these adipose organs when they convert from this lean state to this obese state. So this is just not in hyperplasia in terms of cell number, rather you will find that there is a hypertrophy also, with so many pathology and pro-inflammatory pathways activated, more fatty acid release. One terms, in hyperplasia, you will see there is an increased adiponectin. Adiponectin is a good hormone, but when you see this hypertrophy of the adipocytes, this has a down regulation of the adiponectin, more recruitment of pro-inflammatory cytokines, and this transition of the adipocytes from the lean to obese state, that creates an imbalance from the pro and anti-inflammatory response that shifts towards all these cells to immune cell infiltration, more neutrophilic infiltration, hypoxia, fibrosis, and altogether decrease insulin sensitivity. So this is the pathophysiology, and we have seen the same pathophysiology what Dr. Amit Kumar Das has shown in the pathophysiology of the MASH also. So we have a common soil hypothesis. We have seen the hypothesis of this MASH. You will see this, there is a common pathophysiological factor in all these things. So somehow weight reduction is important. We have learned from lifestyle trials like Look Ahead trial has told a very good lesson that a good amount of the weight loss can lead to some important physiological benefit in terms of type 2 diabetes remission. But how much weight loss is important? This is always a good question. Because if you see the data, just a minute weight loss of 5 to 7% gives you some benefit, but not a huge benefit in terms of type 2 diabetes remission. For this, at least a 15% of the weight loss is important. For dyslipidemia, you will see this data, there is a 15% weight loss is quite important to have an impact. What Dr. Gyan has shown you the data, there is a pleiotropic benefit in terms of reduction in LDL, reduction in triglyceride. So we need a good amount of the weight loss, but we see that all the trials which has been conducted on the lifestyle look ahead, we have direct trial data, we have some other trials, Chinese studies, and all these has shown that a trivial weight loss is not important. We need something more, up to 20 to 25% to prevent or halt these obesity related complications. So we are thriving more for greater weight loss. So if you see the management options, not just because of this lifestyle and psychological interventions which gives a 3 to 5% weight loss, and if you see some greater interventions like bariatric surgery, that gives you a huge 25 to 35% of the weight loss and remission in the diabetes and some improvement in the hypothyroidism. But if you see there is a great gap exists between these 2 points, and that is the point where we need some metabolic surgery, not bariatric surgery. So we call it this GLPs as a source or as a tool of metabolic surgery that is now in our hands, like drugs like tirzepatide or semaglutide. I will show you the data that how much robust these drugs are in terms of weight loss. So this is a good study by Professor Avdesh also, which shows that the comparative analysis of all the anti-obesity drugs, both in sole obesity as well as obesity with diabetes. So if you see the commonly what drugs we are having, semaglutide, tirzepatide, we are currently having these drugs in India. So if you see the weight loss data with 2.54 milligram of subcutaneous semaglutide is up to a tune of 17%. But this is a data, what sir was asking about this Rybelsus 3 milligram. So 3 milligram Rybelsus or semaglutide, that is oral drug, which was studied in pioneer series of the trial. So if you see the 3 milligram is not sufficient for a good A1C reduction. For with 7 and 14 milligram, there was a good A1C reduction. Similarly, if you see the data of that oral semaglutide, that was 50 milligram, they have tried for obesity, and that shows a robust data of 17% in terms of weight loss. But if you compare with the drug in class I'm going to talk about, that is tirzepatide, which has shown a robust data of in SURMOUNT series of trial a tune of 22.5%. So in currently what we are having, tirzepatide is having a superiority in terms of weight loss as compared to the semaglutide. We have a drug in the pipeline, that is rutatrutide, which has been studied in TRIUMPH series of trial, which has shown a 25%. But currently this drug we are not having. But one wonderful thing, what surprising thing rather you can see that in diabetics with obesity, all these drugs are not showing a greater magnitude of the weight loss rather than what they are showing alone in the obesity. So this is a surprising data that with all anti-obesity drugs. So Dr. Gyan has already shown you the mechanism of action of this GLP and GIP tirzepatide. So I'm not going into the detail, but what happens? Why tirzepatide is having a greater edge over the semaglutide? Because semaglutide is just a GLP-1 agonist, and this is having a both combined action GLP and GIP. So what is the difference when you add a GIP and we work on the GIP? So certainly if you see that this has a more action on your adipose tissue, more lipid buffering, more vascularity of the lipids, and a greater action of the pancreas, so which we call as a GLP agonism also, with more glucagon in a glucose dependent way and more insulin. That is first phase insulin secretion is more with the more GIP action. So what Dr. Gyan has shown in terms of the mechanistic aspects of the GLP and GIP. So let's whether this mechanistic profile is translating into the real world RCT's data. So SURMOUNT series of the trial is a robust series of trial which has compared with placebo in SURMOUNT 1 in participants with obesity alone. In SURMOUNT 2, they have compared with obesity with type 2 diabetes, and similarly they have compared with intensive lifestyle also. So after having intensive lifestyle, they have introduced this tirzepatide and they have assessed for the results in SURMOUNT 4. This is always a question to us that what happens when we will stop or withdraw these drugs after using for some time. So there is the answer in the SURMOUNT 4 trial also. And last SURMOUNT 5, in which they have compared apple with the apple, that is they have compared semaglutide with this tirzepatide, all these trials with a good duration of the data. So what in terms of magnitude of the weight loss, what with tirzepatide as compared to the placebo in this is a good study. 2,600 participants they have taken with a BMI of more than 30 or with a BMI of more than 27 with some additional complications related to the obesity like hypertension or ASCVD. So they have carried out this study for 72 weeks and assessed for the percentage change in the body weight from the baseline. So if you look at this data, that just at 16 weeks, this is 22.5% at 72 weeks in most of the participants. But the interesting data is that the curve is separating just at the between the 4 to 8 weeks. So the response is early, not so delayed. So most of the participants, this is a very interesting slide because we have always been asked that how fast we should up titrate also. So even though if you are going on with this just 5 milligram, if you need a 10% weight loss, and if you go with a 5 milligram or 10 milligram dose of this tirzepatide also, you will see that almost 75 to 80% of patients, they are having a good amount of the 10% of the weight loss with this just miniature dose of 5 or 10 milligram also. So, but when they have, you need more weight loss, you need to go on and up titrate the dose at to the maximum tolerated dose of either 10 or 15 milligram, which they have used in all these trials. So almost 4 in 10 participants who has taken this 15 milligram to maximum tolerated dose, they have achieved a weight reduction of more than 25% from the baseline. So I think this is one of the robust data till now we have with any other anti-obesity medication in the history of the anti-obesity medications. So a majority of the patients, you will see that they have achieved just with 5 milligram 10 in any series, they have achieved this weight loss. But the most important thing is just not having a weight loss, rather than what is the redistribution of the fat in your body. So just what I calculate that if you lose just 15% of your body weight, how much you lose from your abdominal visceral fat? It is just 30%. And if what you lose from your liver, it is almost 66%. So this is the magnitude of the weight loss and the magnitude of redistribution of the fat, which gives you the wonderful data in the ESSENCE trial also. So waist reduction was almost 20 centimeter at 72 weeks, and this is the change in the composition of the body fat mass. Reduction in total fat mass was accompanied by this reduction of the visceral fat, but there was some reduction of the lean mass also. And this was the pleiotropic benefit, which Dr. Gagan has already explained, that there was improvement in all dyslipidemia patterns and some improvement in the blood pressure. But maintenance of efficacy, because this is the common question that what happens when we withdraw this drug. So this is the answer, that if you, when they have studied up to 36 weeks, they have achieved the data weight loss of 21%. But those participants who have carried this drug for 88 weeks, they have further lost for 6.7% more. But those who have left it, they have gone back and they have a further weight gain of 14% from the baseline. So waist circumference, there was a similar data. Those who have carried on, they have achieved a 4.6% further weight loss. And this is the comparison of this, not apple with the oranges, rather than apple with the apple in the SURMOUNT 5, in which they have compared with the semaglutide with the maximum tolerated dose of 1.7 or 2.4 milligram, with these dosage of 5, 10 or 12.5, and this maximum dose of 10 or 15 milligram. And this is the data that as comparison to semaglutide, this is 21%, while in the semaglutide arm at 72 weeks, it was only 15.4%. So most of the patients, those who are on the tirzepatide, they have 36%, those who are taking the tirzepatide have achieved a weight reduction of more than 25%. This was not so with the semaglutide as compared to the tirzepatide. Similarly, with waist circumference, this was a quite better data with the tirzepatide with 20 centimeter as compared to 14 centimeter. So this was the slide which I was talking about, that just in terms of lowering of weight is not important, because if you see the waist to hip ratio, you will find the heart failure with preserved ejection fraction prevalence when you have a BMI waist circumference of more than 0.6. Dr. Gagan has explained about this GI side effects, but the most important, there are some trivial differences. Because GIP is anti-nauseating probable action, there was some supposed and some practical experiences also that with tirzepatide there was a little bit less nausea as compared to the semaglutide. So if you see the data of the GERD, so as compared to the semaglutide, you will find less GERD prevalence in the tirzepatide arm, probably because this is the GIP action which is thought to be behind it. Vomiting is quite rare because this data is showing nausea is possible with the starting dose or with the, when you escalate the dose, and diarrhea is also quite important, and predominantly what you see that constipation is more in the semaglutide, because if you see the GLP has a and delayed the gastric emptying, but you have the GIP action that increases the GIP action. So this is the some of the cautions. You have to advise your patient to have small meals, avoid fatty, and get well hydrated when you start with the tirzepatide. Always start with 2.5, escalate the dose to 5, but don't be in hurry. Don't up titrate so fast if you want to carry on your patients with the long time, because a fast titration can sometimes put your patient in trouble. So if you see the relative efficacy of all the anti-obesity medications as compared to the semaglutide, tirzepatide, or previous drugs like liraglutide, tirzepatide in SURMOUNT trial have shown a robust efficacy, significant and sustained weight reduction with a weight loss of 26 to 27% at week 8 at this SURMOUNT 1 and SURMOUNT 4 trial, with all improvement in the metabolic profile. So thank you all for your patient hearing. Thank you so much. And I will be happy if there will be any questions or query on your own experience about these drugs. Thank you.
Thank you, Dr. Sajjad, for wonderful lecture. Just I would like to take 1 minute from you.
Sure, sir.
How much weight loss we can expect from physical activity, and why? I have gone through some literature. In aerobic activity, there is more fat loss. In anaerobic activity and heat, there is more glucose loss. So why in aerobic activity, fat loss is more than glucose loss?
Sir, with physical activity, of course, we lose weight, but just not with the physical activity alone. It has to combine with your hypocaloric diet, because if you see all the previous trial data like Look Ahead trial, Direct trial, and some other trials, they have put and they have achieved a good amount of the weight loss, in some trials 10 or 15%, but they put their patient to a very low calorie diet. In all these trials, the calorie they have been provided 800 to 895 kilocalorie. So with aerobic exercise, of course, we lose more fat mass, but with the similar loss of the fat mass also, there is a lean muscle. So the muscle training is sometimes quite important to add on with this aerobic exercise.
My question is why fat loss is in aerobic activity around 60 to 70% for fat loss, abdominal fat loss, and 40 to 40% carbohydrate loss. In anaerobic activity, there is usually carbohydrate loss, and heat also there is a carbohydrate loss. Why?
So I exactly don't know the mechanism that what you are talking about. If
but
anyone from the audience,
I think in an
Actually, when we do physical activities, especially aerobic activities, so in beginning up to 20 minutes, it is glucose that is the main fuel that get burned. But beyond 20, it is a fat. Fat metabolism begins after 20 of continuous aerobic activity. But it is only for moderate intensity activity. The moment we touch the vigorous or severe intensity, again glucose becomes the main source of energy.
But I would like to share that in anaerobic activity, there is less oxygen available for these activities. So fatty acid oxidation, oxygen is essential. But for glycolysis, it is an anaerobic condition.
Yes.
So it happens in heat and anaerobic exercise.
Right.
In patient of diabetes with obesity, you can start GLP-1 agonist directly, or you have some criteria or duration. So what is the protocol to decrease weight in patient of obesity with diabetes?
In patient of obesity with diabetes, you can directly start with either with the GLP-1 agonist, semaglutide, or with the tirzepatide. But those patients who are not diabetic, you have to set a criteria, because what the guideline says that either they have a cutoff of BMI of 30, but with a BMI of 27, but they should have at least one conditions, like if they have hypertension, any ASCVD, any dyslipidemia, any HFpEF, you can directly start GLP-1 agonist semaglutide also, as well as the tirzepatide also in all these conditions with a lower BMI also. Because if you see the indication data, because right now these drugs have not directly been approved apart from the obesity. We have the data from the Essence trial that is showing, but these drugs are not directly approved to use in the NASH, but you can get the pleiotropic benefit when you add in the patients with the obesity or combined comorbidities also. But non-diabetic patients, with diabetic patients, there is no hesitancy, because you can directly start with these drugs, GLP-1 and the GIP. But one thing you should be very cautious, that for all those decompensated patients, like Child-Pugh criteria, Dr. Amit Das said that insulin is the choice. In very hyperosmolar state, very high glycemia, always insulin should be added. Right? Sir was asking about the 3 milligram of the semaglutide that he started. So initially, if you start with the GLP, they take some time to act. Initially, they are not so fast acting like insulin that you expect results in just 1 week.
Thank you.
Yes, sir.
Thank you very much. Now we had
1 minute, sir. 1 minute, sir.
Sir, ऐसा है ना, I am sorry.
One minute.
Sir, ऐसा है ना,
Yes, let me one.
लोकसभा अध्यक्ष हम हैं.
1 minute.
आप राहुल गांधी की तरह बोल रहे हैं.
बाहर चल जाइएगा. I have to make a comment simple on heart failure with the permission of Dr. Modi. Heart failure with preserved ejection fraction now taking 50% of the composition. And in recent update 2023 focused guideline suggests SGLT2 now as a class 1 level A indication. So that has to be revised. That's only.
सर तो सब एक मिनट रवि, अब no more questions. हर आदमी जानते हैं कि whether you are a diabetic or non-diabetic, if it is a heart failure, then go for SGLT2. Thank you, Sajjad. Now this session is over.
Sir,
now hand it over to the next.
Sir, I must thank Sajjad for mentioning my name so many times.
After the interesting talk of Dr. Sajjad and Dr. Gagan about this exciting new molecule, it brings the third session of today's morning to an end. Now it's time for the prestigious Dr. A.K. Virmani oration, and for that I would like to invite Dr. A.N. Rai sir, Dr. A.N. Rai sir, Dr. B.K. Singh sir, and Dr. Mridunjay to chair this session. Since this is an oration, we won't be having any questions, and there are no time limits for that. Please. A.N. Rai sir. Sir, kahan ja? हाँ हाँ सर कहाँ जा रहे हैं? सर कहाँ जा रहे हैं? अच्छा It's my pleasure and honor to announce the name of Dr. Madhukar Rai sir as the recipient of this year's Dr. A.K. Virmani oration. So ladies and gentlemen, please put your hands together in congratulating Dr. Madhukar Rai sir. Before I call him on the stage, I would like to introduce him to those who don't know, but everybody knows him, but it's customary. So I'll go along and it's a long talk. So I would request Dr. Madhukar Rai to stay put where he is. We'll call him up on stage later on, after I introduce him. Sir is an MD in Medicine and DM Endocrinology, is currently working as a professor, Department of Endocrinology, Heritage Hospital, after serving as a senior professor, Department of Medicine in Institute of Medical Sciences, Banaras Hindu University. Sir is a medical teacher with more than 33 years of experience in teaching undergraduate and postgraduate medical students, and also a PhD research guide for over last 20 years. He has guided more than a dozen PhD candidates and also guided over 40 medical MD students. He has been a medical examiner for UG, PG and DM examination. He has gone more than 125 publications in national and international journals, including the prestigious NEJM, Lancet, Nature, Genetics, BMJ, CID and PLS1 with more than 1200 citations. He has contributed many chapters in various textbooks and updates. Sir has received training at Cambridge Institute of Medical Research UK, has worked with NIH, Bethesda, USA, Cornell's Medical Center, New York, and Bhabha Atomic Research Center. He has been a principal investigator and co-principal investigator of various research projects funded by NIH, European Commission, Gates Foundation, DBT, WHO, and many others. He has been an invited speaker at various national and international forums and also has been rated as best clinical teacher at the Institute of Medical Sciences, Banaras. Sir has been scientific secretary, treasurer, and member of Executive Committee of Endocrine Society of India, member of governing body of Association of Physicians of India, president UP Association of Physicians of India, and he has also been the past president of CCDSI. So, ladies and gentlemen, please welcome Dr. Madhukar Rai sir on stage. Sir, please.
Welcome, sir. Dr. Madhukar Rai is a well-renowned endocrinologist in the not only in the eastern part of India, but I think he is the one of the most knowledgeable person. I feel, and because the Aurangabad is very near to the Varanasi, and we see many of the patient praises Dr. Madhukar Rai, and he's such a humble person and very good looking. So I welcome you, sir, in the prestigious A.K. Virmani oration. We have started this oration 3 years back, and we this year we planned that no one other than Dr. Madhukar Rai should get this oration. So with these words, welcome you, sir, and I request
the
for
chairpersons to
the
felicitate
Dr. A.N. Rai, sir, to
Dr.
felicitate
Madhukar Rai, sir.
Dr. Madhukar Rai.
First of all, thank you for this enormous respect and honor which you have given to me, and Dr. B.K. Singh, a very good friend, and of course Dr. A.N. Rai is a guardian, both in terms of a sort of a professional one as well as a personal guardian also. Our association is very, very old. Friends, it's an honor to be here. I am humbled and speaking in the name of Dr. Veermani, who is also a very good friend. It really is a welcome for me. My talk is like covered in bits and pieces by all the speakers. What I wanted to just put it together is, when we talk of diabetes and heart disease, this is a major cause of death. But when we talk of heart disease and diabetes, dominantly what we do is, we talk in terms of atherosclerotic cardiovascular disease. But that's not true. Diabetes affects every part of the heart, including the cardiac myocytes, the vessels, which could be microvascular and macrovascular both. And one thing which is very commonly missed is autonomic nervous system, which also contributes to, and unlike the conventional wisdom of atherosclerotic cardiovascular disease, which we take as a sine qua non for diabetic heart disease, which is not true, and I will be taking you through the journey. So this is the conventional definition that cardiovascular diseases and is a major cause of morbidity and mortality in a diabetic patient. Presence of diabetes increases the risk of CVD by 2 to 3 fold and compared to the general population, and moreover it occurs around 15 years earlier as compared to the general population. And most of the patients who are diabetic, they die young of heart disease, and that's a very important thing. Now, to understand this and to intervene on the diabetes heart disease, we have to understand the natural history of diabetes, and this is the natural history of diabetes. And what you find is the diabetes starts way back. The pathophysiology starts way back, and the most important pathophysiological thing which happens in diabetes is hyperinsulinemia when the patient is euglycemic. And this is where the role of obesity comes. Obesity in a very different way. When we talk of actual body weight, BMI, it's not that. When there is a obesity, it leads to, obesity is now not defined by body weight. It is defined by increase in the body fat content, and that to visceral adiposity rather than the subcutaneous adiposity. But that's important. Having said that, this obesity leads to hyperinsulinemia when the patient is euglycemic. And as there is a continuous hyperinsulinemia, as you can see, the beta cell starts failing. The blue line shows the beta cell is failing, and this beta cell starts failing. It tries to respond to hyperinsulinemia, and then when it starts failing and it has failed sufficiently, you get a progressive increase in diabetes. And this is the time when we define that the patient is having diabetes. But already so much time has been spent, and there a lot of cardiovascular events have already happened in the patient body. So what is, we are too late. We are late by almost 10 years. Because of the pathophysiology started much ahead, and this we need to understand. And here comes the importance of Dr. K Singh's epidemiological data and other things which we need to know. Now let us compare type 2 diabetes and type 1 diabetes. In type 2 diabetes, what is happening? Basically type 2 diabetes is lipotoxicity. And then glucotoxicity is the terminal event which you try to identify. And due to this, macrovascular disease occurs first, and microvascular disease is going to happen later on, because microvascular disease is dominantly driven by hyperglycemia. In contrast to this, in type 1 diabetic patient, what you find is it's a pure glucotoxic state, where as the patient progresses with insulin therapy, lipotoxicity develops. So the microvascular disease appears first, and subsequently the patient gets macrovascular disease. So this is very, very important. And so in nutshell, microvascular disease is largely a domain of glucotoxicity, while macrovascular disease is multifactorial, and hyperglycemia adds fuel to the fire. So this is the hyperglycemia is a major and independent risk factor for each of this micro and macrovascular disease. But macrovascular disease occurs first, and once diabetes develops, hyperglycemia develops, it accelerates all this process tremendously. In contrast to this, retinopathy will not develop in a person who doesn't have hyperglycemia. Peripheral vascular disease, neuropathy will not develop in a patient unless the patient has developed hyperglycemia. So these microvascular complications are essentially a domain of hyperglycemia. And if you are looking at the heart, there is involvement of muscles, diabetic cardiomyopathy, coronary artery disease, as well as microvessels and autonomic nervous system. And this is what we are going to discuss. Now, coronary artery disease is recognized most commonly. Lately, we have started recognizing, and most of the discussion was focused on this, is diabetic cardiomyopathy. It was the least recognized complication and the most dangerous one. And thanks to all the CVOT trials after 2008, we became increasingly aware of this particular entity. Another entity which we rarely look for in a diabetic patient is a cardiac autonomic neuropathy. This also needs to be looked into. Now, if you try to look into the pathogenesis of the initiation of heart failure, and this has been made so much simple by Dr. Sajjad and other presentation, what is happening exactly in our body is a defect in the energy balance. And when you take excess of calories, which is more than what is needed for your body, this calorie is supposed to be stored in form of fat in the adipocytes. And these adipocytes are white adipocytes, and they have got pre-adipocytes, there are vessels, there are immune systems, and this is a whole system of organ. Adipocytes is an organ system. Now, depending upon your genetic predisposition, what is happening, if you are taking excess of calorie, and by that means you are taking more than what you needed. This excess of calorie means two things. Your adipocyte is good, healthy. What will they do? They will multiply. And they will not come under the stress. And they will continuously store this fat without any problem. And this is called as obese but metabolically healthy patients. And these patients do not have, they have got proper adipogenesis, they have got increased volume of adipocytes, they have got a normal insulin sensitivity, and they have got no inflammation. So we have got a group of patients who are very obese, they rarely develop heart disease. But in Indian population, somehow or other, this fat mass is dysfunctional. It is less plastic. Consequently, what is happening, this fat, fat cells, they hypertrophy rather than hyperplasia. And they come into the stress. These adipocytes, they do not multiply, they pre-adipocytes, and consequently the vascularity decreases, the adipocyte get necrosed, and further inflammatory cells are loaded into it. And this is what I was talking of lipotoxicity, ectopic, and the lipids spills out of this fat, and it gets deposited into various organs, leading to ectopic lipids deposition, NFLD, insulin resistance, type 2 diabetes, and CVD. So the basic thing is a dysfunctional adipocyte which is extra in your body. Now what happens, if you see this is a fat cell, And if it is loaded with fat and it is not multiplying, what will happen is its endothelium reticulum system will come into the stress. And you know the function of endothelial system is to do a proper folding of the proteins. And there is a unfolding of the protein is there. There is leak of ceramides. These ceramides gets inside the cells and they cause insulin resistance by blocking various insulin receptor signaling pathway. Similarly, these adipocytes, when they get excess of fat and they are not multiplying, what they happen, they get into what is called as a mitochondrial stress. And this mitochondrial stress leads to a lot of oxidative injury. They release a lot of oxidants and they are responsible for further insulin resistance and vascular dysfunction. At the same time, there is in the adipocyte, there is a decreased vascularity because they are growing, but the vessels are not increasing. And subsequently, they get hypoxia, they get fibrosed, they invite a lot of macrophages due to necrosis, and the whole cascade continues, and the patient gets into the metabolic syndrome, what we call it as. So this is the time when we should stop talking about diabetes. We should start talking about metabolic syndrome rather than diabetes if you want to preserve it. So if this is a person, if the fat is multiplying and this person gets the fat in the gluteus and the thigh, this person is going to be a healthy, metabolically healthy person. But the moment this fat is only accumulating on the waist and the legs are thin, which I think in this hall, if you see, most of the people will have a thin thigh and a high paunch. This is what is leading to all the problems of increased leptin, increased insulin, hyperinsulinemia, increased free fatty acid release, decreased adiponectin, increased IL-6, and increased TNF-alpha. And consequently, all the organs are affected by this. So we should not be looking only with glucotoxicity. So conceptually, that's why now we know there is a CKM syndrome, and this is essentially driven by excess. It is / dysfunctional adipocytes. It's not only excess, it has to be dysfunctional. All excess fat is not bad. And this leads to the first organ to be affected is MSLD. And this is the beginner. And consequently, you get everything, kidney, heart, lung, getting affected. So this is very, very important. And if you look at the heart involvement, muscle involvement, how does it happen? You see, once diabetes has developed, the first thing it leads to, you recognize with hyperglycemia. This hyperglycemia leads to advanced glycosylation end products, and it leads to autonomic dysfunction because of diabetes causes peripheral neuropathy, and autonomic nerve is also a peripheral nerve. It leads to microangiopathy. So these are the additional things which once hyperglycemia sets in, and there is a subclinical myocardial necrosis. So once hyperglycemia has set in, you get all these things. At the same time, the bioenergetics of the heart is disturbed because of the mitochondrial dysfunction. This is excessive oxidative stress, abnormal cardiomyocyte function, and calcium homeostasis. And of course, there are certain genetic groups which develop very early. Then there is a RAS activation. Diabetes leads to increase in the activity of sodium-hydrogen co-exchangers. And then metabolic derangements in the myocytes, free fatty acid leaking, which is accumulating into the heart as well as the epicardium, lipotoxicity, lipoapoptosis, and adipokines. So there are gamut of processes which are occurring. Now this diabetes also leads to coronary artery disease, which we discussed, and it also predisposes the person to hypertension. All these things combine to have heart failure. And heart failure is one of the most dangerous complications of heart disease. Now, distinct characteristics of diabetic cardiac atherosclerotic disease, we know from Framingham study and host of other studies that it occurs in 2 to 4 times more. Pathogenetic mechanism we have discussed. This is the commonest type, as I have said, and higher prevalence at a lower age. In Indians it is 15 years earlier and more aggressive because of multifactorial. Diabetic cardiomyopathy, least recognized, thanks to, and what is this condition defined as? The ventricular dysfunction that occurs in absence of coronary atherosclerosis and hypertension. This happens in patients of diabetes because of the muscle defect. And the cardiac muscle should have two functions. One is that it should be contracting efficiently, and then it should be dilating efficiently. And the first thing which affects is it doesn't dilate effectively. Now, once it is not dilating effectively, it is putting pressure on the left atria and other things. And this we call it as a heart failure with preserved ejection fraction. Now, at the end, what happens when the process aggravates, the heart starts failing, and then the pumping stops. But mind it, there should be no atherosclerosis and there should be no hypertension. Of course, they are there, they contribute to the causation. So, early stages, subclinical period characterized by, and this is we rarely recognized, by structural and functional abnormality of the cardiac myocytes, leading to fibrosis, hypertrophy, and cell signaling abnormality. Cardiac fibrosis and stiffness, it is the first, and it is the preserved ejection fraction. And then ultimately there is a diastolic dysfunction, and when you are getting a patient with reduced ejection fraction, this is a patient who is in the terminal stage of heart failure, and very little could be done for this particular patient. So this is the late stage. Diabetes mellitus and autonomic neuropathy, cardiac autonomic neuropathy. This is another very important thing which we tend to miss. It is present in as many as 20% of the unselected patients, and 60%, more than 60% on those who have got advanced disease. Clinical features include, how do you recognize? A person who has got a resting tachycardia. If your parasympathetic eye, cut it down. Parasympathetic is first to be involved because it is a longer nerve. And by your MBBS training, you know, the longer is the nerve, the first it gets affected. And that is why you get a gloves and stockings paresthesia, because these are the longest nerve. Similarly, in an autonomic nervous system, the parasympathetic is the longer nerve, and they get affected first, and you get a defect on the heart rate. Then there is a sympathetic denervation, which are smaller nerves, and they will have a poor response of blood pressure response. So the heart rate is controlled by parasympathetic, and fine tuning is done by sympathetic, and your blood pressure is controlled by sympathetic activity. So sympathetic, once it is lost, you get postural hypotension and other things. So this is the autonomic supply of the heart, and features. And how do you get the symptom? A patient of diabetes coming to you with, डॉक्टर साहब लेट करके खड़े होते हैं तो चक्कर आ जाता है. What is this? और डॉक्टर साहब बैठे बैठे धड़कन होने लगती है, स्वेटिंग हो रही है, इसके ऊपर खूब पसीना हो रहा है, नीचे पसीना नहीं हो रहा है. These are all autonomic neuropathy. Other features include silent myocardial ischemia. Patient को दर्द, ischemia तो ongoing है, but he is not perceiving. सबसे बड़ा प्रॉब्लम है जो आपको ऑटोनॉमिक न्यूरोपैथी है, पेशेंट इज गोइंग फॉर सर्जरी, इंट्रा ऑपरेटिव कॉम्प्लिकेशंस. सडनली पेशेंट विल डेवलप सडन हाइपरटेंशन, सडन ब्रेडिकार्डिया, एंड देयर विल बी, एंड दिस पेशेंट कैन सडनली डाई ऑन द ऑपरेशन टेबल. सो यू शुड बी वेरी वेरी कॉशियस. साइंस इंक्लूड टैकिकार्डिया, ऑर्थोस्टैटिक हाइपोटेंशन, रिवर्स डिपिंग, नॉन डिपिंग, एंड ambulatory blood pressure monitoring will identify this. Orthostatic hypotension is a sine qua non, and it suggests a very advanced autonomic neuropathy. Gold standard is, very few people do it, and you need not do it, but you have to look for simple heart rate variation with respiration on standing, and look for orthostatic hypotension, and that will suffice. And this is called as cardiovascular autonomic reflex testing. Some people are doing it. Test for parasympathetic is heart rate variation with breath or standing, and or Valsalva maneuver. Sympathetic is postural hypotension and with Valsalva maneuver. Mortality and morbidity is an independent risk factor. And what is this? Due to cardiac arrhythmias, silent myocardial ischemia, major adverse cardiovascular event, myocardial dysfunction, sudden cardiac death, and all-cause mortality and cardiovascular mortality. So this is the spectrum of disorder which we find. Heart failure, it arises from a combination of diabetic cardiomyopathy, ischemic cardiomyopathy, as well as cardiac autonomic neuropathy. All these things are contributing to this, and most of the diabetics are hypertensive, so hypertension is also to heart failure. So the most dangerous complication of diabetes regarding heart is heart failure. And in many studies it has been found, I was supposed to show you a study where the prevalence of heart failure in a diabetic is to the tune of 14%, which is only less than peripheral arterial disease. Of course, it's a Western study. And you know, a patient who gets atherosclerotic cardiovascular disease, you calculate the 10-year risk of another event or risk of dying. So this is what I was talking about. But if a person gets a heart failure, the risk of death as compared to atherosclerotic cardiovascular disease is 5 times higher. So the patient of diabetes with heart failure has got a 5 times more risk of dying as compared to patient who has got atherosclerotic cardiovascular disease. And now we have got so many things to reverse the perfusion and other things. But once it is cardiomyopathy, there is very little to say. And whatever you say, whether it is SGLT2 or goal-directed therapy, if you look at the relative risk reduction, it is only 20%, 30%. And if you combine together, still you have got a huge residual risk. And this is exemplified by patient who gets a heart failure, the risk is 10% from the beginning, as compared to those who have got atherosclerotic heart disease. When you say you look at 10% is the upper bound. So you start from here, and once the patient who is failing on goal-directed therapy, the life of the patient is same as the patient of a cancer. 5-year survival is very, very less. So this has to be prevented. Insulin resistance and insulin signaling mechanism along with lipotoxicity, these are the two which are initiating the whole process, followed by the hyperglycemia. So lipotoxicity takes the early thing, and that is why obesity is now becoming very, very important. And not only obesity, it is dysfunctional obesity. And no doubt, whole body DEXA and bioelectric impedance is becoming very, very popular to look at the distribution of the fat. And then, भाई देखिए मेरी गलती नहीं है हेमशंकर जी, नहीं आप ही ने सब वो किया हुआ है. You see, so you've got lipotoxicity which starts first, and then there is a glucotoxicity, and what you are going to get is coronary artery disease, you are going to get diabetic cardiomyopathy, and then cardiac autonomic neuropathy, and this is the sequence of event which is going to happen in this particular patient. So this is in nutshell the heart disease in diabetes which we get. Now what is the conclusion? Heart disease in diabetes, sir conclude कर रहे हैं अब, Dr. Hemshankar. It's not merely atherosclerotic cardiovascular disease, but includes microvascular, cardiac muscles and autonomic nervous system. Lipotoxicity and glucotoxicity contributes to its causation. However, lipotoxicity and consequent insulin resistance is the key to all the problems. Unfortunately, research has not added anything to do a healthy adipogenesis. आप फैट घटाने की बात करते हैं, उस फैट की अगर क्वालिटी इंप्रूव कर दें तो भी एक बहुत बड़ा हो जाएगा. We don't have healthy adiposity. The only tool is lifestyle intervention, exercise and diet, which will cause a healthy adipogenesis. And intervention to this effect should start from the maternal life, early childhood, and no doubt that when you see, for preventing the complications, everybody has to come out, including the social scientists and the town planners, and here comes the importance of social determinants of health. Unless we have got a proper social determinants of health, and this is the typical advisory of American Heart Association, which is the most important statement which I know has come from any society, that you have to look for dysfunctional adiposity and treat it. And this beginning should start from here, essential 8 of life, followed by the moment you identify dysfunctional adiposity, start taking action. Once this has set in, आप सिर्फ खेला खेलते हैं, वो खेला हो बे और कुछ नहीं होता है. मैं सच कह रहा हूँ. Then the things slip out of your hand, and this is the worst stage to treat. So friends, research which we have in our population, we are simply taking Western data and trying to extrapolate, and most of the guidelines from RSSTI, Endocrine Society of India and others are not based on typical epidemiological study. They are based on extrapolation, or the so-called Lipid Society of India. They are simply extending it to these Western population data, trying to manipulate it. Where from this 23 to 25 has come? Have you ever tried to decide? The Western has said that if the BMI is 25, in a male, the fat is 25%. In a female, it is 35%. Do you have any such data in India? But our experts, the so-called experts who are sitting, they will give that. So friends, you have to have all these things if you have to counter the meanness of diabetic heart disease. Thank you for your patient listening.
Thank you, Professor Dr. Madhukar Rai, for your excellent talk. I think since there is a session, there will be no question answer. Just to take home message, he has given everything in detail. But two important things, which he said the first slide, the type 2 diabetes, it is the lipotoxicity which is the start first, rather than glucose, and the type 1 is glucose. And why it is important? In type 2 diabetes, strict control of glucose can control microvascular 80%, not the microvascular. And there the steno 2 type study has confirmed that we must tackle other risk factors like hypertension, dyslipidemia, smoking, everything to control the atherosclerosis. Whereas in type 1 diabetes, it is glucotoxicity which is start factor. So if you control the glucose, we can control the microvascular. Thank you very much.
Thank you very much again. आप सब लोगों को धन्यवाद मुझे यहाँ बुलाने के लिए. Thank you so much.
Thank you, sir, for a wonderful, thought-provoking oration. The next session is a panel discussion, and I would request the moderator of the panel, Professor Dr. K. Lohani, to please come up on the stage. And I would request the chairperson of this session, Dr. P.K. Sinha sir, Dr. Om Prakash, and Dr. Rashmi to come up on the stage. P.K. sir.
Panel discussion. Hello. So, friends, ladies and gentlemen, welcome to the session of panel discussion. Dr. K. Lohani will be moderating the session, and panelists are Dr. Shyama, Dr. Siddharth Singh, Dr. Taskin Ahmed, and Dr. Anand Dev. So, we may have chairs for them. So, we need 1, 2, 3, and 4 chairs. So, Dr. Shyama, Dr. Siddharth, Dr. Taskid, and Dr. Anand Dev, please come on the desk. Are you using PPT?
चाहिए
ये तो लोहानी जी का PPT है।
दे दीजिए।
थोड़ा और इधर कर लो ना। तो थोड़ा इधर कर लेना होगा ना। इसको छोड़ना पड़ेगा। अब दो उधर कर लेंगे। 2 उधर।
ठीक है हो जाएगा।
आप इधर आ जाओ, ठीक। So, Dr. K. Lohani, please. Over to Dr. K. Lohani.
Honorable chairpersons and dear colleagues, at the very outset, I would like to thank Chairman Scientific Committee and my younger brother, Dr. Gagan Gunjan, for incorporating this panel discussion in his scientific program. During this session, we are going to address an issue which is of immense clinical importance in contemporary medicine: obesity and MASLD. As moderator of this panel discussion, I will introduce the topic, and after discussion, I will summarize it also. In between, I will involve our learned panelists one by one for presentation as well as discussion. So without wasting time in formalities, let us come to the point. MASLD, as we all know, is the new name for NAFLD, that is non-alcoholic fatty liver disease. And this change was brought about in June 2023 during International Conference of Hepatology. And this change was accepted and signed by almost every national and international body related to liver. The explanation given for this change is worth noting. They said that the term non-alcoholic is non-committal. It does not signify the etiology of the disease. So they replaced it by a more suggestive term, that is metabolic dysfunction. Secondly, they also said that the term fatty is stigmatizing. Nobody in this world would like to be called fat or fatty. So they replaced it by a more scientific term, steatotic. And that is how the new nomenclature came into existence, metabolic dysfunction associated steatotic liver disease. We all know the prevalence of MASLD is rising at an alarming rate. The situation is so alarming that many people use the proverb, the elephant in the room, meaning a situation which is unexpected and difficult to get rid of. According to a data published in International Journal about a couple of years back, 25% of adult population worldwide have NAFLD or MASLD. In India, the figure is even higher, 38.6%. In patients with metabolic disorders, the prevalence is 58.2%. And worst of all, in pediatric age group, the prevalence is 35.4%. Frankly speaking, we do not need statistics from the literature to realize how common this disease is. Just close your eyes and try to recall if in your OPD, if you advise ultrasonography of abdomen to 10%, about 5 to 6% come out with the report of fatty liver. So that is precisely the situation. Needless to say, MASLD is an important cause of morbidity and mortality. In 20th century, when we were medical students, we were taught that fatty liver is a benign disease. But today, the corollary is true. And in support of this statement, I would like to share with you this very, very important slide, which was published in Lancet in 2024. In fact, MASLD or NAFLD is not a single disease. It is a spectrum of diseases. And it begins with simple steatosis, followed by MASH, that is steatohepatitis on one side, and on extreme side, there is cirrhosis of liver and hepatocellular carcinoma. And in between, there is MASH with mild fibrosis, moderate fibrosis, and severe fibrosis. So gradually, from a benign condition, it becomes a lethal condition. And just look at the top of this slide. On an average, after 15 years, 3% of MASLD patients develop MALO. MALO is a major adverse liver outcome. So it sounds small, 3%, but I explain it. A patient out of 100% of MSSL, that is steatotic liver, 40% develop steatohepatitis after 5 years. And after that, another 25% develop cirrhosis. And out of cirrhosis, another 25% develop hepatic failure and 5% develop hepatocellular carcinoma. So overall, after 15 years, the figure is 3% casualty in these patients. And worst of all, my dear friends, about double of this number in MASLD patient, they develop cardiovascular morbidity and mortality. That is why many people say that MASLD is the surrogate marker of atherosclerotic cardiovascular disease. At this stage, I would like to take a pause, and I will involve, or rather invite, my first panelist, Dr. Siddharth Singh, who is Adjunct Professor of Medicine in Trauma and Emergency at IGMS Patna. He will let us know about the etiopathogenesis of this disease.
Good afternoon, everybody. I am Siddharth from IGMS. And thank you, sir. Thank you, the organizing committee, for inviting me. Sir has already pointed it out that why we named from NAFLD as MASLD. Because the journey, because till now what was the old term that non-alcoholic was misleading, first of all, as well as it was stigmatizing, as the sir has just said, and it implies a blame on alcohol while ignoring metabolic drivers. For example, the obesity, the insulin resistance, and the dyslipidemia. Fatty was replaced by steatotic. As sir said, people did not like to be called, there was a stigma that they have been called fatty, so it has been replaced. Moreover, the shift has been to improve the diagnosis, research, and the patient care, emphasizing on metabolic causes rather than just saying that, oh, it's alcoholic or non-alcoholic. Which type of patient will be considered as MASLD? It is steatotic liver disease and having at least 1 out of 5 cardiometabolic risk factors, that is elevated triglycerides, a low HDL, obesity, type 2 diabetes or pre-diabetes, and high blood pressure. The MASLD commonly associated with metabolic conditions. Those conditions I have mentioned it. It is the obesity, the type 2 diabetes, the high triglyceride, dyslipidemia, hypertension. And if you see this graph, you'll just see the obesity is at about 90%, the type 2 diabetes is about 70%, 68% hypertension, 83% of high triglycerides. The most important amongst this MASLD is to draw your attention to this insulin resistance. That is the root cause of development of MASLD, and it begins with the adipocytes dysfunction. Insulin promotes the storage of fatty acids, free fatty acids, and consequently triglyceride at the adipose tissue level. This activity is due to its anti-lipotic activity in the lipid metabolism. If there is insulin resistance is present, the insulin isn't able to inhibit adipocyte lipolysis, and this determines the release of free fatty acid from the adipose tissue in the bloodstream. And consequently, the excessive pressure in the liver where an excessive biosynthesis of the triglyceride take place. Friends, the source of these fatty acid, free fatty acids from the liver represented by the diet, the de novo lipogenesis, and the adipose tissues, that is about 60%. Excessive accumulation of free fatty acids in the liver considered to be responsible for the pathogenic pathway of the liver fibrosis and formation of reactive oxygen species. This excess of free fatty acids in the liver generates lipotoxic lipids that causes endoplasmic reticulum stress, oxidative stress, inflammation, and apoptosis of the hepatocytes. All these are involved in the formation of reactive oxygen species. Friends, the Guha cells release the pro-fibrotic factors that the TGF-beta, which activates the hepatic stellate cells. The activated hepatic stellate cells migrate to the place of injury, secrete an extracellular matrix, and determine the formation of fibrotic tissue in the liver. The next is the thyroid hormone in the pathophysiology of MASH. Thyroid gland is a small butterfly-shaped gland located at the front of your neck, responsible for the thermogenic, adipogenic, and fat distribution, energy, lipid, protein, carbohydrate, cell metabolism. Thyroid hormones such as triiodothyronine or tetraiodothyronine are important keys for repair as they mediate the cellular differentiation through cell signaling mechanism by interacting with nuclear receptors that have alpha and beta. In the liver, regulate energy and metabolic homeostasis by modulating the export of lipid from the hepatocyte into the bile and the bloodstream, as well as the oxidation de novo lipogenesis, and control hepatic insulin sensitivity and suppress hepatogluconeogenesis. In patients with MASH, it is believed there is an alteration in the normal thyroid activity at the beta nuclear level in the liver, and that is cause hepatic hypothyroidism. The MSLD is associated with most CV events and mortality. Dr. Madhukar sir has just clearly said he has covered everything that needs to be addressed. The prevalence of the MSLD is more common than NFLD. MASLD is associated with more severe event and mortality.
Okay, Dr. Siddharth, thank you very much for precise presentation.
Thank you, sir.
There are 2 or 3 things which needs explanation. So I put it before you one by one, and I seek your comment on it. First thing is about the change in nomenclature. We have already discussed about it is non-committal and it is stigmatizing. But do you really think that it has got more significance than these 2 factors?
Yes, sir.
Is it going to change the management aspect of MFLD? It is going to change.
Yes.
Because previously, a patient with fatty liver on ultrasound who is non-alcoholic was supposed to be a case of non-alcoholic fatty liver disease, and we manage accordingly. Now the criteria is presence of metabolic dysfunctions. So the management is now not only of fatty liver or steatohepatitis, the management now involves management of comorbid conditions also.
Thank you, sir.
The second thing is about the etiopathogenesis. Do you think that metabolic conditions like diabetes, hypertension, dyslipidemia are independent risk factor for this MSLD? Or there is a common factor like insulin resistance, which is hallmark of obesity, which on one hand causes MSLD and on the other hand causes metabolic syndrome and atherosclerotic cardiovascular disease. That is why in my introductory remarks I had said that MSLD is considered the surrogate marker of atherosclerotic cardiovascular disease.
Correct.
So is it true?
Yes, sir. You are absolutely correct, sir. And thank you, sir. You have pointed out correctly. It's a cardiometabolic disease. It involves like the 5 components, as sir has said. It is the obesity, the hypertension, the dyslipidemia, and all. And in case if we should look at the treatment also, it's a holistic approach. It's not should be one.
So now I'm coming to the most important part, which is comparatively a new concept. For last 20-25 years, we were talking about 2-hit hypothesis, that is insulin resistance plus lipotoxicity due to oxidative stress. Then many other factors were included into it, like inflammatory markers, like genetic factors, like gut microbiota, etc., etc. But of late, a new thing has been identified which changed the whole scenario, especially the management. That is thyroid dysfunction in liver. Nowadays they call it hepatic hypothyroidism. I explain it a bit further.
Okay.
Thyroid hormone is known to all of us. Its action is also known to all of us. But what we did not know, many of us did not know, that it acts through thyroid receptors, thyroid hormone receptor, THR, and it is of 2 types, alpha type and beta type. The most of the actions of thyroid hormone is mediated through alpha receptors. This beta receptor is present in the liver, exclusively in the liver, to some extent in kidney and pancreas also, but predominantly in the liver. And it controls two most important functions in liver. One is lipid metabolism in the liver. It is under control of this thyroid hormone through beta receptor. And second is mitochondrial biogenesis. So this is responsible for mitochondrial dysfunction also. And these two factors have been identified in the etiopathogenesis very significantly. And in the management, we will come to know that the newer drug which has been launched last year is directed towards this beta receptor dysfunction. So with these few comments, I thank you once again. And
thank you, sir.
I will request now.
Thank you, sir.
The second panelist, that is Dr. Tashkin Ahmed Reza. He is Professor of Medicine at Katihar Medical College, and he will discuss the diagnosis and differential diagnosis of this condition.
Thank you, sir. Thank you for giving me this opportunity to discuss here. Thank you, organizing committee. Thank you all. Today, here I am to discuss about the diagnosis portion of MASLD, very important topic we all. When we are diagnosing a patient of a particular disease, where patient have clinical findings, patient have some symptoms, patient comes to us with varying symptom and all, but very important is in MASLD, most of the patients are asymptomatic. Very few patients are complaining of like fullness, like upper quadrant discomfort, mild off and on symptoms, maximum it has. The only clinical finding in a patient of early onset is hepatomegaly. In advanced cases, like cirrhosis, we may get signs of cirrhosis, but in early stage, it is only hepatomegaly may found. Most of the times, patient comes us with incidental finding of detection of elevated liver enzymes or USG finding of fatty livers. Other side, if patient with obesity, diabetes mellitus, or metabolic syndrome, if we are looking for, we have to screen the patient for USG for fatty liver evaluation. If it is, then we have to look for the non-invasive testing for fibrosis, like fibrosis 4. If it is having low risk, we have to repeat in 2 to 3 years. If it is intermediate risk or high risk, then we have to consider it for vibration control, transient elastography, or blood test measuring fibrosis markers. If it has the low risk, then we have to plan for repeated 2 to 3 years, or if it is having high risk, then we have to take gastroenterologist opinion and all. Now, fibrosis 4 index to evaluate the advanced fibrosis. It is very simple, very easily available on web portals. Only 4 parameters are required to calculate it: age of the patient, AST level, ALT level, and platelet count. Easily we can fill it on the portal and we get the result. It is the quickest way to evaluate probability of fibrosis in a patient. higher positive and negative predictive values it has, and it is very cost effective. It has low cost in the setting, but it has few limitations, like it is not confirmative assessment for fibrosis, and it needs further evaluation through vibration controlled transient elastography or liver biopsy. The cutoff value is less than 1.3. It rules out the fibrosis. If it is between 1.3 to 2.6, it are indeterminate, and if it is more than 2.67, it reflects high probability of fibrosis in a patient. On the other side, VCTE, that is vibration controlled transient elastography, very commonly known as FibroScan. It is dedicated system used to evaluate advanced fibrosis, and it is based on vibration controlled transient elastography technique. Mainly it has two parameters. One is liver stiffness measurement, which is applied for non-invasive quantification of liver fibrosis, and another is controlled attenuation parameters, that is CAP. It is for non-invasive quantification of liver steatosis. Now, the understanding CAP and LSM score, that is higher the CAP score suggests higher amount of fat in the liver, where the finding will be less than 2.237. It is graded as 0. Amount of liver showing fatty changes is less than 10%. If it is 238 to 260, it graded as S1, and the fatty changes is considered 11 to 33%. If it is 261 to 292, graded as S2, and the amount is 34 to 66%. If it is more than 293, graded as S3, and the fatty changes has been considered more than equal to 67%. Another is higher LSM score suggests higher amount of fibrosis in liver. LSM score is less than equal to 7, stages as F0, shows absence of fibrosis in liver. If it is 7.1 to 10, it is stage for F1 shows that mild fibrosis is there. 10.1 to 13 reflects moderate fibrosis. 13.1 to 16 reflects severe fibrosis. If it is more than 16.1, graded as F4, shows which may have cirrhosis. Liver biopsy is only test that can prove a diagnosis of an ASH and reveals both fat and inflammation in tissue and clearly shows how severe the disease is. Liver biopsy can show fibrosis at earlier stages than elastography can. It is invasive, has potential complications, and is prone to sampling errors. These are the few limitations with that. Recommended only if patient is more likely to have an ASH and with advanced fibrosis, or if other test shows signs of advanced liver disease or cirrhosis in a patient. Steatotic liver disease have subclassifications. Number one is metabolic dysfunction associated steatotic liver disease, that is MASLD. If MASLD and increased alcohol intake in a patient, it considered as MET-ALD, where the weekly intake is 140 to 350 gram in females and 210 to 420 gram in males, and average daily intake is 20 to 50 gram in females and 30 to 60 grams in male. Another is alcohol associated liver disease, that is ALD, And the other hand, specific etiology of SLD like drug-induced liver injuries. Second is monogenic disease like liposomal acid lipase deficiencies, Wilson's disease, hypobeta lipoproteinemia, inborn metabolic errors should be considered, and the miscellaneous like hepatitis C virus infections, malnutrition, celiac disease, and then if it has no specific etiology, it is cryptogenic SLD should be considered.
Okay, thank you, Dr. Reza, for discussing the diagnosis and differential diagnosis. There are 2 or 3 things which again needs a bit more explanations and your comment. Number one, right from our student life, we were taught that to diagnose a disease, we have got 3 things in our hand: history, clinical examination, and laboratory investigations. History is obvious. History of diabetes, hypertension, dyslipidemia, obesity is obvious. Clinical finding. Do we have any idea about, on clinical basis, how to suspect that this patient is having fatty liver or steatotic hepatitis or cirrhosis? Can we differentiate it clinically? How?
Sir, most of the patients of MASLD are asymptomatic. Basically, there has no particular symptoms. Very few symptoms may present that are not very much significant, like fullness of abdomen, like something like heaviness in the upper quadrant, like discomfort. And if patient is having, most of the patient comes with the incidental report of LFT derangement like SGLT2, SGOT or SGPT derangement, or USG finding of fatty changes in the liver. That is the incidental most of the time. If I advanced stage, definitely we will get the symptoms on the patient like distension of abdomen, like pain in the abdomen, something like that. And patient have the findings of cirrhosis like splenomegaly, like signs of portal hypertension like ascites and many of that.
If a patient develops jaundice, from the beginning patient had pain abdomen and hepatomegaly. Now the patient develops jaundice. So what do you think, at what stage this patient could be?
Sir, in the it must be in the advanced stages, sir.
Must be steatohepatitis.
Yeah,
must
steatohepatitis.
With or without fibrosis.
Yeah, with fibrosis. Yeah.
And the enzymes will go even further higher, and they say that the AST-ALT ratio will be altered, etc., etc. Okay. Second thing is, you have already discussed very nicely, how important is to find out whether this patient has got fibrosis or not. Why it is important, and how to judge it, you have already said, by a clinical method or a formula, computerized formula, that is FIB4 index, or by fibroscan. And in fibroscan, a value less than 7 means no fibrosis, 7 to 10 F1, 10 to 13 F2, 13 to 16 F3, and more than 16 is cirrhosis of liver. So that is a very important thing. Yes. I will request every colleague that if you come across a patient of steatotic liver disease or MASLD or NFLTB, what do you want to call it, must go for it. If the FIB4 is indeterminate or high, must go for it.
Yes.
And in the report, you get 2 parameters. So one shows the fat content, and the second one shows the fibrosis level. And the report is in kilopascal. So you must go for it. This is very important, because for the management, it is not only enough to diagnose ultrasonographically that patient has got fatty liver or the comorbid conditions. Most important thing is to find out whether your patient is having fibrosis or not. If yes, then what is the degree of fibrosis? Because management nowadays is based on the degree of fibrosis. Yes. And the third thing, just to make it more clear, along with MASLD, a new term was also coined, which is called MET-ALD. This MET-ALD, the term is used when a person has got metabolic dysfunction, as well as he consumes alcohol above prescribed level. The prescribed level is 30 gram daily for male and 20 gram daily for female. If consumption is more than double of this limit, then the patient goes in the category of alcoholic liver disease. But if it is between the prescribed limit and less than double, it is MET-ALD. So we should keep this thing in mind, because There is nothing like water cell compartment, MASLD or ALD. Because most of the time in our clinical practice and in our day-to-day life also, we know that we are having cardiometabolic risk factor. At the same time, we consume or our patient consume alcohol also. So we must make this clear whether patient is in the stage of MSLD or MET-ALD or ALD. Thank you very much. And now I request the third panelist. Third panelist is Dr. Shyama. She is additional professor of medicine at AIIMS Patna. And she will be discussing the management of obesity by lifestyle modification, weight reduction, as well as anti-obesity drug and bariatric surgery. So Dr. Shyama, please.
Thank you. Good evening, everyone. Thank you, Lohani sir, and the organizers for giving me this opportunity. So I'll be discussing today the approach to MASLD management via lifestyle and some pharmacotherapy. So once we have seen that patient is having a MASLD, how we are going to approach? So first is obviously lifestyle modification, which includes obviously weight reduction via diet control as well as exercise. So in diet, usually we will be recommending Mediterranean type of diet, which is mainly plant-based diet, which increase fruit and vegetables with whole grains, increasing nuts as snacking, and then patient will be advised to use less amount of red meat and refined carbohydrate and sugars. And then there is exercise. Exercise, as it is, one patient should be advised for exercise at least more than 150 minutes per week or 300 minutes per week, which comes to at least 30 to 1 hour per day, at least 5 days in 7 days, 5 days a week. So once we have, and we'll aim at weight reduction of at least above 5%. Which will 5 to 10%, which will help in reduction of the fibrosis, inflammation, as well as fat content. हाँ सर, नहीं सर ये अभी तीनों बढ़ जाएगा सर. आप जो बोल रही हैं इसमें. हाँ. So weight loss through lifestyle modification in MASLD is, if we are targeting at least 5%, it will reduce inflammation. With less than more than 3%, mostly fat content is reduced. For after that, there is a reduction in inflammation, and if we target, if weight reduction is more than 10%, it causes fibrosis regression. But the main challenge is to sustain the weight loss, and patient having more than 10% weight loss have a less than 10% chance of sustaining the same weight loss. So after lifestyle modifications, we come to pharmacotherapy. We will be giving, there are nowadays, we have access to several of the weight reducing drugs, which started from the, which mostly came into 2020s, the drastic weight loss that causes more than 15% to 20% of the weight loss. Earlier there was, our target is more than 10%, and earlier the drugs were causing less than 10% of the weight loss compared to placebo. So anti-obesity drugs, when they are indicated, so they are indicated whenever patient has a BMI of more than 30 kg per meter square, that is patient comes in the category of obesity, or patient is overweight, that is more than 27 kg per meter square of BMI with at least one weight related comorbidity present. Their medications are to be used alongside the reduced calorie diets as well as the increased physical activity. So what are the pharmacotherapy available to us? So it started with Orlistat, which started in 1999, and then we have come to semaglutide and tirzepatide. Semaglutide causing more than around 15% of weight loss, and tirzepatide causing around 20% of weight loss. In semaglutide was FDA approved in around 2020. So these are the drugs. So tirzepatide, semaglutide was approved by CDSQ, approval is 2021, and then it is mostly for weight reduction, it is mostly subcutaneous dosing is approved. and dose is usually it is increased every 4 weeks. So orlistat was earlier used, now semaglutide, and then comes the tirzepatide. Semaglutide is GLP-1 agonist, while tirzepatide is dual agonist, that is GLP as well as GIP agonist. Semaglutide is started with 0.25 mg subcutaneous once weekly, which has to be gradually escalated to a maximum dose of around 2.4 mg, and can be reduced to 1.7 mg subcutaneous weekly if dose of 2.4 mg is not tolerated. And it is an injectable agent, and tirzepatide is started at 2.5 mg subcutaneous weekly, and the maximum dose to be reached gradually by increasing by 2.5 mg every week to 15 mg subcutaneous weekly, and the maintenance dose may include 5 mg, 10 mg and 15 mg. If patient cannot be, if weight loss is not achieved through other methods, we can go even for bariatric surgery is indicated, and it is indicated only in individuals with BMI more than 40 or in individuals with BMI more than 35 with obesity related health conditions, which includes diabetes, sleep apnea and MASLD that was included in previous speaker's talk. Thank you.
Thank you, Dr. Sharma, for a wonderful description of obesity management, which is perhaps the most important aspect of MAFLD management. Though you have shown the slide, but again I want to highlight one thing, that is weight loss. Weight loss is the cheap and best way to treat this condition. You must have seen in the slide that if you achieve 5% weight reduction, inflammation, that is MASH, is resolved. And if you achieve 10% weight loss, even fibrosis is resolved in 50%. So that is a wonderful thing. And in fact, most of the anti-obesity drugs is based on this formula, tirzepatide or semaglutide. They reduce more than 10% weight. That is why they are effective against fibrosis. So if a drug does not reduce 10% weight, it is not going to be effective. So that is the clue. I'm repeating this point, that whether you are using anti-obesity drug or you are doing anything, weight reduction and lifestyle modification is very, very important. So and sustained weight reduction. In the other part of your slide, there was a
less than 10%,
a graph which shows that less than 10% reduction is sustained only in less than 10% individuals. And less than 5%, more than 5% is seen only in 30%. So we have to work on weight reduction, and we need sustained weight reduction. So that is one thing. Number two, about anti-obesity drug. In last two sessions, Dr. Gyan Prakash and Dr. Sajjad had discussed tirzepatide and semaglutide and their comparative pros and cons in detail. So there is no need to go into detail. Yes. But one thing I would like to highlight here, in context of MASLD, which should be preferred? Both speakers have proved that tirzepatide is better, and they have given a genuine reason for it also, because it is dual agonist. It works on GLP-1 receptor as well as GIP receptor. So there's no doubt about that, it is superior. But in context of MASLD and obesity, semaglutide should be preferred. Why? The next speaker will tell you. Because semaglutide is a medicine which was approved for the management of diabetes in 2017, then for 2017, if I remember correctly, and then in 2021 for obesity, and now in 2025 it has been approved for the treatment of MASLD also. So if you use semaglutide in these patients, I'm not saying that overall it is better than tirzepatide, but in MASLD patient, semaglutide has got an upper hand because it targets all the three targets of your management. And now in this era of tirzepatide and semaglutide, what is the role of bariatric surgery? Is it still
no, sir, it is equivalent to bariatric. Weight loss is almost contemporary.
So gradually bariatric surgery is taking a back seat, but it is still there, and how it is done and why it should be done, only surgeon can decide. So thank you, Dr. Sharma, very much.
Thank
and
you,
now
sir.
I request the fourth panelist and fourth speaker, Dr. Anand Dev, and he will tell us about the most important aspect, that is management of MFLD by drugs.
Good afternoon, everybody. I am Dr. Anand Dev from IGMS Patna. I will be dealing with the pharmacotherapy of MSALD. So, off-label medications are many, as for example, vitamin E, pioglitazone. Pioglitazone was shown to be effective in the PIVENS trial in 2010. Then there are dual PPAR agonists like saroglitazar that was approved by DCGI in 2020. Now we have newer drugs like resmetirom that was approved by US FDA in 2024. Then we have semaglutide, as now sir has discussed, that had got accelerated FDA approval in August 2025. Now coming to the detailed list of the off-label drugs which are used in NFLD, MSALD, metformin, ESL gives insufficient evidence, NICE not beneficial, Asia Pacific not beneficial, AISF not mentioned, and ASLD not beneficial. Vitamin E, ESL says it has got insufficient evidence, NICE recommends it for use regardless of diabetes, then Asia Pacific says it's not beneficial, AISF insufficient evidence, ASLD, American Association for Study of Liver Disease, it recommends it for the use in non-diabetes mellitus, biopsy proven NASH, this is very important. Then we have PPAR gamma agonist, that is pioglitazone. ESL says consider its use in selected diabetic patients. NICE says consider pioglitazone in adults regardless of diabetes. Asia Pacific says insufficient evidence in Asians. AISF again insufficient evidence. ASLD recommends pioglitazone in biopsy proven NASH. So all these associations have mixed recommendations. Then PUFA not beneficial, NICE again says insufficient evidence, Asia Pacific not beneficial, AISF not beneficial, ASLD not beneficial. Pentoxifylline again nobody is recommending, or ESL says it has got insufficient evidence. And GLP-1 is insufficient evidence, NICE insufficient evidence, again all of them are telling insufficient evidence. Then ursodeoxycholic acid, ESL not beneficial, NICE against not beneficial, And obeticholic acid, ESL says it has got a scarce evidence, NICE says doesn't mention it, again Asia Pacific doesn't recommend it, AISF doesn't recommend it, ASLD again says it has got insufficient evidence. Silymarin again not recommended. Statins, ESL says safe but not beneficial, NICE again safe, all of them are saying statins are safe but not beneficial. Now coming to saroglitazar, it is a dual PPAR agonist. DCGI in 2020 approved saroglitazar in NFLD. All of us know it is a dual, that is alpha and gamma PPAR agonist. It's indicated for NASH and NFLD. It significantly reduces steatosis and liver enzyme inflammation. These recommendations were given after the phase 3 trial evidence that was driven by biopsy. And minimal duration of treatment for saroglitazar is 12 months. Now, resmetirom was the first drug for MSALD that was given FDA approval in March 2024 under the accelerated approval pathway. It is indicated for adults with metabolic dysfunction, associated steatohepatitis and fibrosis stage F2, F3 without cirrhosis. So, lot has been discussed about liver like this thyroid-like metabolism in liver. So, in case of MSLD, liver is in hypometabolic state like this hypothyroidism. So, to be this again, this resmetirom has not to be used solely, it has to be used with diet and exercise for the treatment of adults with MSALD. So, what are the dosing recommendations of the resmetirom? It has to be started on 80 milligram orally once daily Alternative dosing is 100 milligram once daily, but may be considered based on clinical response and tolerability. It can be administered with or without food. No dose adjustment is required for mild to moderate renal or hepatic impairment. Now, semaglutide, lot of discussion on semaglutide, then tirzepatide. So, semaglutide was given FDA approval in August 2025. All of us know that it is a GLP-1 receptor agonist, is a highly effective pharmacological therapy for metabolic dysfunction associated steatotic liver disease. It has shown significant liver fat reduction, inflammation, improvement, and liver fibrosis resolution. Phase 3 trials indicate high dose semaglutide, that is 2.4 milligram, significantly improves MASH, making it a key evidence-based option for patients with moderate to advanced liver fibrosis and metabolic comorbidities. But no discussion is complete without mentioning tirzepatide. So theoretically, tirzepatide has got an upper hand compared to semaglutide, because theoretically, if we see, tirzepatide is acting on it has got GIP receptor agonism also, and GIP receptors are present more on adipocytes. So what tirzepatide is doing, it is helping in a way in the redistribution of the fat. The glucose there, that glucose is entering in the adipocyte. Because of that, triglyceride synthesis inside the peripheral adipocytes is increasing. Because of that, the flux of the free fatty acids to the liver is decreasing, and because of that, there is that basic pathophysiology that so many free fatty acids are going to the liver and they are contributing to the fat accumulation there is getting addressed. So one way this is happening, other way, since it is GLP-1 agonist also, so it is increasing satiety and it is creating a calorie deficit. So both ways it is covering. So theoretically, tirzepatide has got an upper hand, but in literature, available literature, we are not finding this. All the available literature are pointing towards semaglutide, more tilted towards the beneficial effects in MSLD. Maybe in future, we will get more recommendations or more research for tirzepatide related to MSLD. So summary.
Okay, thank you, Dr. Anand Dev. I just take up all the three aspects quickly. The first one, the off-label medication. First of all, let me make it clear, what does it mean, off-label drug? Off-label drugs are drugs which were approved for some other indications, but it is being used in some other indication. Sometimes I explain it by a song, तू प्यार है किसी और का, तुझे चाहता कोई और है, तू पसंद है किसी और की, तुझे मांगता कोई और है. That is off-label drug. It is used when you don't have a proper treatment, in the hope that something is better than nothing. And the most popular off-label drug in MSLD have been vitamin E and pioglitazone. After PERSONALIZATION study, which were published in 2010, until 2020 in India and 2014 world over, this remained the most popular off-label drug for the treatment of MSLD. But it did not get approval by FDA. In fact, none of the drug mentioned by Dr. Anand Dev has got approval except GLP-1 receptor agonist semaglutide. And none of the off-label drug could get that recommendations. Why? Because you need to fulfill 5 criteria. It should improve steatosis, it should improve inflammation, it should improve enzymes, and it should improve fibrosis. And on top of that, its side effect profile should be acceptable. So only semaglutide is the drug, I mean the GLP-1 receptor which were used as off-label drug has now been recognized as a approved treatment. Otherwise, no drug could get that approval. So we should not get confused between, what is off-label and what is the treatment. The second drug is seroglitazar. This drug has got a very bad luck. It has been approved by Drug Control General of India for the treatment of MASLD or NFLD since 2020. But till date, it has not been approved by US FDA. And only Donald Trump can tell you why it is not approved. Right? So till date, you have to treat these conditions America के permission से, American दवा से. Or if you treat it on your own wisdom. But the drug has got one limitation. I'm talking about the scientific reason. When the drug was approved in India, that time, this drug had enough evidences in favor of resolution of MASH. But there was not enough evidence for the resolution of fibrosis. Perhaps that is why it was not approved by FDA. But now we know, last 5 years, the company which is promoting this molecule has gathered enough evidence now that it is effective against fibrosis also. And now the whole thing is on the table of US FDA. And by the end of this year, they will consider whether to grant permission to this drug or not. So wait till December. Regarding the newer 2 molecules which were approved in 2024, resmetirom, everything we have discussed, how it works and why it has been launched and etc. etc. So this is perhaps the breakthrough treatment in the management of MASLD. And again, I make it clear that semaglutide versus tirzepatide, which is better, perhaps the answer is tirzepatide. So far diabetes obesity is concerned. But when it comes to MASLD, it is only semaglutide which has been approved by US FDA. Tirzepatide is not approved for this indication till date. So we need not get confused which is better. In MASLD patient, only semaglutide is approved. And this drug is also approved for diabetes and obesity. That is why I said that it has got an upper hand over tirzepatide in MASLD patient. Otherwise, dual agonist will be always better than a single receptor agonist. And so with these comments, I thank you once again. And I would like to conclude so this is the summary. We all know MASLD has been used as an abbreviation. MASLD is metabolic dysfunction associated steatotic liver disease. A stands for association of at least one cardiometabolic risk factor like diabetes, obesity, hypertension, high triglyceride, low HDL. And screening or diagnostic tests like ultrasonography, FIB4 and fibroscan are very, very important. Lifestyle modification and weight reduction are first line management, but sustained weight reduction is a major challenge. And Drug Control General of India approved saroglitazar in 2020 for the treatment of NFLD NASH. I had prepared this slide in 2023. And that time we had no US FDA approved drug. Saroglitazar was the only approved drug. So only that medicine has been included in this slide. But then as we have been discussing again and again, in 2024, resmetirom has been approved and 25 semaglutide has been approved. Let us see how resmetirom should be used. What should be the treatment protocol? And European Association of Liver and Diabetes and Obesity have proposed a guideline in 2024. And they say that MASLD patients are divided into 2 categories. One with F2, F3 fibrosis. Patient who have got F2, F3 fibrosis. In these patients, resmetirom should be used. Again, I repeat it. F2, F3 fibrosis, not cirrhotic patient, not F4, not 0 and F1. So F2, F3 with MASH, the drug is indicated. Otherwise, it is wastage. And if patient has got fibrosis to the extent that it can be diagnosed as cirrhosis, then the only answer is liver transplantation. You can ask me, then what should we do with 0 and 1 fibrosis patient? These patients require lifestyle modification, weight reduction, and treatment of comorbidity like diabetes, hypertension, dyslipidemia, etc. And review every 1 year. The day you see that it has entered into F2 or F3 category, start resmetirom. This is 2024 guideline. That time, semaglutide was not in the picture. In 25, it came into picture. And where it should be used, it can be used as a replacement of resmetirom. Everything else is same. But they have also very categorically said that we must treat the associated condition like diabetes, dyslipidemia, and obesity. For diabetes, GLP-1 receptor agonist is the choice, or SGLT2 inhibitor is the choice. We can also use insulin and metformin if and when it is indicated. For dyslipidemia, statin is the choice. If statin alone is not enough, then we can add one drug. Abroad, it is eicosapentaethyl. In India, it is saroglitazar in this situation. And for obesity, we have been discussing it, which drug we all know, and bariatric surgery is also an option. So this is how we manage MASLD as per guideline. And the take-home message is very, very straightforward. The current epidemic of MASLD is reshaping the field of hepatology all around the world. Old beliefs are taking backseat. New evidences are pouring in. And as the organizers have given the name, we are literally on a crossroad. Whether we should forget the older things, or we should continue with the older thing, or we should adopt the newer things. Obesity, in spite of all ifs and buts, is perhaps the most important factor against MASLD, and managing obesity through lifestyle, diet, exercise, is crucial for preventing and managing MASLD. In some cases, pharmacotherapy and bariatric surgery might be considered. And again, I repeat, the drug of choice as on date is resmetirom, as approved last year. If you find it costly, or if you find it not available, the semaglutide is also a costly drug, is the second choice. If both these drugs are costly or not available, then the answer is our own seraglitazar. And if for any reason you don't want to use this drug, the best off-label drug as on date is SGLT2 inhibitor. With these few words, I conclude my talk. Now the session is open for comment. First of all, Dr. Hemshankar is waiting for some time.
Sir, thank you very much for doing all these moderation and other things. The take-home message was very clear. F4, nothing, except the liver transplant.
Exactly.
Right? So whenever the patient is in F3 level, you just ask him to be in the line of liver transplant, because that takes in India at least 2 to 5 years.
Yeah.
The availability and everything taken together. So just ask the request them only for one thing, socially, that be in the pipeline. You cannot get a liver transplant immediately today and tomorrow. Exactly. So nothing like that. So that is one. F4, no drugs is needed, no drug is required except for your lifestyle. Lifestyle is the inherent component, so we need not discuss. Obesity is the inherent component, need not discuss. Have limitations. Now you said about the semaglutide and tirzepatide. Tirzepatide is a drug which came later on, right? So you wait for some time, because right now even during the talks of Sajjad and all that, they have shown the ways that tirzepatide has got a better reduction of the fat content is concerned, including the liver fat. Though this has been already in the picture, and these are many papers on this guidelines. So we can't say that semaglutide, because it was available and in USA approved, because of that only. It was a longer component, right? Sir, if you go by the US FDA,
6 months, another drug will also get the approval.
As majority of us are following, only looking towards the western side, US FDA is nothing, just you wait, you have your own experiences.
So sir, thank you very much,
in
sir.
India is doing all these things.
So
over to PK Singh.
Yes, sir. Thank you very much. And thank you, Dr. K Lohani, for giving such a nice moderation. And thanks to the panel personnel, Dr. Siddharth, Dr. Taskir, Dr. Anand, and Dr. Shaibal for such a nice presentation. So we close the session.
Thank you.
Thank you, the moderator, Dr. Lohani sir, and all the panelists and the chairpersons. We will now disperse for lunch. We are running half an hour behind time, so to catch up on that, we will start our post-lunch session at 2:30 sharp.
Dr. Jyoti Kumar Dinkar, please come on the dais. Dr. K Lohani, Dr. Neeraj Kumar, Dr. Jyoti Kumar Dinkar, I welcome all the chairpersons and speaker Dr. K Singh. Please, sir, come.
I would like to invite Dr. K Singh sir to give a talk on topic beta cell protection strategies from bench to bedside. Over to you, sir.
Thank you, chairpersons. Distinguished dignitaries on the dais, fellow clinicians, faculties across different states, and my dear delegates from across Bihar and Jharkhand. It is a privilege to stand before you today in Rajgir, a land that has for centuries been a center of learning and enlightenment. Today, we gather not just to discuss a disease, but to define our strategy against an epidemic that challenges every corner of our healthcare system. For decades, our clinical focus has been primarily glucose-centric. We have spent our careers chasing the number, the HbA1c, the fasting blood sugar, the postprandial spikes, but as we advance in 2026, the science is telling us quite clearly, hyperglycemia is merely the symptom. Beta cell failure is the disease. By the time we see that first diagnostic rise in glucose, the engine of the pancreas has often already lost 50% of its functional capacity. If we are to truly change the life of a diabetic patient, we must move from simply managing the symptoms to aggressively protecting the cell. In this session, we will journey from the bench, where we look at the molecular smoking gun of microRNA 375 and the silent crisis in mitochondrial ERA stress, to the bedside, where we apply incretin-based therapies and early intervention strategies to shield what remains. We will discuss why some cells don't just die, but simply forget who they are through de-differentiation, and how we as clinicians can help them find their identity again. As someone who has seen the public health landscape of Bihar from the director's chair to the clinic floor, I believe that future of diabetes care lies in the precision diabetology. Let us spend the next few minutes looking beyond the glucose strip and into the life of beta cells, because if we save the cell, we save the patient. And let us begin. Beta cell protection strategies from bench to bedside, a translational framework for preserving and regenerating pancreatic function. The paradigm shift. Modern diabetology is moving beyond simple glycemic control and exogenous insulin replacement. The unifying threat, both type 1 autoimmunity and type 2 glucolipotoxicity, diabetes converges on progressive dysfunction and apoptosis of beta cell. So the new imperative is actively protect, reprogram, regenerate the endogenous source. Diabetes management is transitioning from late stage symptom management to insulin replacement, like insulin replacement, to early disease modification and cellular preservation. Beta cells are uniquely susceptible to metabolic and immunologic stress due to their intense energy demands and naturally low antioxidant defenses when we compare it with liver. As there is more beta cell stress, there is beta cell functional loss. So, a shared in point, both type 1 and type 2 diabetes ultimately converge on the progressive dysfunction, dedifferentiation and apoptosis of beta cell mass, and ultimately there is less beta cell functionality. As you see in the diagram, when metabolic flexibility and compensatory mechanism of mitochondria and endoplasmic reticulum suffers, and there is beta cell exhaustion and beta cell death, as dead bodies are more exert more weight, the tip of balance goes in favor of diabetic situation. Chronic exposure to elevated glucose and non-esterified fatty acid nephas create a toxic microenvironment for beta cells. Beta cells inherently possess 30% less superoxide dismutase and 15% less catalase glutathione peroxidase than liver cells, making them highly susceptible to reactive oxygen species accumulation. Toxic lipid intermediates like ceramides trigger endoplasmic reticulum stress, calcium depletion via SERCA downregulation, and localized inflammatory cascades. This is the pictorial depiction of status of mitochondrium in diabetic state and in health. Chronic high glucose alters mitochondrial morphology, reducing crystalline and shifting the balance of dynamics. This disruption severely lowers the ATP-ADP ratio, that is, more ADP is there and less ATP is there, more ADP is there and less ATP is there, preventing the closure of potassium-dependent ATP channels and halting calcium-dependent insulin exocytosis. Impairment of fusion proteins and overactivation of fission proteins leads to fragmented depolarized mitochondria. Elevated uncoupling of protein 2 dissipates energy as heat rather than the beneficial ATP, simultaneously modulating reactive oxygen species signaling. So mitochondrial dynamics and cellular energy crisis is there due to altered dynamics. Under severe stress, beta cell aberrantly expresses normally suppressed genes like LDHA and MCT1, as any nervous person does the things what he should not do. Glucose metabolism diverted away from mitochondrial oxidative phosphorylation toward lactate production, severely impairing glucose-stimulated insulin secretion. Dysregulated signaling strips beta cell of matured identity markers and elevates stress markers like LDH1A3, reverting them to a progenitor-like state, that is de-differentiation. So how will we, the defenses will work, fortifying defenses? Some role of antioxidants like N-acetylcysteine, alpha-lipoic and polyphenols show a strong preclinical efficacy in neutralizing superoxide and hydrogen peroxide, protecting against structural damage. Reactive oxygen especially H2O2 serve as critical second messenger essential for normal glucose-stimulated insulin secretion. There is therapeutic challenge. Over-administration of antioxidant can inadvertently block physiological ROS signaling, interfering with the beta cell's natural ability of release of insulin in response to glucose. So excess of everything is bad. As you see in the diagram, ROS in physiological amount serves as second messenger for glucose-stimulated insulin secretion, whereas chronic ROS in excess leads to oxidative damage and beta cell dysfunction. Preclinical meta-analysis demonstrate that GLP-1 receptor agonists like exenidine, exenatide, semaglutide strongly protect beta cells, yielding a pooled mean difference of 0.1 in apoptotic rates. The forest plot of the analysis of 22 studies show robust clear advantage of using GLP-1 receptors in diabetes, especially in type 2 diabetes. We can think that these GLP-1 receptor agonists protect against glucolipotoxicity. Chronic supraphysiological receptor activation raises concern about long-term cellular adaptation and functional exhaustion. But I will like to mention the effect these GLP-1 receptors exert in the system. Although they stimulate for insulin secretion, they also maintain the health of beta cells. They shield and protect. They promote the positive factors for beta cell longevity and survival. Decades of cellular research on beta cell apoptosis, immunology, and metabolic reprogramming have culminated in an inflection point. We are now witnessing the translation of these micro-level survival mechanisms into macro-level clinical breakthroughs. Focus shifts from isolated cell in petri dishes to human regulatory approvals and global treatment paradigms. As target is beta cell, which is under attack, there are biomarkers which can tell us years before development of clinical diabetes. As beta cells die and rupture, they release their cellular contents, including massive amounts of microRNA 375 directly into the bloodstream. The circulating microRNA 375 acts as a smoking gun left at the crime scene of cellular destruction. Detecting elevated microRNA 375 levels in blood provides a definitive, early, and highly specific marker of active beta cell failure. I will like to mention that at this moment of time, this test is not available in the panel of laboratories because its cost is forbidding. But hopefully it will come down and we will utilize it in near future. This slide is dedicated to the breakthrough in reform of the management of diabetes mellitus. When beta cells from a diabetic patient are transplanted into healthy liver, dedifferentiated beta cells also start working normally in the improved environment, and this is the finding which has given the breakthrough for these reforms in management. In type 1 diabetes, there are 3 stages. Stage 1, presence of 2 or more islet and autoantibodies, but normoglycemia. When there is dysglycemia, it is stage 2, and when there is clinical onset of diabetes, it is stage 3. Redefining type 1 diabetes into these progressive stages provides the essential framework for testing disease-modifying therapies before irreversible cellular destruction occurs. The onset of stage 3 type 1 diabetes must be reframed as an immunologic and metabolic emergency. The immediate peri-diagnostic period is a critical golden hour where maximum residual beta cell mass can still be rescued. Capitalizing on this requires a concerted effort between clinical trialists, the drug approving authorities, and pharmaceutical companies to push therapies that show positive C-peptide outcomes into full regulatory approval for stage 2 and 3 disease. Teplizumab is a golden molecule. It is anti-CD3 monoclonal antibody which has been, commercial name is ZILD. It has been approved in late 2022 as a capstone to nearly 3 decades of clinical trial intervention. The very first disease-modifying therapy approved by FDA for type 1 diabetes, specifically designed to delay the onset of a stage 3 type 1 diabetes in adults and children, identified at stage 2. It is useful in stage 2. Successfully administered to nearly 170 adults and children up more than 8 years of age to date, ushering in an era of active immune modulation to preserve endogenous beta cell survival. Phase 1 and 2 clinical data demonstrates the functional reversal of diabetes utilizing human pluripotent stem cell differentiated into mature glucose-responsive beta-like cells. Cells are engineered to resist immune destruction via CRISPR-mediated HLA edits and encapsulation in biocompatible hydrogel microspheres. In selected type 2 diabetes patients, the therapy achieved medication-free normoglycemia in type 2 diabetes. In type 1 diabetes also, it drove a 40 to 60% reduction in insulin requirements. How will we validate the preservation? C-peptide is a surrogate endpoint. Aggregate patient level data from 21 randomized control trials, more than 2,900 people had participated. 55% C-peptide preservation was there, which amounts to 0.64% HbA1c reduction. Although HbA1c reduction is minimal, it looks like that, but this preservation of residual beta cell has a massive clinical implication. Preserved C-peptide strongly correlates with a reduced frequency of severe hypoglycemia and long-term microvascular complication due to its cushioning effect. When there is low sugar level, these endogenous insulin secretion shut down and severe hypoglycemia is prevented. Future medicine depends on the personalized medicine. No two person is same, their genomes are different, and every person needs a precise medicine. Which diabetic will need immunotherapy, which one metabolic protectors, and which will regenerative, and which one will be modified and combined effort. So, ultimate goal is achieving synergistic protection that balances cellular rest, metabolic flexibility, and active regeneration. There are also emerging molecular targets beyond incretins, like inhibiting ALDH1A3 activity, which restores identity, and promoting METRNL that blocks transdifferentiation. So, friends, we have decoded the molecular mechanisms of beta cell failure and translated them into actionable clinical therapies. The era of merely replacing insulin to manage hyperglycemia is ending. The future of diabetes lies in actively preserving, protecting, and restoring the life and metabolic flexibility of beta cells. So the future horizon, a multimodal paradigm. The beta cell is no longer viewed simply as a failing organ to be bypassed, but as a dynamic entity that can be protected, reprogrammed, and regenerated. Understanding identity loss, ER stress, and autophagic self-defense provides the blueprint for survival. GLP-1 receptor agonists and emerging pathways inhibitors act to actively shield cells from glucolipotoxicity. Teplizumab and CRISPR-edited stem cell isolates prove that immune evasion and functional reversal are clinical realities. The ultimate goal, a functional lifelong cure driven by endogenous cellular preservation. So, protect beta cells, protect patients. Thank you.
Dr. Pramod, we will have the question answer session in the end of the session. So thank you very much for your nice presentation. Now I request Dr. Bharat Bhushan from Bhagalpur. He will be discussing CKD in diabetes. We all know Dr. Bharat Bhushan is Professor of Medicine, retired from Bhagalpur Medical College.
Respected chairperson and my senior and junior colleagues, thanks to scientific chairman Dr. Gagan Gunjan, who inviting me to stand on this platform on CCDSICON. Basically, CCDSICON is a conference, which means CC means kuch karo, D means देखो, S means सोचो, I means इत्मीनान से. My topics is CKD in diabetes. This CKD and diabetes are two common problems in clinical practice. And this CKD is also known as DKD or DNP. करो तो देख लो तो हाँ
और इससे पॉइंटर से भी होता है इससे
वो इससे हो जाएगा हाँ क्या करना
ये आगे
इधर
हाँ
आगे कौन होगा
ये
कहाँ होगा यही बोलो नहीं
यहाँ
तो हाँ कहाँ होगा
ऊपर
हाँ
सर से भी ये कीजिए ये वाला नीचे से
This DNP is a clinical syndrome characterized by 3 P. Number 1 P is persistent proteinuria, second P2 is pressure raised, and third P is progressive decline in GFR. Basically, albuminuria, hypertension, and renal dysfunction are the 3 features of DNP. Regarding GFR, GFR is a filtration marker, accurate measurement of renal function. GFR is equal to 140 minus age multiplied body weight divided by 72 multiplied plasma creatinine. Normal GFR is 80 to 120 ml per minute per 1.73 square meter. Based on GFR, 5 stages of CKD. Stage 1, GFR more than 90, that is good. Stage 2, that is GFR is 60 to 90, that is sign of kidney damage. And stage 3, that is 30 to 60, and stage 4, 15 to 30, is known as CKD. And stage 5, when the GFR is less than 15, is known as end-stage renal disease. This DNP is a most serious cardiovascular complication. This is a leading cause of ESRD. 20% of DNP, that is dyslipidemia, is present, 50% diabetic retinopathy, and in 70% of cases, there is a hypertension is present. This DNP causes cardiovascular morbidity and mortality, 50% high risk of mortality than non-diabetic nephropathy. And 45% of CKD is due to diabetes, rest is due to hypertension, glomerulonephritis, pyelonephritis, obstructive, analgesic, or contrast-induced nephropathy. Inflammation is a potential risk factor which accelerates the rapid progression of DNP. Regarding risk factor, there are multiple risk factors. Age, old age, ethnicity, black, 3 to 6 times more common. Obesity is increased risk of CKD, and genetic predisposition, that is a family history of DNP, poor glycemic control, poor lipid control, that is dyslipidemia, and hypertension and smoking, which accelerate the risk of CKD. Regarding pathology, a patient of diabetic after 15 to 20 years develop DNP in 3 ways. First is there is a glomerular damage. Second, there is ischemia, and this ischemia is due to hypertrophy of afferent as well as efferent arteriole. And third, there is a ascending infection, that is a pyelonephritis. This glomerular damage is due to metabolic effect, is due to hemodynamic changes, that is IGP, intraglomerular pressure is 35 to 45 millimeter. There is a hypertrophy and sclerosis of glomerulus, and there is a thickening of basement, glomerular basement membrane protein. There is a loss of negative charge, and there is an increased size of the pores, that is 5 to 10 or 20 mm. Regarding pathogenesis, basically 5 stages of DNP. In stage 1, there is a functional changes. That is activation of PKC pathway, protein kinase C pathway, that causes increased level of prostaglandin. This prostaglandin dilates the afferent arteriole. And second, there is a activation of RAS, which causes constriction of efferent arterioles. So this dash means dilatation of afferent arteriole and constriction of efferent arteriole, that causes increased renal blood flow, that causes intraglomerular pressure, that is 35 to 45 millimeter, and that causes glomerular hyperfiltration. Second stage is there is a functional structural changes. In structural changes, there is a activation of polyol pathway and polyol pathway. In presence of aldolase reductase enzyme, which is present in glomerulus and tubules, this enzyme converts glucose into sucrose and fructose. This sucrose and fructose is a more potent glycation agent. So glycosylation of basement membrane protein, that causes thickening of the glomerular basement membrane, and that causes glomerular hypertrophy and sclerosis. The exercise-induced microalbuminuria is the only clinical evidence of renal involvement. Next, stage 3. Stage 3, that is a subclinical nephropathy, in which there is a microalbuminuria. The albumin excretion is 30 to 300 milligram albumin per 24 hours, and this is the early sign of DNP. That is a clinical onset of renal impairment. In stage 4, which occurs 15 to 20 years of the age, that is overt or clinical nephropathy, in which there is a macroalbuminuria, in which the albumin excretion is more than 300 milligram per deciliter, and this is the hallmark of DNP. And stage 5 occurs after 20 years of age, that is the end-stage renal disease. In end-stage renal disease, the glomerular filtration rate is less than 15 ml per minute per 1.73 square meter. There is a uremic symptoms. In uremic symptoms, there is anorexia, nausea, vomiting, pallor, and hypertension. There is an increased level of creatinine, urea, and blood urea nitrogen. This blood urea equal to blood urea nitrogen multiplied 2.14. And there is a decreased creatinine clearance, there is a decreased GFR, there is a altered calcium metabolism, and so there is a hypocalcemia and hyperphosphatemia, there is a dyslipidemia, there is a hypertension, and that needs renal replacement therapy, that is a dialysis or renal transplant within 2 to 3 years. Regarding clinical diagnosis, A, B, C, D, E, F, G, H is the clinical manifestation of diabetic nephropathy. A stands for anemia, A stands for acidosis, and this anemia is due to A, B, C, D, E, F. A stands for absorption of iron decrease, B stands for blood loss increase, C stands for cell survival decrease. The RBC lifespan is decreased. Normally 120 days, but it becomes 90 days, 80 days. and D stands for dietary deficiency, E stands for erythropoietin, which is secreted by juxtaglomerular apparatus, and that is responsible for erythropoiesis, that is decreased. And F stands for platelet function is decreased, as there is no quantitative changes of platelet, but there is a qualitative changes of platelet. So the platelet function is reduced. And second, A is acidosis. Basically, this acidosis is due to increased hydrogen ion concentration and decreased bicarbonate concentration. Hydrogen ion concentration that is due to not secreted hydrogen ion at PCT level, and bicarbonates level decrease as not absorbed at DCT level. And second, B stands for breathlessness, and this breathlessness is due to fluid overload or due to pulmonary edema. Second, C stands for CVD, as this CVD, cerebrovascular disease, is due to Mia syndrome. Mia syndrome is M stands for malabsorption, I stands for inflammation, and A stands for atherosclerosis. This Mia syndrome, which is present in CKD patient, is responsible for cerebrovascular disease. D stands for dyslipidemia, and D stands for dystrophy. And this dystrophy consists of osteomalacia, osteoporosis, and osteitis fibrosa. This osteomalacia is due to deficiency of calcium, and osteitis fibrosa is due to secondary hyperparathyroidism, that is increased parathyroid hormone. E stands for encephalopathy. In uremic encephalopathy, there is a impaired consciousness, there is a irritability, and there is a convulsion. F stands for friction pericardial rub, that is a pericarditis, and a special characteristic of this pericarditis, uremic pericarditis, is this pericarditis is painless, and there is a hemorrhagic pericarditis. G stands for GIT manifestation, and GIT manifestation is anorexia, nausea, vomiting. And H stands for hypertension. 70% of the cases there is a hypertension, and there is a hyperkalemia. This hyperkalemia is due to metabolic acidosis. When there is a metabolic acidosis, hydrogen ion comes out from intracellular cell. So there is an increased level of serum potassium. Regarding lab diagnosis, there is a decreased level of hemoglobin, decreased level of calcium, decreased level of bicarbonate, decreased level of pH, decreased level of creatinine clearance, and decreased level of GFR. There is an increased level of urea, creatinine, burn, and there is an increased level of lipid profile, and there is an increased level of serum potassium. In ultrasonography, there is a small size kidney, there is a loss of corticomedullary differentiation, and there is an increased echogenicity that indicates medical renal disease. Regarding diagnosis of DNP, basically this is diagnosed by urinary biomarkers, that is classical biomarkers or newer markers. Classical markers are urinary albumin excretion, which is the gold standard for the diagnosis of DNP, that is the microalbuminuria and macroalbuminuria. And newer biomarkers are transferrin, IgG, IgM, cystatin C, that is a podocyte, microRNA, type 4 collagen, 8-oxodeoxygenosine, and ceruloplasmin, monocyte, chemoattractant protein, and neutrophil, gelatinase associated lipocellin. These newer biomarkers are more sensitive. This is more sensitive than albumin to detect renal damage. These newer biomarkers are important for early diagnosis of CKD, even microalbuminuria is absent. Regarding prevention and treatment, ABCD E is the general management, that is the lifestyle modification. A stands for alcohol reduction. B stands for bulk reduction, weight loss or BP reduction. C stands for cessation of smoking. D stands for diet, that is decrease sodium diet and decrease protein diet. Protein requirement is 0.5 to 8 gram per kg body weight, and E stands for exercise. Regarding treatment of renal dysfunction, there is a tight glycemic control either by oral hypoglycemic agent or insulin. Insulin is the best choice. Among oral hypoglycemic agent, metformin is contraindicated. Pioglitazone, that causes fluid retention. Insulin is the best choice. Both hypoglycemia and hyperglycemia are more frequently occurs. Second is the tight BP control. Tight BP control by A, B, C, D. A stands for AC inhibitor, that is Pril, ARB, losartan, telmisartan or olmesartan, or A stands for alpha blocker, B stands for beta blocker, C stands for calcium channel blocker. Third generation calcium channel blocker is amlodipine, but best choice is fourth generation calcium channel blocker, that is cilnidipine, as cilnidipine acts on both alpha and afferent arteriole and efferent arteriole. C stands for calcium channel blocker, and D stands for diuretics. Potent diuretics is important, like furosemide or torsemide. And tight lipid control by low lipid diet or lipid lowering therapy, that is statin. There are 7 sali of statin. One is the Atorva, Lobha, Simbha, Prabha, Fluva, Rusubha, and Pitabha. And there are 4 sala of effect of the statin. First is the S, stabilization of plaque. So plaque is less likely to rupture. A stands for anti-inflammatory effect. L is a lipid lowering therapy effect, and A is antioxidant. Next is the drug controlling proteinuria, that is ABCD. A stands for AC inhibitor, ARB, or aldose reductase inhibitor, that is 150 milligram per day, and that inhibit polyol pathway, so prevent glycation of glomerular basement membrane protein. B stands for beta blocker, C stands for calcium channel blocker. This verapamil and diltiazem are the calcium channel blocker which lower the excretion of protein. And diuretics, aldosterone, that is spironolactone, this decreases proteinuria when used alone or in combination of ACE inhibitor or ARB. But long use of this drug causes hyperkalemia, so limits the use. Next is the correction of metabolic acidosis by sodium bicarbonate or 1/6 molar lactate, and phosphate binders, vitamin D analog, vitamin D, and correction of anemia by iron, oral iron or parenteral iron or EPO or blood transfusion, renoprotective drug, Torvin or style cysteine, prevention of uremic gastritis by H2 blocker, and antibiotics. Cefoperazone is the best choice. Avoid aminoglycoside or avoid non-steroidal anti-inflammatory drug. Hepatitis B vaccination is essential. And last treatment of advanced DNP, that is end-stage renal disease, is RRRT. Medical is dialysis, and surgical is renal transplant. Indication of dialysis is AEIOU. A stands for acidosis, E stands for electrolyte disturbances, I stands for intoxication, O overdose, U uremic encephalopathy or urea level increase, creatinine level increase. For patient with T1 diabetes mellitus, combined pancreas or renal transplantation is essential. And last slide, protect your kidney in diabetes by tight glycemic control, the fasting blood sugar less than 100, postprandial blood sugar level is less than 140, and by tight BP control, that is the SBP is less than 130, DBP is less than 80, and the BP less than 140 by 90 is good, less than 130 by 90 is better, and less than 120 by 80 is best. Thank you.
Speaker is Dr. Vijay Kumar, Additional Professor, Department of Cardiology, AIMS, and he is speaking on personalized diabetic care. Thank you, sir.
Good afternoon, respected chairpersons, respected faculties, distinguished guests. At the outset, I would like to pay my sincere regard to our guardian, mentor, and founder president of CCDSI, Professor A.N. Rai sir. I must salute his zeal and enthusiasm that sir is sitting and listening each and every lecture right from 8 a.m. today morning. I also like to thank the organizing committee members, and a special thanks to Dr. Gagan for providing me this opportunity. Now the topic which I have been given is personalized diabetes care, what is feasible and how. Whether it is feasible or not, so in discussion till now, we have almost witnessed that while summarizing the talk of Madhukar Rai sir, sir has very well said that in type 2 diabetes, lipotoxicity usually starts earlier than glucotoxicity. And 1 decade or 1.5 decade earlier, the treatment of diabetes was one fits all or one size fits all. But in last 1 or 1.5 decade, there is a paradigm shift in the management of diabetes. In terms of, we have shifted from glucocentric approach to weight-centric approach. We have shifted for considering the comorbidities, and we have taken a special consideration of comorbidities while treating the diabetes. And how precision medicine is important, that in next 10 to 12 minutes, I shall be discussing how it is important or how it is practical to be implemented. So overview of my talk will be the global burden of diabetes. I am not going in detail because each and every speaker has highlighted. Need for the personalized diabetic care. What are the key components? Care in elderly. How do we approach in a multidisciplinary way? And what are the future perspectives considering the role of AI or the inclusion of AI in almost all the fields of medical science, particularly gadget-based therapies in diabetes also. We are now going to be more dependent on AI. As we all know that there are rising incidence, mortality, long-term disability, and economic burden as far as diabetes is concerned, particularly affecting younger age groups, and roughly 1 in 9 adults live with this disease. To your surprise, nearly 44% they are usually being unaware till the complications develop or till they report to their physicians with some sort of complications of diabetes, not only for the management of diabetes, but for the complications of diabetes. So, what is personalized care? Personalized care is, of course, patient-centered approach, major shift from one-size-fits-all strategy to individualized treatment, tailored to an individual's unique genetic makeup, lifestyle and personal preferences, and aims to improve glycemic control and reduce long-term complications. Why it is needed? Because there is heterogeneity, disease heterogeneity, multifactorial pathophysiology, variable response to therapy, and there are of course different risk of complications and different strata of the patients. Why it is needed? It aims to provide holistic care addressing comorbidities, mental health, emotional well-being. It enhances overall quality of life, and shared decision making ultimately improves patient motivation and adherence. The key components are individualized glycemic targets, comorbidity guided drug selection, hypoglycemia risk assessment, weight-centered management, lifestyle personalization, of course cardiovascular and renal risk reduction, and integration of different diabetes technology and gadgets in the treatment armamentarium. Individualized glycemic targets, it is the preferred over a uniform A1C goal that I will discuss in next few slides. It balances optimal glycemic control with safety, stricter targets for younger patients with low hypoglycemia risk versus somewhat less stringent targets for those with comorbidities or limited life expectancy. So we are moving beyond universal glycemic targets, and we are deciding the glycemic targets depending on the patient's variation or patient's clinical outcome. Similarly, if we are assigning A1C goal, now we should not be so stringent. We should be liberal for different strata of patient. If patient is in good health and function, low treatment risk and burden, then of course we should have a tight glycemic control. But those older adults with very complex, poor health or with limited life expectancy, we should be somewhat liberal. So we are moving from stringent control of A1C to somewhat less stringent control of A1C, depending on the strata of the patient, depending on the comorbidity of the patient, and depending on the compelling indications to manage or to control the blood glucose. So there are certain situations which favor more stringent goal, and there are certain situations which favor less stringent goal. These are the situations where more stringent goal, like short diabetes duration, chances of hypoglycemia where there is less chances of hypoglycemia, low treatment risk and burdens, pharmacotherapy with other cardiovascular, kidney, weight or other benefits, without any cardiovascular complications or few or minor comorbidities. But where severe life-limiting comorbidities are there we usually favor for less stringent goal. So we have to be comorbidity guided selecting the drug. We have to be comorbidity guided rather, and we have to customize the treatment depending on the comorbidity. So presence of coexisting conditions to be evaluated, and selection of glucose lowering therapy that provide organ protection in addition to the glycemic control, they should be selected. So depending on the cardiovascular outcome, SGLT2 inhibitors or GLP-1, they have demonstrated cardiovascular benefits, while additive benefits of combined therapy may be considered for high-risk individuals for additive reduction of adverse events. In chronic kidney disease also, there are other compelling indications, and we have to be customized therapy. In heart failure and obesity, again, we have to decide depending on whether patient is having preserved ejection fraction or reduced ejection fraction. So depending on the cardio-renal continuum, we have to decide or we have to customize the therapy. Again, hypoglycemia risk assessment must be done to be assessed at every visit, especially in patients on insulin or sulfonylureas. Prior hypoglycemia is the strongest predictor of future episodes, and major risk factors include age, CKD, incidence of CKD, intensive insulin therapy, hypoglycemia unawareness, and missed meals. So coming to the CGM metrics, we have to decide the time in range of between 70 to 180 should be, the target should be more than 70%. So we have to be familiar with the various CGM metrics also, and what are the targets for time in range or time below range or hypoglycemia chances, that we have to be to follow the CGM metrics also. Weight-centered management, again, more than 5% weight loss improves hyperglycemia, and more than 15% in many of the trials, they have induced almost remission of diabetes. So we have to be weight-centered management also. Strategic drug selection, particularly in obesity, we have to be somewhat selective, and preferred agents, as already has been discussed, that GLP-1 RA or dual incretin agents and SGLT2 inhibitors, they are to be preferred. Again, personalized nutrition therapy should be there. Diet plans are to be tailor-made or to be customized to match patients' metabolic needs and cultural eating patterns. Individualized calorie patterns for weight management, and individualized therapy based on different ASCVD risk, that is to be followed. Individualized physical activity is also to be advised depending on the patient profile, age, physical capacity, or complications such as neuropathy and heart disease. Depending on that, we have to customize, or we have to advise the customized physical activity, or we have to allow the physical activity depending on the comorbidity or depending on the patient's profile. Then technology, we have to again implement the technology. Younger populations, they are more techno-savvy and they are more compliant with the technology in diabetes. So they are more techno-savvy and they are to be encouraged to implement different gadgets to monitor the therapy or monitor the complications. Continuous glucose monitoring, again, it is therapy based on individual glycemic patterns, providing time in range metrics, hypoglycemia alerts, glycemic variability, and postprandial spikes. Automated insulin delivery systems, they are also to be followed. It improves A1C, increased time in range, and significantly reduce hypoglycemia and glycemic variability. Personalized care in elderly also required, like they have to be somewhat relaxed glycemic targets, simplified treatment regimes to increase adherence, and focus on functional status and quality of life is also to be there. Again, multidisciplinary approach, team-based care models, behavioral support, integrated comorbidity, or improved patient engagement, depending on taking the help of other colleagues, other specialty, psychiatry, surgery, gynae. So multidisciplinary approach is to be there, particularly in GDM. We must witness on diabetic foot also. We have to take the help of our surgeon colleagues, and in GDM our gynae colleagues and all those. It is a team-based care model, and integrated management of comorbidity are also to be done. Coordinated specialist input for cardiovascular disease, chronic kidney disease, obesity, and mental health conditions. Personalized lifestyle and behavioral support, usually multidisciplinary approach, they improve the patient engagement, and there is a shared decision making and regular monitoring based on this multidisciplinary approach. What are the future perspectives? Depending on the inclusion of AI and all those, precision medicine in diabetes includes genetic and biomarker guided therapy, advanced diabetes technologies such as fully closed loop insulin delivery systems, and next generation CGM are to be advised. AI and machine learning to guide personalized treatment decisions, integration of digital health platforms, development of novel therapies including dual and triple incretin-based agents with greater efficacy. So to summarize, precision medicine is the demand of the, or rather the need of the hour, and in the current era of evidence-based management and AI inclusion, now it is the best therapy. It's the time to recognize disease heterogeneity and shift to individualized care. Individualized glycemic targets and comorbidity guided drug selection are the key pillars. Cardiorenal risk reduction is a major therapeutic goal, and we are moving towards a multidisciplinary and patient-centered approach. Thank you for your patience listening. Thank you, sir.
Both previous speakers, Dr. K Singh and Dr. Bharat Bhushan, to come over the dais, and it's time for question answer. So if any query to any of the aforesaid three speakers, most welcome. Any query or any comment on aforesaid three talks?
सर भारत सर आपसे पूछ रहे हैं ये लीजिए ये दीजिए ये दे दो ये दे दो ये लो ना ये लो ना
And the second question is that are these biomarkers available in India? The biomarkers you told.
Sir is asking regarding the biomarkers which you have discussed, whether these biomarkers are available in India or not, that sir is asking.
In India, not available.
Sir, few of the biomarkers are available and few are not available,
Not
that sir is
available.
saying.
Okay. I don't think they are available in India. The fibroblast, that is one, and the
Classical available.
kidney injury
Or
molecule,
newer-
that is also not available.
Not available.
Yeah. The other things are available as we do the serum creatinine and all blood urea, and these are not the biomarkers, but we consider it as a security that what is the condition of the kidney injury. Yes.
So we close this session because there is no query. And I request all the three speakers to collect them.
Thank you, sir.
I would also request the speakers and chairpersons of the last session before lunch to come to the felicitation place dais. Next, we will be having a workshop on exercise workshop on diabetes, which will be conducted by Dr. R.K. Modi. To chair this session, may I call Dr. P.K. Singh, Dr. P.K. Singh sir, Dr. T.O.P. Singh sir, and Dr. Amrinder Kumar Singh. Please come on the dais sir to chair the session. P.K. Singh sir, Dr. T.O.P. Singh sir, Dr. Amrinder Kumar Singh. Bhagalpur. Aye. Okay. For a change, we will request the chairperson to sit on the front because it's a workshop. Nahin pe, sir.
इसमें तो रहेगा ही ना। मैं यहाँ रख देती हूँ, सर को बोलूँगी मैं आज उठा लूँगी। ठीक है।
वहीं बैठ जाएंगे। हाँ 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 हाँ, तो उस तरह का चेयर वो लेना पड़ेगा। एक और एक और एक और ठीक 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 शुरू करें क्या? Respected Chairperson, we are thankful to the organizing committee of CCDSI who has given us this great opportunity to present this workshop on exercise. So sir, can we start the workshop? Thank you, sir. So to begin with, first I want to introduce my team. I am Dr. R.K. Modi, clinician. Organizers, please go to the back rows. Organizers. Workshop is on, sir. Please take your seat. Workshop is on. Please take your seat, sir.
If you want to talk, then go outside the hall.
So let me introduce my team for workshop of this exercise. He is Dr. Vijay and Dr. Suman. Yeah. So we all are going to share our views of exercise, and we will also demonstrate simple exercises that we can adopt and we can do in our regular practice. So to start with, let us understand the difference between physical activity versus exercise. Any body movement that requires energy is a physical activity. It is spontaneous, unstructured, and not necessarily focused on fitness, like walking, gardening. But on the other hand, exercise is planned, structured, repetitive, with goal of improving or maintaining physical fitness, like as we go to gym, join a fitness class, and go for sports. So there are numerous benefits of exercise, and I will not explain because everybody sitting here, they prescribe exercise to their patients, and they also do the exercise, and they know well what are the multiple benefits of exercise. But I must mention, it is good for mental health, weight management, injury prevention, it decreases risk of fall, improves sleep quality, and also reduces the risk of non-communicable disease, diabetes, and some cancer. It should be enjoyable, or it is more enjoyable when you do it in a group with your friends. It has got different form that we are going to demonstrate to you. Make a cocktail of different exercise, learn and adopt, build it a habit, sustain and continue so that you can enjoy more of life, you can give more to life. So coming to the first types of exercise, we know aerobic, very common, everybody knows aerobic, that is endurance. Activities that uses large muscle groups are rhythmic and can be sustained over time. And we can see Dr. Vijay and Dr. Suman, they are walking. It is a form of aerobic exercise. They will run also. That shows that it is also a form of exercise. So there are other like cycling, swimming, and many other aerobic activities are there. Anaerobic exercise are high intensity, short duration exercise where energy comes from anaerobic glycolysis. Here we don't dependent on oxygen, but anaerobic metabolism goes there and energy is fulfilled. We will discuss in detail about anaerobic activity later on. The third variety is resistant activity. We can see activities that cause muscle to work against resistance. Suppose I am sitting on this chair. This is chair and I am sitting. So can you draw this chair? Yes. Still I am sitting. So I am doing it against resistance. And this is actually resistance exercise, and we are doing it and we are using our body weight as a resistance. So this is resistance exercise. It shows you the double force is doing against force, this is resistance. And there are other forms of resistance exercise like resistant band. Can you show the resistant band? Yes. Yeah. This is resistance band exercise. So moving further, we have other varieties like flexibility, activities that improve range of motion of joints and muscle. These are flexibility exercise, and yoga is a very good example. Can you show something? Flexibility. This is Shashankasan, Ushtasana, that is Kushtasana. Yeah, this is Kushtasana, that is Shashankasana. Okay. So these all are flexibility exercise, and we can also show you some simple stretching. Stretching, tricep stretch, can you show? Yes. This is tricep stretch. Then shoulder stretch. First left, then right. Okay, very good, thank you very much. Oh, moving over to other form, balance maintenance, balance exercise, activities that improves stability and prevents fall, This is very, very important, and especially for elderly. It looks simple, but it is difficult to practice. You all can practice. It is really not very simple. So, few exercise like heel to toe walk is a important balance exercise, and in details we will show many, and that we can learn and adopt. HIIT is another variety, that is high intensity interval training. These are the short bursts of intense activity alternating with rest. This resistance exercise and high intensity interval training has anaerobic phase of exercise within it. So, we have seen that this aerobic, resistance, flexibility and balance are actually all types of exercise that is being mentioned in the various guidelines. So, all are important that we know, but we are looking for all in one. So, Vijay, can you tell me one exercise where you have all varieties of exercise within it?
Yes, sir. In yoga, it is Surya Namaskar. It has resistance, cardio, flexibility as well as balance.
Very nice, very nice. So, that is very good. So, can you tell something about yoga or demonstrate it?
Yes. Surya Namaskar is salutation to the sun. There is about 12 postures and 24 steps in one round of Surya Namaskar. In first half round, right leg leads, and in second half round, left leg leads. So, let's start Surya Namaskar.
Yes.
Om Mitraయ Namaha. Om Rave Namaha. Om Suryaya Namaha. Right leg behind. Om Bhanve Namaha. Om Khagaya Namaha. Om Vishnu Namaha. Om Hiranyagarbhaya Namaha. Om Aditya Namaha. Left leg forward. Om Adityaya Namaha. Om Savitre Namaha. Om Arikaya Namaha. Om Bhaskaraya Namaha. This one is half round of Surya Namaskar. Now second half of Surya Namaskar, which will be led by left leg. So let's start. Om Mitraya Namaha. Om Rave Namaha. Om Suryaya Namaha. Left leg behind. Om Bhanve Namaha. Om Khagaya Namaha. Om Bhukre Namaha. Om Hiranyagarbhaya Namaha. Om Aditya Namaha. Right leg forward. Om Adityaya Namaha. Om Savitre Namaha. Om Arikaya Namaha. Om Bhaskaraya Namaha.
Excellent, Vijay. You have demonstrated Surya Namaskar very nicely, and I also joined. I don't know you know it or not anyway. So, it is over now.
Yes, sir. Actually, sir, in all backward posture,
Yes.
one should breathe in, and in all forward posture, one should breathe out. And in one position,
That is-
one should hold his breath.
Okay. So, is it over or?
Sir, yes, sir. Actually, sir, it has, we have done cardio, flexibility, resistance, balance, all are over there, sir. But one exercise was missing, that was anaerobic.
Okay.
If we do fast Surya Namaskar, then, sir, it will include anaerobic exercise also.
Okay. You mean, yeah, sure, I will allow. You mean when we do Surya Namaskar with moderate intensity, it is an aerobic activity, but when you will do a vigorous Surya Namaskar, it will become an anaerobic type of exercise. Okay, you can go through. Chairperson, can I allow him? Okay. So he will do 72 asan in 1 minute. Thank you, yaar. It is really difficult. So,
I did 3 rounds of Surya Namaskar. One round had 24 asana. So I did 72 asana.
in 1 minute.
I have calculated it at home. It takes about 52 to 53 seconds.
Even less than a minute. So in a minute he did 72 asanas. So congratulations, Vijay. So do you want to relax?
Yes, sir. After Surya Namaskar, one should always lay down in Shavasana to let heart beat and breathing normal.
So that was the message. Every time you do, or when you finish the Surya Namaskar, you definitely go in Savasana. That is the message. Okay. Okay. Sir, actually we allotted only 30 minutes. So
No, you are correct, but just let me go over. If permitted, can I go over there?
Yeah, sure, sir. You can go and perform also. It is a workshop.
I am doing Surya Namaskar, sir, from 8 years, sir.
मैं तो 8 दिन से
Sir will also show how to do sermon.
Actually, I also, sir. Yes, sir. You say, sir, after first warm up our spine and body. So I. Yes, sir. Yes, sir. Yes. 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 Yes.
I may not be that flexible. Don't worry.
Yes, sir.
Don't worry about the flexibility. आप उनको देख के मत चिढ़िए.
'Cause our message was to show all type of exercise in just Surya Namaskar.
Yeah. Exactly. Yes, no, anybody.
Everybody.
If anyone have big back problem, let's avoid it.
Spine, uncontrolled hypertension, and a cardiac problem. Yes.
So, thank you, Dr. Vijay. Now you please relax. Now moving forward, there is another type of exercise which has got all 4 modalities: aerobic, resistance training, balance and flexibility. So this all exercise in one is Tai Chi. Tai Chi is an ancient Chinese tradition that evolved as exercise. It is actually meditation in motion. And what really matters is energy. We all are surrounded with energy. Energy is floating everywhere in the surrounding. And there is energy is behind your movement, and your intention guides the energy. There are 4 main forms, 4 qualities of energy. These are floating, spreading, gathering, and sinking. Remember, you are surrounded by energy. Gather it and float, spread it out, do it again and again. That is meditation in motion. So please, Dr. Suman, please show a few steps of Tai Chi.
Just calm and relax yourself. Imagine the whole energy is around you, surrounding you, and you're floating in this energy. Breathe, relax, relax your body, and slightly bend your knee. Hold the energy, gather it down, float it up, spread it out, and gather it back inside your body, and sink. Gather your energy up, float it up, spread it out around your body, and gather it back inside your body, and float it up and down and sink. From left side, spread the energy out and gather inside your body. Spread the energy out and gather it back. Spread the energy out and gather inside your body. From right side, spread the energy out and gather it back inside your body. Spread it out and gather it back inside your body. Spread the energy outside your body and gather it back. Now from left knee, float and sink. Spread the energy up and gather it inside your body. Float and sink. Spread the energy up and gather it back inside your body. From right side, again, float and sink. Spread the energy up and gather inside your body. Float and sink. Spread the energy up and gather inside your body. Now, float the energy up, turn to left, gather inside your body and feel it and sink. Float the energy up, left, gather inside your body and sink. Again, gather the energy, float it and gather it inside your body and sink. Now, feel the energy in the form of gift. Spread all around your body. Again, receive the energy in the form of gift. Spread it all around your body. Again, receive the energy in the form of gift. Spread it out. Now, right side, receive the energy in the form of gift of God. Spread it all around your body. Again, receive the energy in the form of gift. In the last, again, gather your energy up, float it up, spread it out, gather it back, and sink and be happy.
Thank you very much. Very nice. So this was wonderful demonstration, and this was Tai Chi. And truly speaking, this is the first time I could understand that Tai Chi is an exercise which is a complete exercise showing all aerobic conditioning, resistance training, balance and flexibility. So all in one, it seems to be very easy, but it is very difficult to do. And if you do it or if you learn it, that will become a real exercise for your body. So thank you very much, Dr. Suman. Moving forward, we have already discussed the intensity of exercise. Two intensities are there, moderate intensity and vigorous intensity. Moderate intensity uses aerobic metabolism. And in moderate intensity exercise, one can talk but not sing. So Vijay, what you are doing?
I am jogging, sir.
You are jogging, very nice. You are doing it very gently. You are doing moderate activity. That's why you responded me very nicely. I can understand it. Okay. So how do you feel here in Rajgir?
I feel very honored, sir, to be part of workshop of CCDSI of practice.
Okay, thank you very much. So you told that you are feeling great because you are honored here and participating in workshop. Oh, now you are doing it vigorously. So, Vijay, can you repeat the sentence? Try to repeat, Vijay. Okay, thank you, thank you. You are unable to repeat. So, he was doing vigorously he was doing exercise vigorously, so it was not possible for him to repeat or complete a sentence. So this is the difference between moderate intensity exercise and vigorous intensity exercise. Thank you very much. So these are the various forms of aerobic activities: walking, cycling, swimming. This all are forms of aerobic activities. There are three phases: warm-up phases, aerobic phases, and cool-down phases. So I request, when you do aerobic activity, please think in that way, that you must end with cool-down phase. And we have already discussed about the intensity. Now coming to the fuel. In the first few minutes of exercise, most of the energy comes from carbohydrate metabolism. I have a good slide for that. At moderate intensity, listen, now you can understand what is moderate, what is severe. So think in that way. During moderate intensity exercise, in beginning, in up to 70 minutes, glucose is the main source of energy. But beyond 20 minutes, till any time, fat becomes the predominant source. But when you talk about the high intensity activities, vigorous activities, even after 20 minutes, glucose becomes the main source, because fat oxidation cannot fulfill ATP demands. So fuel choice depends on intensity and not on calorie density. Speed of ATP production is fast for glucose with less oxygen consumption, but with fat, ATP production is slow and oxygen consumption is more. So moving forward, this is a good slide, Vijay. Can you give some comment on this?
Yes, sir. This is a very good slide, sir. Sir, I have one question, sir, regarding this slide. Suppose, sir, if anyone is doing workout regularly and this adverse weather condition like very hot day or thundering or very heavy rain, one should do exercise.
Yeah, I understood your questions, that you want to know that in adverse condition, a person who is doing regular physical activity, going regular outdoor activities, should continue and do it in a rainy day or in a sunny days. No, definitely not. Whether in adverse condition, one should not go outside for doing exercise, but my message is you must continue exercise. But how? You change the place. You select indoor activities like jogging. What you did here, we can do at home even in a winter days. You cannot get exposed to cold. You can do it in the house. So jogging, either moderate intensity or severe intensity, we can practice in the house. Then other is yoga. Yoga is also very good, and we have seen what is aerobic yogasan, what is anaerobic yogasan. We can practice that also in the under the roof. And third is treadmill walking. That is very popular, and it has got many advantages, and the most common advantage that it is all weather friendly. But I must tell you there are few disadvantages, like altered gait mechanics, because belt moves under feet. There is risk of fall, especially in elderly. A patient of neuropathy or patient may have vertigo, so there is risk of fall. Third is it is a monotonous thing. Long-term adherence sometimes become difficult. There is less muscular activity than outdoor activity, and slightly lower calorie burn. When you compare it from outdoor aerobic activity, there may be some food problem due to constant friction. Especially in a diabetic patient who has neuropathy, there may be callus, blister, ulcers. Cost of electricity is there, and there is less bone loading. Okay, so these are the disadvantages. Now, few words about anaerobic resistance exercise that we can see in this slide, that this is heavy weight lifting. This is heavy. This is a form of anaerobic or resistance training. This is fast running, 100-meter fast run, sprinting. This is called sprinting. This is polymetric jumping. So all these are very, very good exercise because they are anaerobic resistance training. That is very important because they increases muscle mass, increases strength, increases bone density, increases insulin sensitivity. But apart from this, it is a recommended exercise in different guidelines. I will just show you what is the importance of resistance training. I have already told, increases muscle strength. So it will reduce sarcopenia, which is a fact. Everybody has to go through this phase. There is age-related muscle atrophy, that is sarcopenia. So if we do resistance training, that will reduce sarcopenia, and it is recommended in their treatment guideline of sarcopenia. It improves bone density, so it prevents osteoporosis, enhances insulin sensitivity, so reduces glucose load, and strengthens joint and ligament, reduces injury risk, improves posture and balance, lowering fall risk, boosts functional capacity for daily activities, prevents muscle breakdown, very, very important, stimulates muscle protein synthesis from mTOR pathway, causes muscle hypertrophy, and of course it supports cardiovascular health when it is being combined with aerobic activities. So these are important thing about the resistance training. But what I already showed you, different forms of resistant activity that cannot be done at home. Like for this you have to go to a gym, and this is not suitable for our age at least. Everybody sitting here of our age, it is not suitable, and this 100-meter race is also not suitable, and same with polymetric. So I have a set of exercise that all we can learn, adopt, and we can practice at our home. So Vijay, please help me in demonstration. The first is half squat. Even I can do. This is very simple. This is half squat. You do it for 5 to 10 times. Very easy. It is not so easy as you think. You can try once. But if you do it regularly, it is an easier thing. The second is wall sit. So wall sit is, we can make wall like this, and we can sit like this. This is wall sit. Wall sit. Just like we can take support of a wall. And we can sit like this. This is wall sit. Thirdly, chair dip you can show. Chair dip, yeah, you can show. Chair dip is very simple, and it can be practiced. Yeah. Then half push. Vijay, you can show half push. Half push, yeah. Then gluteal bridge. Even I can show you. This is not a difficult one. This is gluteal bridge. During inhalation, you lift, you hold, then and then down. Yeah. There is another set of exercise. We have finished all 5 now? Yeah. Now, these are the another sets of resistance activity that we can also learn and practice. First is wall push-up with hold. Better you go that wall and show. It is also very easy. Wall push-up increases strength in the upper body. We should hold it 3 to 5 seconds. The holding is actually time under tension. We should repeat it 4 to 5 times. Then second one is seated leg lift with resistance. Yeah, with resistance, elevate. This is, yeah. You hold it, do it unilaterally, give unilateral focus. This is very good for quadriceps. Yeah. You can do it bilaterally as well. Yeah, quadriceps. Do it bilaterally. Yeah. Okay. 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 Thank you very much, Suman. Third is standing hill raise with balance. Standing hill raise with balance. So we can take help of a chair, but Vijay is able to do without support. We have to stand on our toes. It looks muscles are muscles of gastrocnemius and soleus, and you also know about the peripheral heart. If you do it regularly, we can increase our venous return. So it is a very good exercise, and we have already demonstrated modified squat, and the last one is bird dog hold progression. That is also a very good exercise. Bird dog hold progression, simple in appearance, uniting balance, coordination in single pose. That is very good, Vijay. I will also join. First we are doing difficult things. Even I can do. Even I can do. But the ideal practice is to do contralaterally. You extend the right upper limb and you have to extend like this. Yeah, this is the correct one. Because due to the both hemispherical balance is maintained. In unilateral, there is chance of falling. Yeah. Now I will show you some resistance training by resistant band. I am focusing on resistance activities because these resistance activities can be easily learned and can be practiced at home, and these are the part of exercise program from various organizations like American Diabetic Association, WHO. This is a guideline based exercise. This is bicep curl. Then you can squat with band, seated row. Actually, this resistant band training, there is also some elements of flexibility and balance training. And we should know the contraindication, recent fracture, active arthritis, severe unstable angina. These all are the contraindication. It has got multiple benefits, increases muscle strength, good for joint health, improves mobility, metabolic fitness, and of course it is safe and portable. Thank you very much. So when we talk about the contraindication of anaerobic exercises in cardiac case, practically yes, but during unstable angina, it is not as advisable. Recent MI, it is not advisable. In heart failure also, in arrhythmias also, we should not advise any anaerobic activity. But when we advise, it must be modified and supervised. Even ACC and AHA, in their cardiac rehabilitation guideline, it is mentioned that resistance training is a part of standard cardiac rehabilitation, but must take help of your cardiologist. So later moving to the flexibility exercise, also very important exercise, improves joint mobility. Can you show some? This is tricep stretch. Then you can move to quadricep stretch. Then shoulder stretch. Then butterfly posture. Then lunges. And finally, cobra position. Thank you very much. Thank you very much. Only few words about HIIT, high intensity interval training. It is short burst of very high energy intense activity that are alternated with periods of rest or low intensity recovery. And it is also indicated for reducing weight. It burns more calories because high energy expenditure even after exercise, and that is called afterburn effect. So if you do HIIT, high intensity exercise, and take rest, in that period also the burning process continue, and that is called afterburn effect. And that's why there is more calorie loss when you do high intensity interval training. It also reduces body fat, particularly visceral fat, and it is very useful for reducing weight also. So last slide about the balance exercise. Balance exercise are very important because it improves postural stability, reduces risk of fall by training the vestibular system, vision and proprioception. This is important for elderly, diabetic with neuropathy, post-stroke and other medical condition. It should be done 2 to 3 times per week. In older adults, looks very simple but must practice, and now Vijay will show you one yogasana, that is tree pose vrikshasana. That is a mind-body balance exercise, and after that Suman will demonstrate at Tai Chi posture. So thank you very much. Moving forward, now the question came, one size does not fit all. I am 61, Vijay is 45 and Suman is still younger. So we have different type of exercise for different one. What happened? टाइम ज़्यादा हो गया? नहीं सर, 1 घंटा के लिए हमको कहा गया है. खत्म हो गया. लास्ट स्लाइड है. नहीं, 1 घंटा नहीं हुआ सर. हाँ. So we have discussed about various type of exercise, but we never talked about pregnant ladies. So it is also important. FOGSI guideline describes 30 minutes moderate intensity exercise daily, provided they have no medical or obstetric complication, and activities with high risk of falling or abdominal trauma should be avoided. So to talk about exercise during pregnancy, I will invite Dr. Suman. Dr. Suman, please tell us some yogas for pregnancies.
Hello. Yoga is very safe and beneficial in pregnancy, but it should be done under guidance of experts. It works physically, mentally, and prepare for labor. Now yoga in first trimester. Sir, next slide, sir.
Next slide.
This one. Oh, okay, sir. Okay. In this phase, one should be gentle, as this is a crucial phase. Focus should be in deep breathing and gentle stretching. Some important asanas are Pavan Muktasana part 1, 2 and 3, Marjari, Vajrasan, Ustrasana, Tadasana, Trikonasana, Matsyasana and Surya Namaskar, followed by Pranayam, Shatkarma and Yoga Nidra with relaxation. But we all know that the morning sickness is very common in the first trimester of pregnancy. The Kunjal is especially recommended. Now yoga for second trimester. Here focus should be on one poses that creates space for growing belly, improve balance and relieve pelvic pain. Here some asanas, pranayam, shatkarma and relaxations are given there. As we know, constipation is a very common problem in the second trimester. For this, Laghu Shankh Prakshalana is advisable for at least once in a week. Now, yoga for third trimester. In early period, avoid squatting and Supta Vajrasana to avoid premature delivery. Some important asanas are Pavan Muktasana part 1, Kandharasana, Matsyasana and Pranamasana, and followed by Pranayam, Shatkarma and relaxation. And okay, sir. And to counter advice, sir, Pavan Muktasana part 1 should be done in a late afternoon or early evening. Also Kandharasana, Matsyasana to stimulate kidney to remove excess of fluid. Thank you, sir.
Okay. Dr. Suman, yes. We expect few asanas you must demonstrate, like Vajrasana. Vijay, you can also accompany Vajrasana that can be safe in pregnancy. Vajrasana. Then Titli Asana. Then Bhujangasana, Pushtrasana, Matsya Asana, And finally, for relaxation, you need Matsya Kridasana. That is for relaxation. So that is all. Thank you very much. So periodic medical checkup is advisable throughout the pregnancy. And finally, the last slide. We have two main guidelines, WHO guideline and ADA guideline. WHO focus on overall health and well-being. ADA guideline intent for diabetic population but can be followed by all. They give strong emphasis on strength training, resistance exercise because it can reduce weight, preserve muscle, increases insulin sensitivity, and it is good for metabolic health. And WHO guideline simulates with ADA guidelines. That is aerobic exercise of moderate intensity, at least 150 minutes per week over 3 days, with resistance training 2 to 3 times per week, with flexibility and balance training 2 to 3 times per week. Sedentary behavior must not be continued, and there must be some interruption, break sedentary period every 30 minutes. So I end here, and this is the last slide. Not only discuss, but learn and adopt also, not only for patient with cardiometabolic risk factor, but also for all healthy persons to be healthy throughout life. Also for healthcare provider. Of course, all of us sitting here, respected members sitting here, offer a cocktail of aerobic, resistance and flexibility exercise to all, but with individualization. I end here. Long live CCDSI. Thank you very much, sir. Thank you, sir. Charlie. Thank you, sir. This task was given by Gagan. He asked me to do something new. Only I am loving exercise. The only thing is that we have very shortage of time.
After this interesting workshop, we'll be starting the next session. And to chair the session, I would request Dr. Jayant Panda, Dr. R.K. Modi and Dr. R.N. Prasad to come up the dais once it's set up. We'll just take a few minutes to do so. I'll take this occasion to again request all the speakers to stay within their stipulated time limits. We are again a bit late, so we won't be taking any questions for that. And I will request the chairpersons to see that the speakers are on time. Dr. R.K. Modi, Dr. Jayant Panda sir, and Dr. R.N. Prasad sir. Please come on the dais to chair the session. Panda sir. The participants of the workshop, I'll request you to go to the memento area to gather your mementos. Dr. R.N. Prasad? Aye, sir. Please. Dr. Modi sir, please do some aerobic asana after collecting your memento and come over here sprinting.
Welcome friends. It's a very excellent workshop on exercise. Normally the exercise becomes a didactic lecture in 10-15 minutes is very difficult to do. So Dr. Modi has taken the advantage of doing a live exercise on stage, and it's a very inspiration to all of us. And after that I'll invite Dr. P.K. Agrawal sir, and you know his CV is in front. A leader in clinical medicine, medical education and research. He is at Katihar Medical College, the professor head Department of Medicine at Katihar Medical College, and a postgraduate teacher, a senior clinician with strong academic and administrative experience, lot of leadership and professional membership as well as academic output and awards. His topic is acute severe hypertension. What should be the rational approach? Over to you, Dr. P.K. Agrawal, sir.
Thank you, sir, for your kind introduction. Respected chairpersons, wonderful audience, I have been assigned an important topic, acute severe hypertension. This 15-minute syndrome of any conference
बंद करेंगे पीछे क्या? इतना मेहनत से स्पीकर बोल रहे हैं, प्रोफेसर हैं, सीनियर आदमी हैं, प्लीज.
Yeah, silence. Yeah, sure, please go ahead.
I'm saying this 15-minute syndrome of any conference makes it difficult to cover all the points, the subject like acute severe hypertension or hypertensive crisis. Nowadays is called marked elevation of hypertension. So many guidelines are present to treat chronic hypertension, but not a single guideline is there to control the acute severe hypertension. In acute severe hypertension, each and every person is individualized, and each and every disease type is individualized. You all know the hypertension remains a major worldwide public health problem. When the blood pressure go above 180 by 120 millimeter of mercury in general, we call this is a hypertensive crisis. We divide it into two parts. One is the emergency, another is the urgency. When this shoots of the blood pressure is not associated with target organ damage, we label this as a case of hypertensive urgency, and if it is associated with target organ damage, we label this is a case of hypertensive emergency. The peculiarity of this situation is each situation has a different threshold, targets, drugs, and time frame. To treat acute severe hypertension is not only a science, but this is an art. You must know the art, how to treat a case of acute severe hypertension. We already discussed urgency and emergency. Other nomenclature, the old nomenclature like the malignant hypertension, if this shoot of the blood pressure is associated with papillary edema, we previously labeled is a case of malignant hypertension, and other forms of the retinopathy with this level of the hypertension is the accelerated hypertension. The brief about the pathophysiology of acute severe hypertension. There will be the inappropriate sympathetic outflow from the brain, and this will lead to increased arterial stiffness, thereby increasing the systemic resistance and ultimately leads to increasing the blood pressure. Side by side, inappropriate high cardiac output due to inappropriate high sympathetic outflow contribute to the high blood pressure. Also, it will lead to abnormal vasoconstriction, thereby increasing the preload. Associated with this, this will lead to activation of renin-angiotensin-aldosterone axis, thereby increasing the salt and water retention and ultimately rise in the blood pressure. This flow chart, you please look over this flow chart carefully. In a vessel, the vessel is maintained, the tone of the vessel is maintained with a very delicate balance between the vasoconstrictor and the vasodilator. Vasodilator like PGI2 and vasoconstrictor like catecholamine, thromboxane 2, aldosterone, and etc. The sudden rise of the blood pressure will lead to imbalance between the vasoconstrictor and the vasodilator, and the vessels go in phase of vasoconstrictor. Side by side, there will be the upregulation of cellular adhesion molecule. At this stage, patient is in hypertensive urgency. When this ongoing progression goes on, there will be the loss of vascular tone. This lead to endothelial dysfunction, coagulation cascade activated, and there will be the activation of the platelets. This results in thrombosis as well as DIC, that may lead to DIC. This is associated with the vascular permeability, and there will be formation of edema. This is the stage of hypertensive emergency. This is the pictorial diagram which we have discussed. This is the activation of the coagulation system. The clinical features depends on the target organ damage. It may be presented as a cerebral infarction or pulmonary edema, hypertensive encephalopathy, acute coronary syndrome, intracerebral or subarachnoid hemorrhage, eclampsia, aortic dissection. These are the various clinical presentation with acute severe hypertension. Very important first step is adequate clinical evaluation. First, take a proper history, particularly about the drugs like the cocaine and the sudden important antihypertensive, that is the beta blocker withdrawal. You also know the most important cause of acute severe hypertension is non-adherence of antihypertensive drug. So you must take a history, the beta blocker withdrawal. It may be present if there is pregnancy. This could be a case of preeclampsia, eclampsia, head trauma or injury may be present. You must inquire about the neurological symptoms like agitation, delirium, chest pain may be present. This may be the reflection of not only the myocardial infarction, as well this may be the reflection of aortic dissection. Particularly if the chest pain is associated with backache, this may be the reflection of aortic dissection. This you must consider because thrombolysis therapy is contraindicated in aortic dissection. The chest pain associated with the backache may be a case of aortic dissection. You must go for the fundoscopy examination to rule out the presence of the papilloedema and other forms of the retinopathy. Signs of the raised intracranial pressure you look for, like nausea and vomiting. Investigation depends on the case to case, but the general investigations like ECG, echocardiography, renal function test, liver function test, you may go for each and every case, and if needed, you may go for the cardiac biomarkers, CT, MRI, etc., whenever these investigations are needed. For the management overview, the first is the blood pressure is more than 180 by 120 millimeter of mercury. Divide it into two parts, urgency or emergency. Urgency is not an emergency. You have to drop the blood pressure gradually. First, admit the patient. Try to admit the patient if at all it is in emergency, and if it is a case of urgency, have a close watch. If possible, admit the patient in ICU. 4 important questions you have to inquire about. At what BP level requires treatment? How quickly should BP be reduced? What is the BP target during this period? And how should this goal be achieved? Which drug should be used in each case? Because hypertensive crisis management, I have just discussed, this is a trick. Too rapid reduction in BP, patient may land up in a stroke, shock, and too slow reduction in BP, patient may land up with ACS or pulmonary edema. To say both, do not suddenly lower BP or do not take too long to lower the BP. Hypertensive urgency management, just discussed, this is not an emergency. Yes, you have to low down the BP, but gradually. Target is over 24 hours, 160 to 100, 160 by 100 millimeter of mercury, or around 25% reduction of the baseline. Over days, go below 140 by 90 millimeter of mercury. Oral drugs usually suffice, and the general drugs used are the labetalol, clonidine, and hydralazine. Once controlled, choose the specific drugs associated with the disease. Like, as for example, if it is associated with the diabetes, you may choose ACE inhibitors or ARBs. If the patient is in emergency, you divide this emergency in two parts. One is the general, another is the exception. 4 important exceptions. One is a stroke, another is aortic dissection, third, preeclampsia oblique eclampsia, and fourth is pheochrocytoma crisis. And any other part is general. For the general persons, target is, in this emergency, target is the systolic blood pressure reduced to 25% of the baseline in first hour. In urgency, it should take 24 hours. In this, it should be in first hour and reduced to 160 by 100 millimeter of mercury within 2 to 6 hours. Target, of course, 140 by 90, less than 140 by 90 millimeter of mercury within 24 to 48 hours. Management of important hypertensive emergency like retinopathy, the preferred drug are nicardipine, phenoldiprate, nitroprusside, labetalol, clevidine. Few drugs are available in India, few drugs are not available in India. Acute coronary syndrome, preferred drugs, labetalol, esmolol, and nitroglycerin. A specific condition, a stroke. A stroke may be present in 3 important varieties. One is ischemia, another is hemorrhage, and third is encephalopathy. Cerebral autoregulation maintained in between the 50 to 120 millimeter of mercury. Mean arterial pressure 50 to 120 millimeter of mercury. Loss on lower side, patient may land up in ischemic stroke, and loss on higher side, patient may land up with hemorrhagic stroke. Principal, use drug that do not increase intracranial pressure like sodium nitroprusside. Stroke management. If the patient qualifies, if this is ischemic, if the patient qualifies for thrombolysis, reduce the BP level to 185 by 110 millimeter of mercury before thrombolysis and maintain it 180 by 105 for the at least next 24 hours. If BP is more than, if this patient does not qualify for the thrombolysis and if BP is less than 220 by 110 millimeter of mercury, do not initiate or reinitiate antihypertensive treatment. Please try to listen. In intracerebral insult, particularly the ischemia, why this blood pressure goes high? Because there is a zone of penumbra with the graded cerebral perfusion. This we are targeting to save that zone of penumbra. The cerebral perfusion is maintained by the difference between the systemic pressure and the intracranial pressure. Any insult in the brain will lead to rise in the intracranial pressure, and this difference is reduces. If the intracranial pressure rises, the system automatically rises the systemic pressure to maintain the difference for the proper perfusion. So that you are advised, please do not reduce the blood pressure at least for 48 to 72 hours. This is detrimental patient, if this is intracerebral hemorrhage, if acute less than 6 hours, systolic blood pressure 150 by 220 millimeter of mercury, lower to 140 millimeter of mercury, and if it is more than 220 millimeter of mercury, lower gradually to 180 by 105, mean arterial pressure less than 130 millimeter of mercury. Hypertensive encephalopathy is an important entity. This is the diagnosis of exclusion. If you exclude the ischemia or hemorrhage, it could be a case of encephalopathy. And the reduction in blood pressure will definitely improve the patient, because the main culprit is cerebral edema. So you try to reduce BP reduction advised by 10 to 25% in the first hour. Of course, the preferred drug in ischemic stroke, nicardipine, labetalol, these all can be used in each and every situation, except in subarachnoid hemorrhage. There is one special drug, and that is the nimodipine. You may use in subarachnoid hemorrhage. Aortic dissection management, only 2 points you have to remember. Diagnose aortic dissection, reduced fast in 1 hour, less than 120 millimeter of mercury, and the drug a combination of the sodium nitroprusside with the beta blocker. And the heart rate target is around 60 per minute. In pheochromocytoma, again, the BP reduction in 1 hour less than 140 by 90 milliliter of mercury, and the preferred drug of mentioned here, the phenoldiazepine, nicardipine, verapamil, benzodiazepine, phentolamine. Warning is, do not use beta blockers alone because of unopposed alpha stimulation.
Sir, summarize.
Preeclampsia,
Summarize.
One minute. Preeclampsia, eclampsia, the target is within 1 hour. The starting point is if it is more than 160 by 110 millimeter of mercury, and the target is within 1 hour it should reduce to 140 by 90 millimeter of mercury, and the best drug 2-3 we generally use labetalol. You may give magnesium sulfate. Perioperative hypertension, avoid cardiac surgery if it is more than 140 by 90 millimeter of mercury. My take-home message: decide whether the patient is in hypertensive crisis. If patient is in hypertensive crisis, the management is check for target organ damage. If it is present, it is emergency. If not, this is urgency. In target organ damage present, hypertensive emergency, admit to ICU, follow general rule, except exceptions we have already discussed. In urgency, admit and control BP to less than 160 by 110 millimeter of mercury within 24 hours, and drugs used clonidine, hydralazine, labetalol. One important message of my talk is the proper control of chronic hypertension prevents acute crisis, offers long-term benefit. Thank you. Invest in your health, take control.
Thank you. Thank you, Dr. P.K. Agrawal, sir. And he has very nicely told not only the pathophysiology and causes and approach to acute severe hypertension, but told how I'll approach. And in a very short time of 15 minutes, the whole subject is summarized. Any comment or question quickly? Last. So we'll go to the second speaker.
Thank you.
Okay. The second speaker, Dr. Ravi Kirti, please. His topic is hyperglycemia, hyperosmolar state, clinical aspects and management. And he is the professor in general medicine, AIIMS Patna. Over to Dr.
Thank you, sir. Good afternoon. So in the next 10 to 15 minutes, I shall be discussing hyperglycemic hyperosmolar state. As we know, there are very few but very important metabolic complications of diabetes, which include, of course, hypoglycemia and diabetic ketoacidosis, and the third one is hyperglycemic hyperosmolar state. So let's start with a case. Sorry. problem है देखें. So we'll start with a clinical case. So an elderly gentleman is with a history of type 2 diabetes and Parkinsonism is brought to the emergency with a 3-day history of polyuria and progressive confusion. And on examination, there is severe dehydration, he is hypotensive, and his sensorium is not great. So obviously we should have a few differentials at this point of time. Since the topic is hyperosmolar state, so obviously that is one differential diagnosis. But there could be other reasons, there could be many reasons for confusion and general deterioration from a simple UTI to an intracranial event. So how do we proceed from here? So some basic blood investigations. Blood glucose is very high, 842. Creatinine 1.6. Urea is 100 and actually this is blood urea nitrogen, this is 102. Sodium slightly high, 148. He has neutrophilic leukocytosis suggesting probably some infection. pH 7.34, so borderline acidosis. Bicarbonate again borderline, 18 millimoles per liter. On urinary examination, urinary dipstick, there is obviously significant glycosuria, and there is a trace of ketone. Nitrite is positive. So how do we interpret this? Now let us talk about the condition and then we will get back to our case. So hyperosmolar state, this is primarily a disease of the elderly. Just as DKA is mostly found in people with type 1 diabetes and they're generally younger, hyperosmolar state is found mostly in the elderly population and they're usually people with type 2 diabetes. But it is important to remember that there is significant overlap, meaning, and not just overlap, actually both type 1 and type 2 diabetes can give rise to both DKA and HHS, and there is no age cutoff which can distinguish DKA from hyperosmolar state. So that is important to remember, but the majority of patients with HHS would be elderly with type 2 diabetes, as opposed to DKA where patients are usually younger with type 1 diabetes. That is one thing. The second thing is about 30% of patients will not fit into either of the two prototypes. So there is a significant overlap also. This condition is less common than DKA, but has a significantly higher mortality. It is estimated to be about 15% mortality from HHS. So the clinical presentation, just like DKA, it can also present with polyuria, polydipsia, and weight loss. But as opposed to DKA, in the hyperosmolar state, the history is somewhat insidious and it develops over days to weeks. So there is a history of general deterioration and polyuria, polydipsia, some weight loss which has been going on for some time. And it is associated with lethargy, confusion, coma. Occasionally there may be focal neurological signs like hemiplegia, and patients can also present with seizures. On the other hand, whereas in DKA, we have some patients, quite a few of the patients presenting with abdominal pain and vomiting. This is very rare in HHS. The neurological manifestations are more pronounced. On examination, obviously, the neurological deterioration will be there. So GCS is usually low. They might be drowsy or confused or sometimes comatose. there is significant dehydration. There is dehydration in DKA also, but usually the degree of dehydration in HHS is much more severe compared to diabetic ketoacidosis. The JVP would be low, the tongue would be dry, the axillae or the rest of the skin would be dry. Patient is usually tachycardic, and they may be hypotensive, sometimes in shock. So the investigations, obviously blood sugar is important, and that is the first thing that will give a clue to the diagnosis. The blood sugar is usually very high, so in the range of 800 to 1000 milligrams per deciliter. Often you will often find blood sugar readings in that range, and usually it is more than 550. KFT is important. We will see why, because patients are dehydrated, so they are often in prerenal failure. And it is also important to calculate osmolality, which we will be discussing in the next slide. HHS is usually precipitated by something. Most of the patients will have some underlying condition that would have precipitated this condition. So it could be infection, it could be infarction, or sometimes just non-compliance with the usual treatment. And so we have to look for underlying infection, etc. So complete blood count usually we would have to do. Blood gas analysis, you can either do an arterial blood gas analysis or even a venous blood gas analysis, because here we are not so much concerned about hypoxia. We want to see the acid-base status of the patient. Urine dipstick, of course, because we want to rule out ketoacidosis in a patient who has presented with severe hyperglycemia and obtundation. Other investigations like ECG, chest X-ray, blood cultures, depending on what you suspect to be the underlying condition. But blood sugar, KFT, complete blood count, and blood gas analysis, urine dipstick, these are routine investigations that we would have to do in any patient where we suspect hyperosmolar coma, hyposmolar state. So the diagnosis requires these three things: hyperglycemia, and as I said, the hyperglycemia is usually in the range of 600 and above milligrams per deciliter. Hyperosmolarity, so the calculated osmolarity has to be above 320 milliosmoles per liter or per kilogram. And there should be absence of significant ketoacidosis. Mild acidosis and mild ketosis is okay, but if there is severe ketosis or ketoacidosis, then the diagnosis would change to DKA. And as I said, some patients will have an overlap. So osmolality is calculated using this formula. So twice sodium, twice of sodium, so that we can account for the anions that go with sodium. In some textbooks they would say twice of sodium plus potassium, so depending on so you can either take just sodium or sodium plus potassium, but the more this formula is more in vogue. So twice of sodium plus plasma glucose in millimoles per liter, or if we are using milligrams per deciliter, then we have to divide it by 18 to get in millimoles per liter. And blood urea nitrogen, again, if you're taking millimoles per liter, then you can go with that, or if it is in milligrams per deciliter, we have to divide it by 2.8. The range is 275 to 295. For a normal person, the calculated osmolality would be in the range of 275 to 295. If you're adding potassium also in this formula, then it will be slightly higher, 280 to 300. But to call somebody as having hyperosmolar coma, the osmolality has to be above 320. So going back to our case, he had a blood glucose of 842 and he had a blood urea nitrogen, excuse me for that. So the BUN was 102 and sodium was 148. So if you put everything in the formula, this is 379. So this is a severe hyperosmolar state. Anything above 350 is severe hyperosmolar state. So this patient has a hyperosmolar state. Usually when we see the patient, we will have blood glucose. Sodium might come a bit later. So in that situation also, we can at least if we can use a blood gas analysis, that will also have sodium. So we can use sodium and blood glucose, and that itself will give us some clue, even if we are excluding urea, whether the osmolality is high or not, and we can make a presumptive diagnosis. And there's also a concept of effective osmolality, which actually excludes urea, because urea does not cross the cell membrane. So and for that there is a different cutoff for osmolality. I think it is 300 in that case. So coming to the management, now that we have diagnosed this patient, so of course we have to attend to the airway and breathing. Airway is important because many of these patients will have a low GCS, and so it is possible that they are unable to maintain airway. So if the GCS is 8 or below, generally we would suggest intubating these patients. And breathing might be important if they are hypoxic. For example, this might have been precipitated by pneumonia. Pneumonia is a common precipitating factor. So oxygen supplementation would be required. The mainstay of treatment is IV fluid management. This is the most important aspect of treatment of HHS, because this is a hyperosmolar state and we need to correct that. Not only that, fluid repletion often corrects the blood sugar level also to a great extent. So IV fluids, we would usually start with isotonic fluid, normal saline in most situations. Some people would also use a ringer lactate solution, but most the starting fluid is usually normal saline. And the typical fluid deficit is of the order of 8 to 12 liters. So that needs to be replaced in the next 48 hours. So while the fluid deficit is usually much higher compared to DKA, but at the same time our patient profile is that of an elderly person who may also have other comorbidities like heart failure, CKD, etc. So fluid management is quite tricky. But usually in the first hour, we would give at half a liter to 1 liter. And then according to the fluid status, we would continue IV fluids in the 250 to 500 milliliters per hour. So first 2 to 3 hours, we would give 0.5 to 1 liters per hour, and thereafter reduce it to about 250 ml per hour. And thereafter, obviously, we have to assess the patient's fluid status and accordingly continue fluids. We have to remember that these patients are in fluid deficit, so there has to be a positive fluid balance. We have to aim to lower the osmolality by 3 to 8 milliosmoles per liter per hour. And the fluid has to be correct, the total deficit has to be corrected over 24 to 48 hours. Please conclude. Yes, sir. So, and after a few hours, we need to decide whether we want to continue with normal saline or we should shift to half normal saline. For that, we need to check the corrected sodium. So for every 100 milligrams per deciliter of blood glucose, we have to add about 2 millimoles per liter of sodium to get the corrected value. And if it is more than 135, then it is reasonable to shift to a hypotonic fluid. And when blood glucose is less than 250, then we need to add dextrose. Potassium, again, very important. We should delay initiation of insulin if potassium is less than 3.5, and only when it is more than 3.5 we have to start insulin replacement. Between 3.5 to 5 millimoles per liter, we usually add 10 to 20 millimoles of KCl to each liter of fluid. We'll have to be mindful of the fact that we are giving fluid at a very high rate. So that is why we need to take that into account when we are adding potassium. And if it's more than 5, then we don't add KCl. And finally, IV insulin. So the typical starting dose here is 0.05 unit per kilogram per hour. So let's say if it's a 60 kilogram person, we would start with 3 units per hour of insulin. And we are aiming to a decline in blood sugar by 50 to 70 milligrams per deciliter per hour. If we are unable to achieve this, we can double the rate, and if the rate of decline is significantly higher than this, then we can half the rate. And of course, when the blood sugar level is less than 250, then again we have to reduce the insulin rate. We have to monitor blood glucose hourly and urea and electrolytes 2 to 4 hourly, so that we can keep calculating the osmolality and decide on our fluid rate. And we have to look for precipitating causes. Consider thromboprophylaxis, because this is a hyperviscous state, so we should, unless there is a contraindication, we should give low molecular weight heparin to most of these patients. So a normalization of osmolality, blood glucose less than 250 and a urine output more than 0.5 ml per hour, and a normal sensorium means that the patient has actually come out of the hyperosmolar state, and that is when we shift to subcutaneous insulin. And usually we give a 1 hour overlap of IV and subcutaneous insulin. So I would end there. So we should suspect HHS in elderly patients with type 2 diabetes who present with altered sensorium and neurological features. Calculation of osmolality is a very central part of managing patients with HHS. And we should diagnose if there is hyperglycemia and hyperosmolarity without significant ketoacidosis. Fluid management, potassium replacement, and IV insulin, these are the cornerstones of management of HHS. And of course, we should look for and treat any precipitating causes. Thank you very much.
Thank you, Dr. Ravi Kirti. Nice talking. Any question?
I will take up questions at the end.
Yeah. So next speaker, we are inviting Dr. Ramesh Agrawal, and he'll be speaking. Diabetes remission, a very interesting topic, and welcome Dr. Ramesh Agrawal.
Yeah.
He's Professor of Medicine, Lady Hardinge Medical College, New Delhi. Yeah, now you can start. Yeah.
Very good evening, sir, and the audience, and I'm very grateful to the organizers for calling me here to speak on, as Dr. Modi has said, diabetes remission, a myth or attainable goal. Certainly it is something which still remains a mystery, that whether diabetes, we have been listening, we have been learning, diabetes is an irreversible disease, then how there's something like remission, is that remission similar to a cure? So these are certain things probably which I will be discussing in the next couple of minutes. So historically, type 2 diabetes mellitus was a progressive disease. The number of factors may be a progressive beta cell dysfunction, some reduction in the beta cell mass, chronic insulin resistance, glucotoxicity, lipotoxicity, and the clinical trajectory. We all know that there has been progressive deterioration of glycemic control, and we try to escalate our medications somewhat from oral medications to insulin and try to achieve a good control for the diabetes. But can diabetes be reversed, or can diabetes be remission, or can diabetes be cured? So that's something which we need to understand. A very simple slide, somewhat more than 1 lakh females they studied, and they found that as the weight is increasing, the relative risk of developing type 2 diabetes is also increasing. So see, as the weight is increasing, the BMI is increasing, the risk of developing diabetes is increasing. So something which is very clear is that weight is a harbinger. It's basically a predisposition for many of our illnesses, including diabetes. And if we look at this slide, so it is showing that as the time passes, and this is the weight change. So as the weight is now increasing, again, the risk of progression up to diabetes is reduced if you reduce the weight. So this is the segment which is showing you that there has been a reduction in the risk of developing diabetes from pre-diabetes state if we adopt the lifestyle changes. So probably that was also discussed by Dr. Modi very nicely, that what we need to do for achieving those adequate lifestyle. So another question which comes is that, okay, that we have weight, we tend to develop diabetes. We reduce some weight and probably the risk of developing diabetes goes down. So is it that if we do nothing, so still diabetes remission is possible? So another study was there, as they studied about more than 1 lakh people, and they found that if they studied for 7 years, so yes, there is some remission is possible, but to an extent of only 1.6%. So only 1% of the people may still get remission of the diabetes if they do nothing. And similar studying from the England, they studied more than 2 lakh people, and they showed that, okay, you do nothing, but only 1.7% people may by chance get the remission or the some treatment for the diabetes without doing anything. But one thing they found that if the duration of the diabetes is early, say for less than 2 years, less than 5 years, the chances of remission becomes more. So the question comes that what is the exact term? It is a reversal, is a remission, it's a cure. So these terms have been used inconsistently. So diabetes as such is a chronic progressive disorder, and the remission signals improved control. So it is a control of the diabetes and actually not eradication. So remission aligns with the oncology definition, as we say when we treat any cancer, that there is a remission of the disease. It's not the cure. So if you turn back to your unhealthy lifestyle or unhealthy food habits, so the diabetes may come again. So risk of relapse remains, requiring ongoing monitoring and the risk factor management. So finally in 2021 they came out with a consensus definition of what is actually diabetes remission, and they defined it as an HbA1c which is less than 6.5%, and that occurs spontaneously or after an intervention and persists for more than or equal to 3 months after stopping any sort of pharmacotherapy which can lower the glucose. Some alternate definitions for this was also suggestive. There are fasting plasma glucose less than 126 milligram per deciliter, or an estimated A1C from a continuous glucose monitoring of less than 6.5. So they came up with this definition of a diabetes remission. And then there was a twin cycle hypothesis, probably which could explain that why this diabetes remission is possible and what is the underlying pathophysiology. So there are two things in the body which are primarily responsible for this underlying pathophysiology and the remission. One is the liver, where the fat accumulates, and one is the pancreas. So we'll just tell you the brief summary of what this twin cycle hypothesis explains and how this remission occurs. If we eat more, chronic calorie excess is there. So fat, of course, accumulates in the liver. And this increased liver fat, it will lead to hepatic insulin resistance. This we all are aware of. But this increased hepatic insulin resistance then further lead to pancreatic fat accumulation. So the twin hypothesis is where the hepatic and the pancreatic organs, they go hand in hand. And this pancreatic fat accumulation leads to beta cell destruction. So the crux is, if you reduce the weight, that means the fat in the liver is reduced. Simultaneously, the pancreatic fat is reduced, restoring the insulin secretion and the glucose regulation. So ultimately, it boils down to your reducing the fat and having a healthy lifestyle. So this was a remarkable study and a landmark study, probably which defined and made everything at rest, that yes, diabetes remission is possible. This was a direct study carried out for more than about 4 to 5 years, started in 2014, and they continued studying till 2018, came with the, finally with their data in 2021, and then an extension study was there of this in 2024. So what this study said, and they studied it around 298 individuals, but they were white European population with type 2 diabetes. And here interestingly, the duration of the diabetes was less than 6 years, although the BMI was as high as 27 to 45 kgs. And they intervened with a very low calorie diet. So very low calorie diet means 850 kilocalories per day. And they continued that for more than 12 weeks, followed by some food reintroduction. And the aim was whether intensive weight loss can induce remission of type 2 diabetes. So again, they studied the patients for more than 2 years with a very low calorie diet to find out whether the diabetic patients could be in remission. The results were, of course, encouraging that they found out more than 46% of the patients, when they reduced weight to the tune of 10 kgs, so diabetes was, there was remission in the diabetes. But however, when the weight started increasing, that remission again, it dipped down to 36%. So it seems that whatever remission is possible, it is entirely linked to the weight of the body, because weight of the body is linked to your liver and your pancreas. So remission are well sustained for a given weight change. So anything from 10 to 15 kg of the weight, if it is reduced, so the diabetes remission is going to stay for about 60 to 80% of the patients. Similarly, as I said, the liver fat falls, VLDL falls, pancreatic fat falls. So all of that happened, and they saw it in this direct study, and the results were valid for 24 months. So just to have an overlook, how could this relationship between the weight loss and the diabetes was there. So if you reduce weight by 5 kgs, so there is still possibility of a remission of 7%. But if you have, if the patients reduce it to say more than 10 kg, the remission rates go to more than 50% to 80% of the tuning. So this was the study for, the earlier study which I showed was for the white population in UK. So they, as we all know, the South Asian population have a different lifestyle, different population, visceral obesity is there. So they, this study, standby study, they studied this in South Asian population in UK itself, and the results were almost similar, that reducing the weight by a significant number, of course, decreased, the diabetes remission was there, and it was more than 38% in the patients who could reduce the weight. So similar results were there in the white population, similar results were there in the South Asian population in UK. So we are doing also a similar study, not exactly that we are looking for a diabetes remission at our institute at Lady Hardinge Medical College. So we are also, we have engaged around 50 participants in 2 subgroups, 50 participants in one and 50 in the another. In the 50 participants in one group who are overweight and obese and who may be pre-diabetic but exactly not diabetic, and we are doing their body composition analysis. And now the preliminary results which have been there for the first 50 patients is that their body fat has reduced, visceral fat has reduced after 8 weeks of 15% calorie restriction in their diet, and the HbA1c has also reduced, not significantly, but just of course marginally, because they all were non-diabetic and maybe some patients were pre-diabetic, and the dyslipidemia also improved. So everything is tailored down to what you do with your body, what you eat and how you exercise. So this was a study. Say, you can always question that it is only linked to that patient has to be obese, and then only the diabetes remission can be there. Now type 2 diabetes patients, we all know that they are maybe thin type 2 diabetes. So in those patients, this retune study was done, and in this study also they found that if the patients are put on a low calorie diet, they also get into remission of the diabetes. So because the fat which they lose is from the pancreas and the liver and not probably from the whole body. So this was the result of this study which I am talking of, retune study, that their BMI was only from 24.8% and it fell to 22%, but the remission was there because of the loss in fat in liver and pancreas. So these whole number of studies have been done in the past which have given now adequate evidence that as the weight loss is there, as the weight is decreasing, the remission of the diabetes, it happens. And as you reduce the weight to more than 10 kg or so, there is a possibility that you may remain, the patients may remain in diabetes remission for quite a number of years. So what are the predictors of diabetes remission? Just to sum up my slide, short duration of diabetes is one thing which we have to look that it is not generally not possible the patient is having a diabetes of more than 10 years, 15 years, and we are very hopeful that even that weight reduction or calorie restriction may improve, may get into remission. So shorter duration of diabetes is probably one of the predictors of diabetes remission. Substantial weight loss, at least something to the tune of more than 10 to 15% will certainly lead to diabetes remission. A lower baseline HbA1c will, probably the patients will help more rather than having HbA1c of 10 or 12 or so. And a better preserved beta cell function, which of course goes hand in hand with the duration of the diabetes. Certain additional factors are there like lower pancreatic fat, younger age group, early lifestyle interventions. So all of these collaboratively leads to that the diabetes can be, yes, it can be kept in remission. So at the end, I would like to conclude by saying that diabetes remission is real and achievable, and it occurs most commonly with substantial weight loss and early disease intervention. Long-term durability varies with relapse common if the weight is regained, as we saw in the direct study, that when the patients, they again put up on weight, the remission just fell down from say 46% to 34 or 35%. So therefore, probably diabetes remission is not a myth, but it seems to an attainable therapeutic goal in selected patients, particularly when intervention occurs early in the disease trajectory. So that's, and thank you.
Yes, and you finished your lecture before time. Congratulations.
Thank you.
Yeah, next.
Very well spoken, Professor Ramesh. Actually, we should not lose hope.
Yeah.
It's the topic is very tricky. We should tell this is a attainable goal. Rightly, you have proved that.
Yeah.
Thank you. We'll take the questions at the end. And the last speaker of this session is Dr. Ajay Kumar Sinha from Nalanda Medical College Hospital. And he is talking on a very important topic, the dysautonomia. How to diagnose diabetes dysautonomia. Many times, even for the neurologists, it's a challenge. Over to you, sir.
कैसे चल रहा है? वो तो ठीक हो गया ये नहीं पॉइंटर इसे भी नेक्स्ट कर सकते हो ना पॉइंटर यस ओके First of all, it's my duty to thank the organizer, Dr. K Singh, Dr. Gagan, Gunjan, Dr. Shaibal, Dr. Abhishek, and all other team members for giving me the opportunity to be here. Honorable chairpersons, Professor Dr. Jan Panda sir, Dr. R.K. Modi, Dr. Dandania, all the eminent consultants of Bihar and Jharkhand, not only from Bihar and Jharkhand, but the rest of the country. Very good afternoon to you all. I have to give a talk which has been very common. Dysautonomia is very common, but difficult to diagnose and very difficult to treat. Because if the patient has got the history of chronic diabetes and if he is coming for the lightheadedness, giddiness, loss of consciousness, persistent diarrhea, urinary trouble not relieved by the urologist, you may think of diabetes dysautonomia. Next 10-12 minutes, the topic is big, I will be fast. I have to finish within 10 to 12 minutes. Okay. So before I start my presentation, let me give you a true history. Few months back, a young patient of 42 years old, suffering from the diabetic, not controlled good, landed into the emergency with a problem of septic shock and high blood sugar. It took time, but we have treated well. There were a lot of attendants, they were all happy. We were about to discharge. But in the morning, when we were making a discharge ticket, somebody has told us that the patient has died. Patient was well, doing well. Why the patient has died?
So later on, I will not go in detail, later on when we check the previous ECG and previous symptom neurology, he has pointed out there were QT prolongation, and maybe because of the malignant arrhythmia, the patient died suddenly. So that was, and it happened few times when we were treating the COVID patient. So that makes me think about that, how to diagnose the diabetic dysautonomia. Now, diabetic dysautonomia is a form of diabetic autonomic neuropathy characterized by damage to the autonomic nervous system. It affects not only the heart, but multiple organ systems like cardiovascular, gastrointestinal, genitourinary, and pseudomotor pathways. And the most clinically significant and extensively studied subtype and dangerous is cardiovascular autonomic neuropathy. The CAN is frequently underdiagnosed with reported prevalence ranging from 20% to 65%, increasing with longer disease duration. In type 1 diabetes, the prevalence is 20 to 40%, and in type 2 diabetes mellitus, 25 to 50%. The risk of dysautonomia increases significantly with disease duration more than 10 years, poor glycemic control, and coexistence with of other macrovascular complications such as retinopathy and neuropathy remind us that whether we are missing to diagnose diabetic dysautonomia. Few words about the pathophysiology. Like neuropathy, pathophysiology of neuropathy, the same pathology is valid for the dysautonomia. Persistent hyperglycemia promotes formation of advanced glycation end product, altering protein structure and disrupting neuronal and endothelial dysfunction. Increased oxidative stress and mitochondrial dysfunction results in neuronal apoptosis. And finally, damage to the vasa nervorum along with release of pro-inflammatory cytokines makes the trouble and creates the diabetic dysautonomia. The classification of diabetic autonomic neuropathy, the most important and most studied is cardiovascular autonomic neuropathy. It presents with resting tachycardia if the person suffering from diabetes having a long duration, more than 10 years, badly managed, and if the patient BP pulse rate is more than 100. It arouses us to think about autonomia. Orthostatic hypotension presents with lightheadedness, chakkar aata hai. He has tried a lot of medicines, cervical and all kind of things, maybe because of autonomia, dysautonomia. Silent ischemia and sometimes malignant arrhythmia leads to increased mortality. It is the most studied, as I have already quoted. Gastrointestinal autonomic neuropathy. Many a times diabetic patient presents with the chronic diarrhea, constipation, dysmotility, nausea, vomiting. One can think of the diabetic dysautonomia. Genitourinary autonomic neuropathy includes erectile dysfunction. Rather, erectile dysfunction is supposed to be an early sign to have diabetic dysautonomia, and the patient may have retrograde ejaculation, neurogenic bladder, urinary retention, and recurrent infection. Pseudomotor dysfunction, sometimes persistent foot ulcer in a diabetic, may arouse suspicion that patient will have pseudomotor dysfunction because of diabetic dysautonomia. And sometimes patient present with pupillary dysfunction. A few words about the cardiovascular autonomic neuropathy, why it matters, because it has markedly increased mortality. We were not able to know because patient dies suddenly because of malignant arrhythmia. It is said that 5-fold increase in cardiovascular mortality, making it one of the most serious complications of diabetes. It can present with silent myocardial ischemia. Many a times the patient of long onset diabetes present with burning hyperacidity. But on examination it was found that the patient has suffered from silent myocardial infarction. Orthostatic hypertension, that's a very common. Simply checking the blood pressure in supine and standing position gives the diagnosis the patient has orthostatic hypertension. One has to check the QT interval prolongation. If the patient has given the recurrent LOC, loss of consciousness, one has to check ECG, one has to take the help of the Holter monitoring, and the risk of sudden cardiac death. So diagnostic approach for the diabetic dysautonomia. There are a lot of tests, the simple clinical test and the lengthy tilt table test and many other tests. But what is important, one have to know the background of the patient, whether the patient has got one has to know the clinical history first, whether the patient, to diagnosing dysautonomia because of diabetes, one has to check the background history. What is the clinical history of the patient? What is the glycemic control? What is the microvascular complication? And what are the symptoms? With heart rate variability, which can be checked by the ECG and by doing some test like Valsalva maneuver. It is a bedside test. And there are many other tests and risk stratification, whether the can is early or definite or severe. And the physical examination which we do in our clinical ward is resting heart rate. We check the resting heart rate. We check the blood pressure after the Valsalva maneuver or the supine or standing position. And there are advanced diagnostic tests. In matter of suspicion, one has to go for the 24-hour Holter monitoring, tilt table testing, QT interval assessment, and cardiac imaging. These are the battery of tests, Ewing's battery of tests. There are 5 tests. Few tests are to detect the rate variability, and 2 tests are detect to the changes in the blood pressure. What is the normal, and after doing test, what is abnormal? I will not go in detail. So it is simple test, and if I will train my PG, which I have done it, they are able to do some study also, how common in my ward for this dysautonomia. Orthostatic hypertension, this is a very common situation, clinical situation, which lands into the physician office, the chakkar. So orthostatic hypertension is defined as a 20 millimeter mercury fall in systolic blood pressure or 10 millimeter mercury fall in diastolic blood pressure within 3 minutes of standing. Supine blood pressure followed by within 3 minutes, one has to take the blood pressure. Common symptoms include dizziness, lightheadedness, blurred vision, syncope, increased risk of falls. Although some patient may remain as asymptomatic, but this gives the idea of whether this diabetic dysautonomia will land it into the emergency or not. Evaluation includes bedside active standing test, tilt table testing can be done, and continuous blood pressure by the ABPM and ECG monitoring during positional change. Its presence suggests advanced cardiovascular autonomic neuropathy and is associated with increased cardiovascular morbidity and mortality. Gastrointestinal autonomic dysfunction, one has to be very cautious. There are tests, gastric impeting scintigraphy and the breath test. These are the tests specifically done to diagnose the diabetic dysautonomia because the symptoms are common. If the patient is telling us persistent nocturnal diarrhea or constipation, one may think of the diabetic dysautonomia. One can try the clinical test and then he will be able to diagnose the diabetic dysautonomia in a correct way. As I have already told you, erectile dysfunction is often one of the earliest clinical manifestations in men with diabetes and may precede overt cardiovascular autonomic neuropathy. Bladder involvement may present as decreased bladder sensation, incomplete emptying, urinary retention, recurrent urinary tract infection, or overflow incontinence. Diagnostic evaluation includes post-void residual volume measurement, bladder ultrasonography, and many other tests in the background of chronic diabetes. Pseudo dysfunction, if the patient is having persistent foot ulcer, not cured, one can check the pseudomotor dysfunction in diabetic dysautonomia. The sweating is reduced, particularly in the distal part of the body, distal limbs. So if distal limbs has got, and there are tests to detect whether the sweating is occurring or not. So these are the risk factors. The poor control is one important, duration, microvascular complications, cardiometabolic factors, whether the patient has got the other cardiometabolic problem, high BP, abnormal echo, ECG, like the age and gender. There are emerging biomarkers which we need it in heart failure, like we are using NT-proBNP in a diagnostic way, not for prognostic. Likewise, dysautonomia is very common in diabetes. We want that there should be some easier test that can guide us that yes, patient is having or are in a way to develop diabetic dysautonomia. But this has been not approved by any agency. The American Diabetic Association recommends routine assessment for autonomic neuropathy as a part of comprehensive diabetic care. In type 2 diabetes, after 5 years, it should be done. In type 2 diabetes, with the onset of the diagnosis of diabetes, one can test for the diabetic dysautonomia. Annual evaluation is advised in high-risk individuals, particularly those with long disease duration, elevated HbA1c or existing microvascular complication. But it's a tricky, time-consuming. Recommended screening tools include bedside cardiovascular reflex test, Ewing battery test, 5 tests, heart rate variability analysis, and orthostatic blood pressure measurement for early detection and risk stratification. This is the case illustration. A 50-year-old male with type 2 diabetes mellitus for 12 years presents with dizziness or on standing and reduced exercise tolerance. HbA1c is 9.2%. On examination, the resting heart rate by pulse oximeter was 102 beats per minute, and blood pressure drops from 130 by 80 millimeter mercury in supine to 104 to 170, 104 to by 70 millimeter within 3 minutes of standing. Ewing battery of those 5 tests reveals abnormal heart rate variability. Based on more than 2 abnormal autonomic tests and presence of orthostatic hypotension, the patient is classified as having definite to severe cardiovascular autonomyopathy, warranting close cardiovascular monitoring and risk management. But there are differences also which can mimic like diabetic dysautonomia, Parkinson's disease, amyloidosis, alcoholic neuropathy, drug-induced hypertension, chronic kidney disease, vitamin B12 deficiency, autoimmune autonomic ganglionopathy, and paraneoplastic syndrome. But one thing is important, before taking the diagnosis, before making the diagnosis of dysautonomia because of diabetes, one has to check the previous 10 years record in type 2 diabetes mellitus. To conclude about the diabetic dysautonomia, is a frequently underdiagnosed yet clinically significant complication of diabetes, with cardiovascular autonomic neuropathy representing its most serious form due to its strong association with arrhythmias, silent myocardial ischemia, and increased mortality. Chronic hyperglycemia leads to oxidative stress, formation of advanced glycation end products, and microvascular ischemia resulting in progressive autonomic nerve damage. Therefore, it is mandatory to do test for dysautonomia if the patient presents with type 2 diabetes mellitus with slightest doubt if there is any symptom. For optimal glycemic control and timely risk stratification are essential to reduce long-term cardiovascular complications and improve survival and outcome in diabetes mellitus. Thank you very much.
Thank you, sir. Thank you, Dr. Ajay Kumar Sinha, sir. Very well described and very important part, this diabetic dysautonomia. In the interest of time, we are not taking any question, and I request everyone to discuss the topics because they are all are very important topics. One acute severe hypertension, one HHS, one remission, and dysautonomia. This can be taken with the discussion with the speakers down the floor. Thank you.
Thank you,
Thank you, organizers. Thank you, everyone.
Stay with us. Okay. Next session, chair. So, thank you, chairpersons and speakers. You are kindly requested to gather at the selfie point for memento and group photography. To proceed ahead, the next session is debate, and for this session, may I invite the chairpersons, Dr. Rajkamal Chaudhary sir, Dr. Hemshankar Sharma sir, and Dr. Ajay Sinha sir. The instruction for debate is 13 minutes first spell plus 2 minutes rebuttal, total 15 minutes. Pardon, sir? Ajay Sinha, sir, Medanta. Yes, sir. So, kindly, you are requested to kindly stick on the time, sir. 13 minutes plus 2 minutes for rebuttal. So, may I request you to kindly invite the
So, friends,
debaters.
be prepared for the great fight between two friends. And don't go by their body weight system and the aggressiveness, because the Panjan is always ready for a head-on collision. So I just welcome him over here. Raju. Professor Dipanjan Bandyopadhyay is an Amitabh Bachchan of that area. Dipanjan, yeah, you are ready for the fight?
Hopefully.
So hopefully. So all diabetics must take antiplatelets unless otherwise contraindicated. And I wish good luck to Dr. Arya as well. Be prepared to just counter him. The counter is going on in between Iran and others. So don't worry about it. We are there, although we are not Trumps, we are Putins. Okay, thank you. Over to Dipanjan. Remember the time,
Good.
15 minutes,
Good.
15 minutes, and then rebuttal.
Good evening, respected chairpersons and honorable members of the jury. We are here to debate on the motion that all diabetics must take antiplatelets unless otherwise contraindicated. We know that aspirin has been there for more than 1,000 years, but it was less than around 100 years back that it was first used as antipyretic and as an analgesic. Its antiplatelet effect came much later on, and today we know that it is an important cyclooxygenase inhibitor. At low doses, it inhibits thromboxane generation, but does not interfere with the generation of prostacyclin. At higher doses, it obstructs the generation of both thromboxane and prostacyclin. So to make matters simple, low-dose aspirin is an antiplatelet agent and higher dose aspirin is a more pan inhibitor of both the COX-1 and the COX-2 cycles. There has been much discussion recently on aspirin responsiveness, but suffice here to mention in this small period of time that the assays or tests which evaluate aspirin sensitivity are not very specific. More importantly, for the purpose of today's discussion, diabetic people have hyperreactive platelets and their platelet aggregability is intrinsically higher. So the benefit of using aspirin in the diabetic population is more than in using them in the non-diabetic or the general population. Why the debate? The value of aspirin for primary cardiovascular disease prevention is controversial because the benefits are for everyone to see, but there can be this benefit can be offset by a relatively modest increase in the risk of bleeding. In contrast, secondary prevention has been established and convincingly demonstrated to outweigh the risk of bleeding. We know that diabetes predisposes to heart disease, diabetes predisposes to ischemic stroke, and diabetes also predisposes to peripheral arterial disease. If you look at this very simplified bar diagram, it shows that diabetics are at higher risk of cardiovascular disease throughout their life, and this incremental increases more and more as the person ages. There have been past randomized trials. Many of us have been through these trials when we were juniors, and it suggested that aspirin conferred modest cardiovascular protection, particularly against non-fatal MI in individuals without established CVD, meaning that aspirin conferred benefit of primary risk reduction. Coming more to recent years, this was a 2016 publication which said that aspirin reduced the risk for non-fatal MI but not non-fatal stroke, and little or no benefit for all-cause cardiovascular mortality. However, it included several trials which we do not again have the time to get into details, but if you look at this forest plot, the benefit of aspirin is at the most modest, but undoubtedly across the board, aspirin has a benefit both in terms of reducing CVD and all-cause mortality from cardiovascular diseases across the board. This is a more simplified version which says that for each of these non-fatal MI, non-fatal stroke, CVD mortality, all-cause mortality, we have divided the studies into those which were overall studies and those which included only diabetics. and you can see the relative risk reduction is higher for the diabetics than for the diabetic, non-diabetic population combined. Coming to the contentious issue of primary prevention, these three trials stand out as the most recent documentation of primary prevention in persons with diabetes, and it was shown that this study basically dealt with the composite endpoints of non-fatal MI, etc., etc. The safety outcome was assessed as major bleeding event, as intracerebral hemorrhage, sight-threatening bleeding event in the eyes, or a gastrointestinal bleeding of major degree. And major bleeding was increased from 3.2% to 4.1% in the aspirin group, with most of the excess being GI bleeding, ladies and gentlemen, and other extracranial bleeding. So, intracranial bleeding was not the most important issue at hand. You can see there was a distinct benefit in risk reduction with aspirin at the primary prevention level as well. The two more recent studies, the ARRIVE, which I will, and the ARRIVE and the ASPRI, which we shall now look at, goes into a little more detail with the diabetic population. You can see in ARRIVE, with more than 12,000 patients, there was a substantial decline in the primary endpoint, but GI bleeding events occurred in less than 1%. And as I said, intracerebral hemorrhage occurs in even in less than the GI bleeding. This study was related to the elderly population. Remember, elderly populations are more at risk of bleeding. And the rate of hemorrhage per person was 8.6 versus 6.2, which is an increment of around 2% between the aspirin treated group and the non-aspirin treated group. So, there is a significant trade-off between efficacy and safety across trials which investigate aspirin use in primary prevention. And if you look at this, it actually shows that the number needed to treat to achieve benefit is sometimes more than the number needed to harm or to achieve a bleed. But time and again we repeat that the majority of these bleeds are minor bleeds, non-consensual bleed, and the risk of intracerebral hemorrhage is significantly low than that has been promoted. Coming to the second or the last part of the presentation, these are the most recent guidelines that we could lay our hands on, and I understand that the opposition will come up here and say that not all diabetics will benefit from aspirin or antiplatelet use because of the accentuated risk of bleeding. The ESC tells us that even with people without a history of symptomatic atherosclerotic cardiovascular disease or revascularization, aspirin low dose may be considered to prevent the first severe vascular event in the absence of clear contraindications. That is what the motion we propose, unless otherwise contraindicated. So aspirin across the globe for diabetes has been clearly recommended in this guideline. For patients with atherosclerotic disease, as I already mentioned, they are at very high cardiovascular risk, and low dose aspirin is recommended, although ad hoc trials are lacking. Meaning, even when the benefit is established in the domain of secondary prevention, we do not have upfront randomized controlled trials. The two trials that I mentioned below, they showed comparable efficacy of a lower dose of aspirin to a higher dose of aspirin. So for all practical purposes, preventive strategies should use the lower dose aspirin so that the antagonistic effects of aspirin are restricted only to the thromboxane pathway as we discussed, rather than the pan-cyclooxygenase inhibition. The most recent guideline that we have at our disposal is the 2026 ADA guideline, which has highlighted glycemic management, BP management, good lipid management, and management of other cardiovascular risk factors with kidney benefit. And they say that recommendations for using aspirin as primary prevention include men and women above the age of 50 with diabetes, at least one additional major risk factor. Non-invasive imaging might or might not be used or taken into consideration. And for people above the age of 70, as I said, which are high risk, the balance appears to have greater risk than benefit. So essentially, ladies and gentlemen, we need to approach our diabetic population with individualization. We need to see whether they have those apparent contraindications or not, but then aspirin across the board is what we suggest. Overview: aspirin appears to be a modest effect on ischemic vascular events. The excess risk may be higher. However, for adults with atherosclerotic cardiovascular risk more than 1%, and diabetics have intrinsically a higher ASCVD risk, more and more events will be prevented with the use of aspirin, unless contraindicated. So aspirin may be considered in the context of high cardiovascular risk. For people with documented SCVD, use of aspirin has far greater benefit than those with primary preventive strategies. Two populations: for people less than 50 years, you need to use your clinical judgment. Similarly, for people above 70 years, you need to use your clinical judgment. A wonderful projection of the benefits which have been highlighted by several trials, starting from the earlier trials when we were into our undergraduate years, right up to the Ascend, Aspirin, and the Arrive, which I discussed. And you see, there is a relative risk reduction across the board when we are using aspirin in patients with diabetes. So the case for net clinical benefit is, there is a fine balance between benefits and risks for regular aspirin use in primary prevention of cardiovascular disease, and high risk people substantially benefit from the use of aspirin. Diabetes mellitus itself, as I said, is a high risk story, and there is accentuated benefit in the using aspirin with people with diabetes. This is one of the most recent meta-analyses which I could lay my hands on, and the beyond severe risk, aspirin has a role in the prevention of venous thromboembolism, chemoprevention of colorectal cancer, neuroprotection with reduced risk of dementia. So there is a panacea of beneficial effects of aspirin. Diabetics have hyperreactive platelets, as I said, and insulin resistance promotes more hyperreactivity of the platelets. So diabetic platelets benefit more from aspirin use. To conclude, the benefit of aspirin for patients with CVD outweighs the excess risk of bleeding. Undisputed role offering modest benefit. There is a trade-off between aspirin initiation versus increased risk of bleeding, but then GI bleedings are usually more, which can be offset with the use of low-dose aspirin, concomitant use of proton pump inhibitors. Contemporary guidelines and position statements tell us that all diabetics may be prescribed antiplatelets unless otherwise contraindicated. Thank you. I rest my case.
Dipanjan, can you just take your seat over here? Now, may I request, friends, you have just heard him. Diabetic is a pro-thrombotic state, and the role of aspirin. Now, you must have heard about the secondary prevention and primary prevention. He stressed upon probably more onto the secondary prevention, and the primary prevention is only with limitations. Now, let me see the second stalwart. Arya sir, aa jaiye. Welcome on the stage. So you have heard him, and now I am the Om Birla of the Lok Sabha speaker. Just answer him.
Good evening, respected chairpersons, and it's an honor to speak on this topic. Very interesting thing is that last week I had called Dr. Dipanjan, and I was discussing with him about this topic, and he was very clear, Dr. Arya. Sun rises in the east and there is no debate about it. I told, yes sir, I agree, and I story. I would explain in the subsequent slides. See, we all know what are antiplatelet drugs. We know this, so no point in repeating. Actually, my job has been made very easy by Dr. Gunjan. More than 4 times he has repeated that there is a risk of bleeding. So this makes, and he has also proved in the studies. So this makes my work much easier. So the key primary prevention trials, non-significant results. There are so many trials that individual randomized trials consistently fail to show clinically meaningful survival advantage for universal aspirin used in diabetic primary. So this is very, very clear. Overview of, there are so many trials. We discuss science. So let us talk science, and there are so many trials which shows that major trials evaluating like JPAD trial, POPER trial, FN trial, and they all have proved more than one time that this was a trial done in JPAD, that population was this much, intervention, aspirin, outcome, no significant reduction in primary CV events. So why to take the risk? Why to use in all the diabetic patients? No. Conclusion, limited benefit in primary prevention. Another trial, diabetic patients with asymptomatic PAC, results aspirin did not reduce cardiovascular events, no mortality benefit. Conclusion, routine aspirin not justified, ladies and gentlemen. Ascent trial, this trial was also shown by Dr. Gunjan, population this was intervention aspirin 100, and what was the result? Benefits, 12% reduction in serious vascular events, risk 29% increase in major bleeding. 29% is not simple. Conclusion, benefits offset by bleeding. Meta-analysis, antithrombotic trials are there, small reduction in vascular events, increased major bleeding, routine aspirin not recommended. Once again, ladies and gentlemen, the story doesn't end here. There are so many types. ADA guidelines, aspirin recommended for secondary prevention, primary prevention, age 50 years, additional low bleeding risk. ESC guideline, European Society, aspirin not recommended. Not recommended for routinely for primary prevention, consider only in very high CV patients. ACC AHA guideline, again, low dose aspirin may be considered, but there is always increased risk of bleeding, so not recommended in age more than 70 years. Risk stratification before prescribing, assess SB3 risk score, age, hypertension, lipid profile, smoking, family history, bleeding risk. So these are the things which has to be assessed before we start aspirin or any antiplatelet drug to a diabetic patient. So bleeding risk factors, major factors are there. Age 70, history of GI bleeding, peptic ulcer, anticoagulation. Intracranial hemorrhage is a very, very threatening thing. Yesterday I had a talk in Banaras. My topic was cerebral
So better strategies for CV risk reduction. The only aim which my opponent is telling that there is a CV risk benefit by using antiplatelet. But there are so many other things by which we can reduce. We can go for statin therapy, we can go for BP control, we can go for glycemic control, smoking cessation, and of course lifestyle modification. So with this we can target and we can lower the risk of CVD. Cardioprotective anti-diabetic drugs are there. Let us not forget SGLT2 inhibitors. Far and far it is proved that it is a cardiac and cardioprotective drug and it helps even in GLP-1. Provide cardiovascular protection beyond glucose control. So, reject universal use. This is the bottom line. Advocate for individualized care. Current evidence does not support routine aspirin for all diabetics. Clinical strategy must prioritize personalized risk assessment and shared decision making. Key take-home message. Diabetes increases cardiovascular risk. Aspirin essential in secondary prevention. Routine use in all diabetics not supported, and assess risk versus benefit. I conclude, ladies and gentlemen. Antiplatelet therapy in diabetes must be evidence-based, it must be individualized and guided by clinical trials and guidelines. Avoid unnecessary bleeding complications. Thank you.
Well, you have already given the answers. Now there is a rebuttal, 2 minutes to Dipanjan and then back to you, and then we will be participating in the discussions. 2 minutes ka lagao.
Thank you, the honorable member of the opposition, for making things more clear. What we said and what we had proposed is that diabetics are eligible for antiplatelet therapy unless contraindications exist. We have talked only of diabetic risk. There are concepts of risk enhancers, risk modifiers, and the entire risk stratification is a very, very difficult ball game. In clinical practice, we understand that diabetics per se are a high risk population. What we have mentioned earlier, people less than 40 years, people higher than 70 years, people with high bleeding risks, people with past evidence of bleeding disorders or bleeding episodes, they are not the candidates for antiplatelet use. We need to select, we need to choose. We also need to take into account the patient's choices. But then the motion, I think my member of the opposition has made the motion even stronger. The diabetics are eligible for antiplatelet therapy unless otherwise contraindicated. Thank you.
I was literally worried when Dr. Dipanjan was repeatedly telling my opposition. No, sir, I am your brother. There are no opposition. We are not in the parliament. Well, if you ask me, the topic of debate should have been changed. The debate topic should have been that all diabetics should not be prescribed antiplatelets until and unless strongly indicated. So with that, I still feel that we should restrict the use of antiplatelets in diabetes. Thank you.
Hello. The topic was that what you said. The Pankaj did not deviate from that. He just stressed upon about the diabetic, which is a prothrombotic state, and what was the use during secondary prevention and primary prevention. Primary prevention has got multiple limitations, and that is not recommended very well. Particularly persons like, you have already said there is a history of bleeding more than 70 years, right? Those are the situations where it should be given. But with slight limitations, if there are no history of bleeding and all that, all cases for secondary prevention can be used. Now your slide also showed the other drugs, plasofil and all that.
Yeah.
Those were not the points of discussion. Actually, the case has been under discussion with the ADA or the ACC with only low doses of aspirin. Basically, it moves around the low dose of aspirin
patients of ischemic coronary artery disease, or otherwise also, they are having anemia 8-9 grams, and you have great difficulty in putting them on aspirin. So this is the biggest problem, and even without a risk factor, you can't afford to give them aspirin. So diabetic for primary prevention, no, it's a big no, unless there are compelling indications, unless there are. I know that lot of population, you see diabetic population having anemia. Good number of population, good number of people are having anemia, all the diabetic populations. So that is a big issue, what to do. And aspirin, I believe, is more khatarnak compared to clopidogrel. So, those patients who are having anemia, diabetics, anemia of 8-9 grams, very difficult to put them on aspirin. So I would still believe that for secondary prevention, yes, big yes. But primary prevention, I think we should not. Yeah, individualization. I think both of them have done very well. Over to Raj Kamalji.
Sir, the topic of the discussion is diabetics and antiplatelets. So regarding this, I would like to say that aspirin should be used in all diabetic patients, in all primary prevention. Why? I will tell you why. The reason is because in diabetics, what happens? The hyperglycemia, the blood sugar level rises up. And because of the rising blood sugar level, the platelets, they become sticky. They have a clogging factor which adheres each other. So it goes to have a thrombosis effect. So that is prevented by using antiplatelets like aspirin. The second point is, well, I would like to ask a question from both of you, that should we use antiplatelet in type 1 diabetes, or if the diabetes is controlled by insulin, because it is only the aspirin is used only in cases where there is hyperglycemia. That is the effect of the hyperglycemia. So that's what I want to ask you. Sir, now you can tell me.
So are you asking whether poorly controlled diabetics merit more rational use of aspirin? So diabetes, when we talk of diabetes, we are usually talking of the type 2 diabetes. Although some studies have said that the benefit can be extrapolated to any type of diabetes, whether type 1 or type 2. And as you rightly pointed out, that secondary prevention, the data is more robust, but primary prevention, it can be used provided you delete the contraindications.
Thank you very much. Now I think there was a good discussion. You want to say something? Please. And after this, I will just ask you to vote. So nobody will take it otherwise, you can just vote.
Very nice debate. Congratulations both the debaters. Very well chosen topic because it's controversial. My opinion that this platelet aggregation inhibitors should be kept as case-to-case basis. But there is another drug in this segment, the statins, with lot of pleiotropic benefits, even action on endothelium, action on platelets, and irrespective of the lipid level, statin should be universal. That opens another debate.
Sir,
But out of these two group of drops,
I am sorry, Dr. Panda, sir, the statin were not the part of discussion over here.
yeah.
Right, you can take the endothelial function and all that we will discuss, and during the talks also we can discuss.
Sir,
so I think, thank you. No, anybody? No, Ajay? Voting, yes. No, you just vote. I give you the full authority.
It's a very important topic. Aspirin should be used in primary prevention or not. In secondary prevention, there is no doubt. One has to give it, unless until there is some compelling indication. In primary prevention for Indian patient, where the gastric dysmortality and gastritis are more, what do you mean by compelling indication? The chairperson has pointed out that for primary prevention, aspirin should be used in diabetic, except in compelling indication. What does it mean by compelling indication?
I think the compelling indication would be if somebody got a strong family history of coronary artery disease, strong history like sudden death, all these, and other risk factors as well. CKD, yes. Vascular disease or, IMT more. So these are
10 year risk factor if it is more than
10. Yeah.
वोटिंग हो गया फॉर व्हाट हाथ उठा दिए सर आप लोग फॉर पूछे ही नहीं अरे फॉर सेकेंडरी प्रिवेंशन अभी भी कुछ हाथ नहीं उठे हैं फॉर प्राइमरी प्रिवेंशन विथ लिमिटेशंस
शंकर सर
primary prevention with limitations.
Sir, Rai sir,
so everybody has agreed. Thank you very much. Both of you have done justice. Rai sir, final comment, sir.
Once it was said that diabetes is a coronary equivalent. It was said. Now it has been looked up. But until there is absolute contraindication. I think if the patient has multiple risk factors, it should be given. So risk factors should be there.
So the same thing, sir. In secondary and primary, both the ADA and ACC has recommended like that. So everybody has got the universal opinion. Nobody is against this, sir. Sir. Thank you, sir. Thank you. That was the best thing. Thank you very much.
Thank you, chairpersons and speakers. Thank you, sir. You are kindly requested to gather at the selfie point for memento and group photograph. So, to proceed ahead for the next session, may I invite the chairpersons, Dr. P.K. Agarwal, Dr. Dhanvantri Tiwari, and Dr. Ravi Kirti. इधर से अग्रवाल सर, माना कि आप लंबे हैं लेकिन फिर भी सीढ़ी इस्तेमाल कर लीजिए. हमको लगा आप ऐसे ही चल रहे हैं. So chairpersons are requested to kindly stick on the time because we are running short of time. So over to you, chairperson, sir.
कौन सा है?
I would like to invite Dr. Jayant Panda, a known diabetologist, and this is an era of AI, and he will discuss incorporating AI-powered technology into diabetes practice. Over to Dr. Panda.
Thank you, sir. And it's my honor that so many important people are around. Before I go to my topic, I'll try to save some time for the organizers. I understand inauguration is there and we're already running late. So I'll make a interactive presentation just for 10 minutes and shave 5 minutes for the organizers. Actually,
silence please, silence please.
What
silence, Shaibal, please.
What happens when anybody who goes for a memento, there has to be a little chaos. So by that time we will have a poll. How many of you use artificial intelligence in your diabetes clinic? Yeah. So, you know, how many of you know that in the field of diabetes, there are so many equipments involving machine learning which can predict patients' complications, hypoglycemia, CGM, and that's there with us for last 25 years. It's not that it's new. We have that as soon as we had the first pump in the world. Around 2000, the first pump was launched, and the CGM that you use now, the continuous glucose monitoring, which also plugged up with automated insulin doses. You know, the best combo, you can tell two things together, is the CGM and automated insulin delivery. So a machine which detects the blood glucose, tells you about the status, decides the dose and pricks it. And we have utilized machine learning in that. And you know, initially we put machine learning, and second phase we put deep learning. In artificial intelligence there are two phases. So if you remember three things, you remember whole of artificial intelligence. One is pattern diagnosis, one is machine learning, one is deep learning. Pattern diagnosis, like if you put a recorder in your table, if it listens you counseling your patient for 100 patients, the 101st patient it can counsel. It can tell what you will tell the patient in a better way than you. That is the pattern diagnosis. And with that, the radiologist, the pathologist, the science which has a pattern, they diagnose from a pattern. You know, pleural effusion, diagnosed from a pattern. The pneumonia, diagnosed from a pattern. The histopathological diagnosis, Langerhans-Janz shell, diagnosed from a pattern, is already taken by the artificial intelligence. In corporate hospitals, the pattern diagnosis is taken by artificial intelligence in a better way than the physicians. Then comes machine learning. Machine learning, I was giving an example. In the insulin pump, we have a CGM, we have a AID. The CGM detects and the AID delivers. What CGM does, continuous glucose monitoring, every 3 minutes a blood glucose estimation is done from the interstitial fluid. It goes to the patient's smartphone, the caregiver's smartphone, the educator's smartphone, the doctor's smartphone, and accordingly things are prepared. And as early as 4 to 6 hours, it predicts a hypoglycemia. And especially in nocturnal hypoglycemia, suppose at 3 a.m. you are likely to have a fatal hypoglycemia, that can be detected by the machine, and machine can tell you that this is the danger your patient is having. So, in many ways, in predicting hypoglycemia, in our own plan of drugs or insulin, in detecting the complications early, in subjecting patient to any detailed investigation, the AI-powered technology is very simple and can be incorporated to your own diabetes clinic. Quickly I'll go through the slides. First, thank you CCDSI. And CCDSI means we mean the Bihar Jharkhand group very strongly. My mentor, Professor N. Rai here, and the whole team, Professor K Singh, Dr. Gagan, Gunjan, Dr. Shaibal, Guha, Dr. Vijay, and a whole team I see. I salute the effort of Bihar Jharkhand. It's a mother branch which has shown the way to all other branches. Give a big hand for the Bihar Jharkhand chapter of CCDSI. So I have designed this talk in these headings, which you will go through. I'm leaving the slide sheet here. You can follow. These are all based on the evidence and the science. And we are telling you about the diabetes burden and AI urgency. Taking AI to your clinic is an urgent thing, because before your patients take and they reject you as imperfect consultants, you take AI and make your clinic self-sufficient for your patient. The AI clinical fundamentals like machine learning and deep learning, the CGM and automated insulin delivery system I was telling, screening and complications. Every diabetic can be asked about their complications, implementation roadmap, the regulation and the challenges and equity and the future trends and action plan. So here quickly I'll go through. You all know that we are running with 800 million diabetics, which is projected to be 1.3 billion by 2050, which is a 62% growth forecast. And unless you are prepared, you cannot face, because 50% patients are undiagnosed. And you just put patient profile, AI will tell who is going to develop diabetes after how many days. You see the projected prevalence growth towards right. In diabetes, for device data, CGM pumps and wearables, for cloud processing as the ingestion and normalization, for electronic health record integration, the clinical workflow and the clinical action like decision support and care, all purpose the artificial intelligence is vital. So this AI 101 for clinicians is something basic, giving you about the pattern and the structured clinical data, time series and sensor, medical imaging and omics, they come into picture. So the aggregating raw data in electronic health record, normalizing units, the engineering clinical variables and the machine learning models, they deliver actionable insights. Just you subject the electronic health record, the profile of your patients, your AI can tell who is going to develop diabetes, hypertension, obesity and related metabolic problems, how often. The CGM and artificial intelligence, I was telling, the glucose management, I'm not going to the details of it. You can see here the first part, that predicting a hypoglycemia. Suppose at 11:15 p.m. the hypo is predicted, it's coming down from 120 downwards. Right before sufficient time, you get a indication that your patient is going to develop hypo. This is the hypo alert shown towards the left of the graphic, forecasting models and the real world cases. The predictive prevention of hypoglycemia I have told, and the most important is prevention of nocturnal hypoglycemia. The postprandial profiling, exercise timing, stress and sleep, the lifestyle integration, you can utilize artificial intelligence in that. Diet can be specific to your GDM patient, to your child in type 1 diabetics, to young diabetics as well as type 2 diabetes with complication, with heart failure and with kidney failure. The automated insulin delivery is something I have already told. The controlling algorithm, the CGM sensor and taking the patient physiology into account, the liver and the renal functions, it can tell you about the amount of insulin required. And the decision support, the real life based advisors and telehealth are managed by AI, and you'll be surprised, without any consultant, the tele-consultation can be run by AI, giving suggestion to your patients. If you incorporate in your system, AI will very simply deliver the information to your patients. So the clinical performance, like validated pivotal trials and the point of care workflow is very important for retinopathy. If you just screen the retina, the predictability of a background retinopathy, a proliferative retinopathy, or a normal retina can be transferred to the consultant. It's very difficult to get an ophthalmologist all the time. It's very difficult to get a podiatrician all the time. But a predicted diabetic foot, a predicted hypoglycemia, a predicted diabetic retinopathy always saves patients' organs. The diabetic retinopathy AI in practice, workflow and reimbursement is in place, and similarly the diabetic nephropathy with AI, diabetic cardiovascular event, and predicting the events to 100% accuracy, including A1C, blood pressure, LDL, eGFR, is possible by artificial intelligence. And multimodal omics integration with the multimodal stack, performance uplift and clinical pathway come in the way with the digital twins, the virtual patient model, the patient-specific virtual model, the scenario testing, and the proactive care planning come into picture. The chatbots and virtual coaching, the implementation roadmap like pre, peri, and post-implementation, as well as the details of the AI plan. I'm not going in the interest of time.
Sorry to interrupt, sir.
Yeah, there's the last slide. The clinical outcome in time in range, we have 15% additional patient, septimetric 40% decrease hypoglycemia, 25% workflow impact in the admin burden by the electronic health record, and 92% operational achievement in the diabetic retinopathy screening. So from here you can see, and the last slide I'll show you regarding the privacy, security and the equity. That is the only challenge in artificial intelligence, that you have to protect the data of your patient because it is coming digitally. It's cost effective as well, and the last thing is this is the case study I'm not telling. The emerging trends for multimodal models, the federated learning, as well as the 90-day adoption plan you can take for your clinic, and start with high-yield use cases, measure what matters and build trust through governance. So with this I'll end my presentation, ladies and gentlemen. The last thing, AI is never a danger to our practice or our credibility as consultants. But if you will not adopt AI, your young generation consultants and patients who are electronic savvy will not give you the credit of a successful clinician. In old time, the clinical medicine was the strength. Now I tell, to become successful clinically, the artificial intelligence incorporation is the strength. Thank you for your time.
Thank you, Dr. Panda, for a wonderful deliberation. And you pass a message for the precision therapy. Each and every doctor must be loaded with AI. Thank you. Thank you for your lucid presentation.
So thank you, sir, for this nice presentation. We move on to the next talk. The talk will be by none other than Hemshankar Sharma, sir. He needs no introduction to this audience. He is among the senior most clinicians and teachers of medicine in the state. And it's my honor to introduce him. He will be speaking on refractory hypertension in diabetes, when to suspect a secondary cause. Thank you, sir. Over
Thank
to
you,
you,
Ravi. Thank you very much. I'm lucky to have all the three. Out of the three, two are my students. So a student when guiding the professor is really a proud moment for the teacher. I'm really thankful to all the three of you. So the dual burden, as we all know, we have been discussing about the diabetes and hypertension and all lot many things. We all know that over 1.4 billion adults have hypertension and 537 million people live with diabetes. Combined, they are the leading cause of stroke and kidney failure. And I think if you just search over here, you can find a couple of cases, 3-4% over here may have suffered from both of these things. The Indian reality, we all know, 58% of Indian type 2 diabetes mellitus also have hypertension. 19.4% suffer from refractory hypertension that is hard to treat. And risk of heart events is at least 2 times higher in this age group. Now, if we go by the next aspects, there are 2 terminologies, resistant hypertension and refractory hypertension. So, we all know that what is resistant hypertension. When you can't keep the blood pressure within the target limits with at least 3 groups of drugs belonging to 3 different classes, but at least one of them has to be a diuretic, and they are used at maximal therapeutic dose levels. So, if they do not respond to this, this is resistant hypertension. And when you increase the number from 3 to 5, including one mineralocorticoid, and they are still not responding, this is called a refractory hypertension. So, you have to confirm before this. So, at the moment, first moment, you have to know that whether you are dealing with a case of hypertension or no hypertension. The fault may be in yourself, right? Or the fault will be with the patient concerned. So, you have to go see both the poles, that where is the problem. Pathophysiology, the vicious cycle in diabetes, we all know that the core drivers are RAS overactivation, volume expansion, this is very important, and sympathetic nervous system overdrive with vascular remodeling. These are the 4 main components on which we will just be discussing our all points of discussions. Confirming true resistance and excluding pseudo resistance. We all know that how to record it properly, because majority of the times the doctors are not in a practice of recording it themselves. And if you become more senior and senior, then you have to rely more on your other partners who are not well trained, I must tell you. You have to confess that I do not know how many of you are recording the blood pressure yourself and taking the correct instrument, the correct position of the patients and all that. So, the thing is that what is the thing what is going to help you out? We all know that at least 2 things, home blood pressure monitoring and the 24-hour ambulatory blood pressure monitoring. These are the 2 golden things. The best is 24 hours ABPM. But how many of us have the access to this one? So, it is better to have a home blood pressure monitoring. You must teach the patient, always take an important step. You just teach the patient yourself, not through your paramedic help and other things. So, now we will be coming to whether the patients are taking the drugs properly or not, whether the drugs have been prescribed properly or not. I have seen a couple of prescriptions even by my postgraduates, friends, that they have been taken just ACE inhibitors with ARBs, which is usually a normal contraindication, not an absolute contraindication, but a normal contraindication that we should not combine these drugs. So, the 2 drugs from the same class, we have seen many prescriptions and we are looking for it. So, we have to find out all these aspects. We have to look for the masked hypertension, or we have to find out a reverse dip and all that. Diagnostic algorithm for secondary hypertension is clinical, lab references, hormonal and the advanced forms. So, in clinical you have to screen for OSS symptoms, snoring, daytime sleepiness, physically abdominal bruit, weak pulses, moon phases, review all medications, particularly the NSAID, steroids and the many home care medicines. That means the Ayurvedic medicines and all others not to quote, but I will definitely quote Ramdev Baba type of drugs you are taking, and you do not know what is the composition and what the things are there inside this. Serum creatinine and eGFR is very, very important. We had a lot of discussions in the morning session with the eGFR. But I think every one of us should have, our mobile, the eGFR calculator by the CKD EPI techniques, and that gives you a good help. Electrolyte monitoring is very important, particularly with hypokalemia. Urine analysis is one of the most important aspect of diabetic nephropathy. Everybody knows this. If you just go on testing serum creatinine and other things, it is a forgetful thing. I think you should just do one routine urine and you will be getting most of the answers, and that will be guiding your step care approaches towards what investigation should be taken later on. Check the TSH and fasting glucose levels, but definitely whether the confusion is that whether the fasting and the postprandial, which one, both are there, they both have to be there, and it is the complete oral glucose tolerance test which has got a golden outlook, I will say, and it has even match to match with HbA1c collaborations and all that. Hormonal assays measure the PSA and PRA for primary aldosteronism, calculate aldosterone to renin ratio ARR, screen for pheochromocytomas, and they look for the level of the metanephrin in the urine. Then after all these aspects, we have to look for the imaging, Doppler, CTA, MRI for renal stenosis, but don't miss for a brew, right? If you are finding hypertension, you must palpate the femorals, and if you find a poor femoral, then you go for looking for a coarctation of aorta and all that. A very simple bedside thing is all these things. 24-hour urinary free cortisol for Cushing syndromes. So these are some points which will be telling you about the secondary causes of hypertension and how to screen for them in general. Chronic kidney disease and diabetic nephropathy, as we all know, we have to look for a glomerular damage. Prolonged high blood glucose damages the kidney filters. This leads to protein in urine and declining urine functions. Progressive reduction in the eGFR is much more important than a single noting of the eGFR. Fluid and sodium retention is very, very important because these are all mediated by the RAS activations and the other factors. The vicious cycle is hypertension accelerates kidney damage, and in turn kidney damage makes the blood pressure even harder to control. So in a patient, when they are not responding, kindly look for a kidney disease. Don't miss it, and that is very important. Don't go by the level of the serum creatinine only. Always consider the whole platform of the CKD-EPI. What is the age of the patient, what is the sex of the patient, what is the serum creat level, and then the simple calculation it will be telling you. For example, if there is a male 70 years and serum creatinine is 1.2, you may overlook it. But the moment you just write 1.2, 70 female, you will find it is stage 3A or B. So imagine the situation, just by changing the feeding the correct data, you all know that where you stand like that. Pathological comparison between these renal biopsies, these are for our academic purposes. We need not worry for all these aspects. Renal artery stenosis, as just go by the Brui and then confirm it by doing the various techniques of just doing an ultrasound Doppler. If done properly, you don't worry about it. Don't go by the CT, MRI, angio and all that. That is the later component when you are going for the corrective surgeries and all that. Primary aldosteronism, an underdiagnosed endocrine cause. The pathophysiology is it leads to a sodium retention, potassium excretion. So if you have this type of combination, a hypokalemia with hypertension, kindly look for aldosteronism. Only very simple line. Hypertension with hypokalemia, please rule out the primary aldosteronism, and that is very important. Pheochromocytoma, as we all know, that these are the phagic things, paroxysmal problems, and these are the tumors of the adrenal medulla secreting catecholamines. The different types of bursts, the burst of profuse sweating, palpitations and severe headache are one with hypertension points you that these episodic natures and the paroxysmal things are pointing towards pheochromocytoma, and you have to do a good CT scan or an MRI, whatever you feel like, and the availability of the patient, then you can just diagnose and go for the proper treatment. Cushing syndrome is cortisol and metabolic impact. Always remember, Cushing's are of two types, primarily a disease or the iatrogenic one for which the doctors are responsible. Right? In a very bad condition, we all know, even the pediatric populations, you find out that the kidney problem is there and you just inadvertently think that it is a membranous glomerulonephritis and the nephropathy and you are using steroids. And you are not exactly knowing what is the basic diagnosis. And without doing that, and without whether the steroids are to be used or not to be used, so that is all depends upon you. So never just cause all these problems. We all know that cortisol promotes volume expansion of the renal level, and that is very, very important aspects. So diagnostic workup is a 24-hour urinary free cortisol level and dexamethasone suppression test. These are very simple tests, and you can just do it to diagnose all these things. OSA is one which is just like a myocardial infarction. It's almost an equivalent of the coronary artery disease. Just correct the OSA, just correct the snoring. Take the history of snoring. The patients are usually obese and snoring, और कहते हैं कि ट्रेन में चल रहे हैं, पूरे डब्बे को हंगामा कराते, किसी को सोने नहीं देते हैं. घर में पत्नी आती है कि पति सोने नहीं दे रहा है, and vice versa and all that. So these are the things, these are very simple things. Confirm this by sleep studies and go by the CPAP, and you are okay, and fantastically you have improved. Thyroid functions, we all know the hypo and hyperthyroidism. Both have to be evaluated. And hyperthyroidism, we all know that tremor, tachycardia, palpitation, eye signs, if it is there clinically, it is hyperthyroid, and the reverse, bloated, feel, croaky voice, loss of eyebrows and all that is hypothyroidism. Go by the tests and do it. Always remember, Always do a free T3, T4, TSH, and in cases of the younger individuals or in females in 30s and 40s, rule out thyroiditis. That is very, very important, because sometimes the patient will come with hypothyroidism and sometimes with the hyperthyroidism. So unless you do a AMA, that is antimitochondrial antibodies, you cannot diagnose it, and particularly always test for the antibodies to the thyroglobulin. So these things are very, very important. This medication-induced hypertension, we all know, NSAID is very important. Sympathomimetics, simply by taking nasal drops, frequent nasal drops, rhinitis medicamentosa you are creating. And these are the very simple things which can lead to a hypertension and patient not responding. Steroids, I have told you earlier, this oral contraceptives are very important. Licorice in multiple drug combinations of Ayurveda, you will get these things. Lifestyle and metabolic drivers of resistance, that is very important. Excessive salt, obesity, physical inactivity, alcohol intake. Physical inactivity means 150 minutes of walking per week. That is important. You have to walk 10,000 steps a day, at least a minimum of 5 by 7, 5 days. It is better to walk 7 by 7, but at least 10,000. I just saw one of my friends, I asked him, how much you are walking? He said 10,000 steps daily. मैंने कहा कितना टाइम लेते हो? तो कहा कि मैं 2-4 हज़ार वॉक करता हूँ सुबह में, फिर दोपहर में, फिर शाम को. कितने टाइम में करते हो? तो आधा घंटा, आधा घंटा, आधा घंटा. वो 1.5 घंटे 2 घंटे में कवर कर रहा है 10,000 steps. That is not fair. So you have to do an intensive exercises, walk at least for 25 minutes. We start with a normal pace, increase the pace for 15 to 20 minutes, then shut down slowly. Never start the motorcycle and at the top gear, or try to end the top gear with a good brake. So that will be a problem. All these aspects we have to find out. Insulin resistance, we all know, sympathetic overdrive, refractory hypertension. Pharmacological management, a stepwise approach. Optimize the triple therapy. Switch the diuretics from hydrochlorothiazide to chlorthalidone. And always remember to correct the hypokalemia. Remember, hypokalemia is one inadvertent complication of all these aspects. And don't forget also hyponatremia, particularly in the elderly individuals. Hyponatremia has been reported much more commonly, and that is very, very important. The patient comes usually with coma to you. The fourth drug in the refractory hypertension is spironolactone. You have to use it from 12.5 milligram to 50 milligram per day, and that is very important. Consider the alternatives, eplerenone, finerenone, and or the lower hypokalemia risk, and all the other things. Indian context, RSSDI recommendation, first line choice preferred, we all know. ARBs are the first line, avoid beta blockers, except for certain specific conditions when beta blockers are indicated, and they are all like the nevabilol and other drugs, which are very, very important. But always remember one thing, we have masked the autonomic neuropathy and all that. So inadvertent uses of the beta blockers, that also non-cardio selective, should be definitely be avoided. That is very important. Avoid thiazidex because they also not only cause the hyponatremia but also cause the worsening glycemic control. The preferred combo is ARB plus cilnidipine. You have to increase the doses therapeutically and go to the highest level, therapeutic level, and then add on the drugs to reach up to 5 drugs, as I told you at the outset. Lifestyle mode, key shift, physical activity, inactivity should be taken back, be more active, salt restrictions, walk, brisk walking, emerging pharmacological therapy, aldosterone synthase inhibitors, bragdostat and lorundrostat, dual endothelin receptor antagonist, aprocitentan, and the zilebesiran. All these drugs are now getting available in India. I am telling you, these are drugs with limited usage, and they are available in India these days. Now, device-based therapy, we all know. I am not going to detail. Renal denervation therapy. They take away this. Come last slide. Systemic evaluation, always do a proper clinical evaluation to diagnose most of your cases. Clinical should be at the best of your mind, and you must be well aware about all these aspects. Optimize the therapy, see the patient is taking the drugs, make them answerable, make them just check their stocks at times. कि आप जो दवा ले रहे हो कितनी दवा है, 30 दिन की दवा ले गए, 20 दिन बाद आ रहे हो, पता चला 15 दिन की दवा पड़ी हुई है. That means they are not taking the drugs properly. And the lifestyle changes, they are all there. Thank you very much. Sorry for I just took a couple of minutes extra. Thank you.
Thank you, sir, for simplifying this topic so well for all of us. Thank you very much. We have all benefited. And we'll move on to the next session.
Thank you very much.
Thank you, sir.
Anupam, aaja.
So I now invite Dr. Anupam Prakash. Thank you for having come all the way. And he will be speaking on handling steroid-induced diabetes, real-world challenges. Over to you, sir.
Well, thank you. Very good evening. I understand that we are in a bit of hurry. So at the outset, it is a proud privilege to be here. Thank you, chairpersons. Thank you, the organizing committee, especially Dr. K Singh, Dr. Gagan, Gunjan, Dr. Shaibal was here, and the whole senior fraternity of Bihar. Bihar is just like a second home to me, and I have been there at Epicon also. Dr. Hemshankar is there, Dr. K Singh is there. So the topic that I will be dealing upon is steroid-induced diabetes. Move करेगा? So handling steroid-induced diabetes, real-world challenges. So when I reviewed the data, this is a very important topic, and steroids today are being used much more than what they were being used earlier. And so it is important to understand how this physiology works when we start steroids on patients. And there are a couple of things which I will not exceed the time, and I will try to cover the important things only, because most of the things I know, most of us are well versed with this. But it is important to understand that there is a whole lot of diseases. Now increasingly we are diagnosing autoimmune disease. We have a pointer? COPD, bronchial asthma, neurological diseases. You have so many diseases we are using steroids. COVID saw a flare up with steroids. And if you go by the pathogenesis, so we all understand that glucocorticoids, they are, okay, thank you. So glucocorticoids, they cause hyperglycemia. They increase the glucagon pathway also, and that is how they actually cause hyperglycemia. The important thing is that I will skip the epidemiology. This was one of our studies. So we had, this is hospital hyperglycemia. Now this is not related to steroid-induced diabetes, but I try to understand, this is patients who come to hospital. 50 patients were there, and you can see out of these are 50 hospital hyperglycemia patients, and half of them were diabetics or pre-diabetics, and 50% of those, that means 25, were not aware that they are having diabetes. So this is important. I just want to say, stress hyperglycemia or hospital hyperglycemia, as we say, in these hospitalized patients, stress hyperglycemia, the confounder or the causative factor is steroids. So we have to understand this, that steroid-induced hyperglycemia is very common probably. And we followed these patients for a period of 3 to 6 months, and we did an OGTT in these patients. So those who were normoglycemic at discharge, they did not become diabetic, but those who were pre-diabetic, 50% of those converted to diabetes. So you can see, if you have stress hyperglycemia, you are at increased risk of developing diabetes. So these are the common steroids that we use, but the important thing is that risk of steroid-induced diabetes increases with the potency and dose. Higher doses, longer duration, and repeated steroid use, all three will result in a greater propensity to cause steroid-induced diabetes. Mechanism I have already mentioned, but yes, you have hepatic effects of glucocorticoids which stimulate glucose production. I told you they have effects on glucagon pathway also. The peripheral effects are increasing insulin resistance or decreased insulin sensitivity. So the muscles, they become less responsive to insulin, probably because of the glucagon pathway. So steroids act both on the liver as well as peripheral muscle, causing increased propensity to cause diabetes. Now this is the pattern that we see. So when we give steroids, apart from the IV steroids, if you give oral steroids in your OPD practice, you try to give it either morning dosing, or you split, if you are giving a higher dose, as morning and evening dose. And this is what happens. Fasting will remain normal, and if you are not aware of this, you will miss that your patients are developing hyperglycemia through the day. So that single dose of morning steroids will not alter fasting plasma glucose, but through the day it will have a marked post-meal hyperglycemia, and which will peak during evening or late evening. So if you are not monitoring patients, or if you are not suspecting that your normal patients will become pre-diabetic or diabetic, then the evening dose, if you are splitting steroids, that evening dose will further contribute to a higher dose of hyperglycemia in the evening. If you are using it IV, then obviously any injection that you give, within a few minutes to hours, you will have hyperglycemia, and that is unpredictable. It will depend from person to person how high it is. So this is just an example. I told you morning steroid dose you give, there is a normal morning glucose and significant hyperglycemia, especially postprandial, which is very, very important. Risk factors: increasing age, obesity, family history of diabetes, pre-diabetes state, and metabolic syndrome. So just like we were discussing in the debate, more the number of risk factors for metabolic syndrome, more chances that you will have hyperglycemia because of steroids. This we discussed. So high steroid dose, longer duration, potent steroids such as dexamethasone, multiple daily dosing, and even patients if they are having repeated courses of steroids. So these are all risk factors which predispose individuals to develop diabetes, steroid-induced diabetes. Manifestations are more or less simple, just like other types of diabetes, but the important thing is, again, just like other diabetes, it is asymptomatic or they are vague. So you will not suspect, and especially if you are giving patients steroids, you know these symptoms are there for all patients who actually require steroids, like COPD, neurological illnesses. So unless until you have a high index of suspicion, you will not be able to diagnose this. So this I already said. So when you encompass the definition, so either it is a new hyperglycemia after steroid initiation, or unexpected worsening of previous diabetes control. And marked postprandial glucose spikes is what we actually should always suspect. So if the patient had spikes but now they are much more after giving steroids, you should suspect that it is the worsening is because of steroids. Complications, we already had a lecture, hyperosmolar hyperglycemic state, and this is one complication which can occur with steroids. Less likely to have diabetic ketoacidosis, and any patient who has recurrent infections, you should always suspect that yes, the patient may be having steroid-induced diabetes. The recommendations are the same because the diagnostic criteria are the same for other parts of diabetes. So you can screen high-risk patients wherein you are starting steroids, measure fasting glucose, but always check post-meal glucose, maybe post-lunch, maybe post-dinner or a pre-dinner at that time also. And if you are in doubt whether it is steroid-induced or a pre-existing diabetes, HbA1c would be helpful. That we did for our study also. So diagnostic criteria is the same. So fasting plasma glucose more than equal to 126, but these are for steroid-induced diabetes. But remember, steroid-induced dysglycemia or pre-diabetes is also going to occur in your patients. And you should follow those patients who have steroid-induced pre-diabetes or dysglycemia, because they are the ones who have more propensity to develop diabetes later in life. Monitoring strategy, so hospitalized patients, yes, you can do a pre-meal blood sugar charting and a bedtime glucose charting. Outpatients, you should enforce self-monitoring of plasma glucose or blood glucose in these patients, and more frequent testing during steroid therapy, and maybe later on you can screen them for with an OGTT if they normalize. The principles of management, I said high index of suspicion, so you need to have an SMBG or monitoring for early recognition. Glucose monitoring as SMBG is very important, and all the evening we have been talking about lifestyle measures, so they remain in vogue in steroid-induced diabetes also if you want to prevent it. And pharmacologic therapy when you require it, especially in hospitalized patients, you will need to give pharmacologic therapy. So what are the options? Lifestyle, I am not going to go into the details because this has been dealt in great detail in the workshop also. Dr. Modi was there. Pharmacology therapy, you should understand metformin for insulin resistance, important. Sulfonylurea, short acting for postprandial hyperglycemia would do. And DPP-4 inhibitors may be used because they do not cause hypoglycemia, so morning normal fasting blood sugars would be controlled. We do not have evidence about use of GLP-1 receptor agonists, SGLT2 inhibitors, but they will be good drugs to control, probably because these days there are not many studies on steroid-induced diabetes. And remember, these drugs, especially if you have patients with cardiometabolic risk, this is the standard of care and you should use. But invariably, especially in hospitalized patients, you will need to give insulin. And especially if you are giving steroids for a shorter duration, with better control, it is always wise to use insulin. So, insulin is preferred for moderate to severe hyperglycemia, especially in hospitalized patients, and will allow rapid titration. So, that is what short courses will benefit. NPH insulin can be aligned with steroid timing in the morning, or you can give basal bolus regimens, or correctional insulin if it is only moderate hyperglycemia. Now, these are special populations which you need to take care of, especially the new onset diabetes after transplantation, which is very common. At times, cancer patients also receive dexamethasone, which is a potent steroid. So, you need to take care of these patients. And the principles by and large would remain the same. So, that is what prognosis, I told you, hyperglycemia may resolve with steroid cessation, but patients may develop diabetes later on. So, screening on the vigil for the patients who develop dysglycemia on steroid use is very important. So, a follow-up is very essential. So, the key take-home messages are steroid-induced diabetes is common but frequently overlooked, especially if you are not going to screen the patients whom you have advised for steroids. Postprandial hyperglycemia is typical, so that is the way you need to screen. And monitoring is essential for patients who are given steroids. Insulin would be required in most of the cases for moderate to severe hyperglycemia, and obviously early treatment would improve outcomes and prevent complications like infections and HHKS. Well, thank you. Thank you for a kind attention. I have finished before time.
Thank you so much. Not just for finishing within time, but also for speaking on a topic which is clinically so relevant. We all come across these patients, and you have given a wonderful overview of the problem. Thank you so much.
Thank you so much. Thank you. Thank you.
And with this, we end this session. Thank you. Sorry, we have one more speaker. So, we move on to the next talk. The speaker is Dr. Sankar Sen, and he will be speaking on the future of diabetes classification towards a more dynamic phenotypic based system. Over to you.
Thank you. Thank you, CCDSI Bihar and Jharkhand, for inviting me. I am from Siliguri in the Darjeeling district of West Bengal, but I was a PhD student from PMCH Patna, so it's more of my hometown, home state only, Bihar. The future of diabetes classification towards a more dynamic phenotype-based system. So this is something I'm going to discuss, is nowadays being discussed quite often regarding type 2 diabetes. And at the outset, at the 10th annual conference of CCDSI Bihar Jharkhand, as the Secretary of the West Bengal chapter, I invite you all to the 5th CCDSI conference of the West Bengal chapter, which will be held at Siliguri on 6th and 7th of June 2026. A hearty welcome to all of you for our 5th annual conference. So regarding heterogeneity of diabetes, as pointed out by the respected chairpersons, that the phenotype is quite important because all diabetes are not homogeneous. Heterogeneity of diabetes, so the question is, are all type 2 diabetes same? Type 2 diabetes is a diagnosis of exclusion. So this is very important. For us in clinical practice, we have to rule out the autoimmune diseases like type 1 diabetes, latent autoimmune diabetes in adults, the genetic diseases like maturity onset diabetes, MODY, neonatal diabetes, other secondary diabetes. If none of the above are there, then we say that this is type 2 diabetes and this is a diabetes of exclusion. The current diabetes classification, we know that type 2 diabetes is the major holds the major chunk of the overall prevalence of diabetes, and the heterogeneity is based on clinical characteristics, the type, the risk of complications, the response to treatment. We know the treatment varies from person to person, and even with the BMI and age of onset, the heterogeneity remains. So the diabetes classification is there since the time of Charak Shishtuta in 500 BC to in recent times, and type 1 and type 2 has been differentiated since long. But why do we need to classify a disease like diabetes? Because we need to guide the diagnosis by right diagnostic tests so that correct treatment can be planned, like insulin is to be given from the beginning in type 1 but not in type 2. We have to personalize the treatment, we have to treat GDM differently and predict the disease progression, complication risk and long-term outcomes, and also the epidemiological and public health insights, and the research and drug development, medical communications, and to translate scientific understanding to clinical practice. So presently, we have only 2 clusters of type 1 and type 2, but across the globe, many groups are working on combining clinical, pathophysiological, and genetic characteristics to define the subtypes. So diabetes is a heterogeneous disease. We think of hyperglycemia, we come across this ominous octet. So there are various pathophysiology of treating diabetes or diagnosing diabetes, but this ominous octet, which was proposed by Dr. Di Fronzo way back in 2009, is something which has been in our clinical practice from that beginning to think of pathological defects and also to plan treatment. So the C-peptides, the markers of autoimmunity, the obesity, the presence of complication, whether the diabetes is ketosis prone or ketosis resistant, and the age of progression, all are very important. So there are various classifications, see WHO into 1965 to WHO classification into 2018, 19 onwards, there are various classifications. But for type 2 diabetes, we have something new to offer today. So model of heterogeneity has been propounded like this type 2 diabetes, by whether it is monogenic or secondary, whether the different pathways are there and certain clinical parameters, so the need for clustering or classification of diabetes. So I will be discussing on the palette model where the many molecular pathways involved in the diabetes pathogenesis are represented as colors, and each individual with type 2 diabetes is represented by mixed colors as in this picture in B. But the Andes model became very important because only clinical parameters were taken into account. So what is this Andes model? In 2018, the all new diabetes in Scania, a classification was done which measured or assessed in clinic the BMI, the age, the presence or absence of GAD, the HbA1c, the HOMA-B and the HOMA-R. And with these 6 parameters, they propounded the theory in 2018 that there are 5 phenotypes. What are they? The severe autoimmune diabetes, the severe insulin deficient diabetes, severe insulin resistant diabetes, are 2 mild variants like mild obesity related diabetes and mild age related diabetes. So the novel subgroups of adult onset diabetes and their association with outcomes is very important, and this 5 cluster classification was very important, and the phenotypic classification came into being. For mild age related diabetes, it's a very late onset diabetes and a less progressive disease, while a mild obesity onset diabetes is high BMI, early onset, but a less progressive disease. But we commonly come across the severe autoimmune diabetes where the GAT55 is positive, and severe insulin deficient diabetes where there is low BMI but a high risk of retinopathy and neuropathy. Very importantly, the severe insulin resistant diabetes is one which is having high BMI, late onset but higher risk of chronic kidney disease. So these all parameters came into being, and ADA also accepted this, that there are various phenotypes in type 2 diabetes. So to identify the subgroup specific needs, to personalize treatment, to prevent misdiagnosis, and to optimize the medication choices, and to reduce the complication risk, as I said, the SIDD, the insulin deficient ones, the retinopathy, peripheral neuropathy and autonomic neuropathy predominates, while in the insulin resistant ones, the CKD, the non-alcoholic fatty liver disease all predominates. So these are all the classifications, and these are the various mechanisms, and also the treatment approach varies for all these 5 classifications. Now, after this Andes model, what is important is we needed to replicate it in other Chinese, other Korean, all populations were studied. But it was studied in Indian population. The first was a small Welgian study was done in certain states, mainly from Dibrugarh, Dr. Anupam Datto and Sanjeev Kakatiyan team, Bangshi Shabu's team from Ahmedabad, CSA Agnes team from Pune. There the clustering was done, but GAD65 antibodies were not measured because it was not so easily available. But the other characteristics of classification from the Andes model from Sweden were taken into account. And the subgroups of patients with young onset type 2 diabetes in India revealed insulin deficiency as a major driver. So unlike the type 2 diabetes where insulin resistance is the most important thing, in India insulin resistance along with insulin deficiency was also there from the beginning. There was no GAD65 results in Indian patients. So is the SIDD hiding mild type 1 diabetes, the predominant subtype in young type 2 diabetes, was the question. Later, various other studies also were planned, and there were certain clusters like SIDD, IROD, I will be going into a bit details of this, CIRDD and MARD are the 4 clusters which are described. Severe insulin deficient diabetes was there, insulin resistant obese diabetes was there, combined insulin resistant and deficient diabetes was a new cluster, and this was the most ominous form of the diabetes, and mild age related diabetes was there. So the ICMR India diabetes study was done, and it was done in many centers all across India. The age at diagnosis, the BMI, the waist circumference, the HbA1c and serum triglycerides and HDL cholesterol, the lipid profile came into being in this particular study along with HbA1c and waist circumference and BMI, and it was a multi-center study, and there are 4 clusters which are representative in the Indian ICMR studies. So we know about the Asian Indian phenotype which are having high abdominal fat, increased insulin resistance, a low BMI with a high body fat percentage. We have high triglyceride with a low HDL, and very importantly the main difference with white Caucasians, like if they're getting insulin resistance, we had also beta cell dysfunction. So diabetes at a younger age, at lower levels of obesity, which tend to progress faster from stages from pre-diabetes to frank diabetes, were more predominant in Indians, and beta cell dysfunction occurs quite early and rapidly in Asian Indians. So these were the parameters, and the INSPIRE study then came into being by Dr. V. Mohan's team. It was just around when COVID in the corner in 2020, the novel subgroups of type 2 diabetes were again studied. I'll be skipping some slides because of the lack of time, but again here the C-peptide were also studied, and along with the BMI, waist circumference, serum triglyceride and HDL. So the 4 classifications which are found in type 2 diabetes by these studies were the severe insulin deficient diabetes, around 26% of the population, insulin resistant obese diabetes, around 25.9% of population. Very dreaded is the combined insulin resistant and insulin deficient diabetes, around 12% of the population, and around in 36% of the population it was mild age related diabetes. So very importantly, the insulin resistant obese diabetes and combined insulin resistant diabetes deficient are the novel clusters which are found in the Indian population. So if we compare the Andes model which was done in Sweden compared to the Indian population, the CIRDD is a unique phenotype, difficult to control with more risk of retinopathy and nephropathy, while insulin resistant obese diabetes is the obese group is another novel group which was found in this Indian population. So to summarize, the severe insulin deficient, insulin resistant diabetes, metformin is the first line of therapy, SGLT2 inhibitors, GLP-1 receptor agonists help, thiazolidine helps in improving insulin sensitivity but may cause weight gain. For severe autoimmune diabetes, the insulin therapy needs to be done from the beginning because of the presence of autoantibodies, GAD65, IA2 and so on, and we should avoid sulfonylureas and may consider adjunctive therapies like GLP-1 in these patients. Severe insulin deficient diabetes, early insulin therapy to prevent glucose toxicity, GLP-1 receptor agonist may help with glycemic control, and severe insulin resistant diabetes we know, metformin, the SGLT2 inhibitors, the GLP-1 receptor agonists and so on, which we commonly use. And most commonly the mild obesity related diabetes is very important. GLP-1 receptor agonists are nowadays semaglutide widely available, and the prices are coming down, probably more wider usage will be there. Metformin and SGLT2 inhibitors helps in these obese related diabetes. And the least discussed, the older onset age related diabetes of more than 60 years, these are the mildest form of diabetes. Mainly lifestyle modification might help, but we can add a metformin or a DP4 inhibitors which have less chances of hypoglycemia in the older population. So for SIDD, more of insulin plus OADs may be considered. For SIRD, the insulin sensitizers plus SGLT2 inhibitors. For mild age-related diabetes, DP4 inhibitors may be the first line along with metformin. And for obese diabetics, the GLP-1 as SGLT2 inhibitors are in our armamentarium to fight this disease. So to summarize, the European cluster's algorithm works in Indian type 2 diabetes patients also. Severe insulin deficient group is most common in Indians compared to the Caucasians. Mild obese group is most common in Swedish. They are associated with various complications. And first time in India, the clustering was done in individuals with type 2 diabetes using 8 clinically relevant variables. And the novel cluster of combined insulin resistant and insulin deficient diabetes is of particular importance as it is characterized by difficult to control hyperglycemia and increased risk of kidney disease and retinopathy. So SIDD has the highest risk of retinopathy and neuropathy, and SIRD has the highest risk of diabetic kidney disease and fatty liver. The classification can be done at diagnosis based on NDIS clusters and could be useful in clinic to predict risk of complications and guide choice of medication. So my take-home message is we must consider autoimmunity, insulin resistance, insulin deficiency, comorbidities, end organ damage risk when we plan treatment of a patient with diabetes. And phenotypic classification is a foundation for future research into the genetic and environmental factors influencing the diabetic phenotypes. This is a small chart which can enumerate all these types of diabetes which are found in Indian population, which was done recently. This diagram by the daughter of Dr. Abdesh Kumar Singh, a renowned endocrinologist from Kolkata, and she has done this diagram, and this has been advertised in the international journals. Thank you all for your patient hearing, and I again invite you on to our the foothills of Himalayas at Siliguri during 6th and 7th of June. Thank you.
Thank you, Dr. Sankha sir. This was a very nice presentation, and you opened our eyes towards the cause and the further guide in treatment of the diabetes from the very classification itself. Thank you once again.
Now this session is over. Thank you.
Till the time we prepare for the next session, for the inaugural session, I would call on the dais the chairpersons of the next session. Next we have a workshop, eco workshop, conducted by Dr. Ajay Sinha and Dr. Shraddha Ranjan. I would like to request Dr. Hemshankar Sharma, Dr. Umesh Khan sir, and Dr. Alok and Dr. Hemshankar sir, Dr. Hemshankar sir, Dr. Hemshankar Sharma, Dr. Umesh Khan sir, and Dr. Vikas Singh. Dr. Hemshankar Sharma, Dr. Umesh Khan, and Dr. Vikas Singh, please come on the dais to chair the next session on ECO. ये अभी इधर से तो कोई दिक्कत नहीं है.
Hello. Vikas. Yes. Friends, we are here for a very short course, and I know all these very intelligent persons can do wonders in the shortest possible time. So may I request Dr. Shraddha to be here And my very dear friend, Dr. Ajay Kumar Sinha sir, please be here. No, she is there, but without the boss, it is मैं अकेला बहुत देर चलता रहा. इधर से ही सर, इधर नहीं तब सही का. अब उम्र वो वाली नहीं रही आपकी. Friends, the thing is that you just lend your ears and eyes to the speaker concerned, and what she is letting us know, she will make us enriched by the knowledge of the eco.
Yes, sir.
Right? Because तुम इधर आ जाना दिखेगा, हमको तो कुछ दिखने से ही फर्क नहीं पड़ रहा है. सामने दिखेगा, अच्छा हम लोग देख. Over to Shraddha.
Okay, we'll
15
start,
minutes.
Without wasting time, I'll start, sir. Thank you, organizing committee and the patrons of CCDSI for inviting me for this eco workshop. So this is the last session of the day. We'll be very quick. We'll show some interesting cases and then off to inauguration ceremony, I suppose. So this is case 1, 68-year-old female who presented with dyspnea, cough, orthopnea. She was on medical management for LV dysfunction, mild aortic stenosis from 2-3 years. Her symptoms worsened, quality of life was very poor, ECG showed an normal sinus and LBB, angio was also done, CT chest was also done, everything was normal, but she didn't improve. So this was her echo, and as we can see, the aortic valve was very calcified. Definitely ejection fraction is low, but what we find that aortic valve is calcified, but we are not getting gradients. 20 mmHg was the mean gradient, which qualifies as mild aortic stenosis. So what was to be done next? Should we have continued the medical treatment? Does the echo needs to be repeated? Maybe we can give her some advantage for the CRTP or deimplantation. Should we look at T, do DSE, or straight away send her for aortic valve replacement? So the answer is simple. 2D echo with continuity equation. When we calculate the aortic valve area by continuity equation, it was 0.7 centimeters square, definitely severe aortic stenosis. So this was a case of classical low flow, low gradient severe AS. And always the message is here that in low flow states, like if the ejection fraction is low, the aortic valve gradient will not come up to be severe aortic stenosis even if the valve area is very less. So the message is here, if we find a report of severe LV dysfunction with mild aortic stenosis, we have to double check it. Always aortic valve area has to be calculated. The gradients have to be taken in whatever way we can find it to be, maximum. And I will not go into details of this. What it says that there is an entity called low gradient AS. Low gradient AS will recover with aortic valve surgery, and these patients will have a entirely different course of life. So we don't have to miss that. So that's the message today. And when this patient was, we did a dobutamine stress echo on it, and we can see on the right side of the screen that her gradients increased after the dobutamine stress echo was done. So this is a method to confirm that actually the aortic stenosis was severe. And another method which can be used is calcium score of the aortic valve. If the calcium score is more than 1600, it is quite likely that the aortic stenosis is severe. And these patients will definitely, if the contractile reserve is there, they will benefit from aortic valve surgery. Now coming on to case 2. She was a young female who was referred to emergency with a history of alleged fall from height 2 days back. She fell from the roof of her house. So she was in shock, on double inotropic support, very tachypneic, and the things, pneumothorax and all these things were ruled out. She got intubated, E-fast was negative. Then bedside echo was done. It showed that she had a global hypokinesia with a very severe LV dysfunction. ECG was not very informative, sinus tachycardia. The troponins came up very high. NT-proBNP was very, very high. So something was missing. So this was the echo. It just showed that the ejection fraction was very low, and there was some mitral regurgitation, which was more than moderate. So there was a confusion whether it was mitral valve injury or something. X-ray was full-blown pulmonary edema. We can see the fractures of the bilateral superior pubic ramus. So definitely the injury was there. But what happened to her? Why she was having dyspnea? So next step, whether she has to be sent for mitral valve replacement, should we do an angiography because the troponins are so high, should we stabilize her, IBP, ECMO, what to be done? What we did, we just tilted the probe a little bit, nothing much. We just tilted the probe and we could find that, sorry. We could see that there was a disproportionate movement in the, this is not moving. What we could find that the base of the left ventricle was not moving well and the apex was moving very hyper, it was very hyper mobile. So that was actually a reverse Takotsubo cardiomyopathy. We know that there's a classical Takotsubo cardiomyopathy looks something like this, where the base moves, base is very, base moves a lot and the apex gets ballooned up due to the stress. But there is an entity which is reverse of it, which was in our patient. So when we had a suspicion of that, we did nothing. We just absolutely did nothing, no angio, nothing. We just stabilized her, supportive management, and she recovered completely. So that's how a patient who was very sick, if we would have intervened with angiography or IBP, because we knew that this is a stress cardiomyopathy, type of a stress cardiomyopathy, she is going to recover in a 2-3 days. So that's how, and we were able to publish it as well. So the classical stress cardiomyopathy, the shape is Takotsubo, which is octopus spot, and this reverse Takotsubo cardiomyopathy, it is sometimes it's like a squid shaped.
So the case 1.
Yes, sir.
You said that the angiogram was taken 6 months ago. It was a non-critical disease,
normal.
right?
Yes, sir.
So once we took the decision of doing the AVR,
yes, sir.
So before that, I think another angiogram can be done or should not be done?
I don't think that's important, sir, because 6 months only and it was normal.
What is the average life of expectancy? That means what is the time duration for one angiogram to the second angiogram? If it is 6 months and beyond, then you should go for the another one, or should you wait?
I don't think so, because degenerative atherosclerotic process will take that much. If
I don't go by thinking, go by guidelines. What the guideline says. Ajay sir.
I don't think that there are any guidelines regarding this, sir. And if somebody at 60 years of age has normal coronaries, so it's very, very unlikely that she is going to have it in 6 months.
I don't think there's a guideline for that.
I don't think there is.
No.
Before AVR, we have to have one angiogram. Yes.
AVR, you should have an angio first.
Sir, definitely.
So that is what I wanted to insist.
That we have
Any
to have.
valvular surgery, you have first to go with the angiogram, then find out, correct that, and then go for this.
Yes,
so thank you very much.
Yes, sir. So another, we had one trauma case. This is also a good, interesting trauma case. So I just wanted to share this. This is just few days back we had this patient. He also fell from tree, and he had multiple fractures, and he was in fulminant pulmonary edema, which was actually missed because he had pleural effusion. It was thought that okay, tapping was done. It came out to be transudate. So like this, his course was quite dramatic from the last 10 days, and he was not improving. And ARDS was suspected, VAP was suspected that he is having pneumonia. Echo was done, there was moderate AR, normal LV function. So it was not a stress cardiomyopathy also. So we thought that AR is maybe, it is pre-existing. But then something was not fitting, so we planned a transesophageal echo. And what we could see is that the aortic valve was completely torn, and there was a florid AR, which was not picked up on transthoracic because of limited window, and the aortic cusp were prolapsed. And this patient, when underwent to a surgery with aortic valve replacement and repair of that tear, and he is doing quite well. So that's the message, that if a patient is not improving, or in trauma cases, echo plays a very important role, and sometimes transesophageal can do wonders. Case 4 is a young female. She was just, she had a history of fatigue, weight loss from few months, 2-3 months, and then she had a stroke. The relatives were very concerned when brought to, she was admitted in neurology and was sent to us for an echo to rule out cardioembolic cause. We found small vegetation-like structures on the aortic valve, but her blood cultures were negative, and these structures were not very classical of infective endocarditis. And so we suspected NBT, that is non-bacterial thromboendocarditis, which led to a cancer workup, and actually she retrograde, she was found to that the CA125 was strongly positive, and on CT scan she was found to have ovarian CA. So these are the cases where sometimes echo will take you to retrograde to the diagnosis.
Why did you suspect for malignancy?
So because
normally one as a clinician, simple downtown physician, I will
Yes,
go
sir.
for a endocarditis or a subacute bacterial
Yes, sir.
nephritis or
So
what.
first we ruled out blood cultures. That is the first suspicion always. Blood cultures were negative. Then the neurology people had already worked up for autoimmune diseases because she
Okay.
was a stroke in young. Autoimmune diseases were also ruled out. Then there was something because these small vegetations are very classically NBT. So then we suspected, then the tumor markers were sent, and then in CECT she was found to have ovarian CA.
What other differential diagnosis you can think of in such cases other than malignancies?
Other than malignancies, autoimmune, any hypercoagulable state can cause these things. Sir.
Yeah.
Yes.
So did you rule out that?
Autoimmune was ruled out, definitely.
It was ruled
yes,
out.
Yes, For
Okay.
a stroke in young, neurology has already ruled out autoimmune.
Okay.
Yes, sir.
Thank you.
So do we have time? I can go on.
वो मेरे पीछे लगे रहते हैं, कोई खास बात नहीं है.
One more case. Okay, sir.
One more case, आइए, अभी time है.
So, it's 55-year-old female, and she was a known case of bronchial asthma on inhalers from many years. ECG showed right axis deviation, RVH, incomplete RBB, X-ray cardiomegaly, dilated pulmonary artery. So she was thought to be okay. She is a cor pulmonale, and on echo also we found dilated RA-RV, severe PH. Just because she was a naive case and we have not ruled out intracardiac shunt, but she was 55-year-old, we were not very optimistic or looking forward to get an ASD. But then as a protocol, we did contrast echo, saline contrast, and we could see that there was some right to left shunt there. So there was definitely, and negative shadow was there on the left side. So that this prompted us to do a transesophageal echo, and definitely she had sinus venosus ASD, which she was carrying from birth and was misdiagnosed. So any pulmonary hypertension we should always rule out intracardiac shunt. Like in this patient, we caught her at the age of 55. And with the help of pulmonary vasodilators and diuresis, this right to left shunt also vanished, and on the cath study, PVR was not very high, and she was operated, and she's doing very fine. So that's the message for that. Thank you, sir.
3 minutes अभी है, अभी आप और एक केस बताओ.
बताओ, ठीक है सर. सर, हाँ जी सर. Yes, so yes, there are now people are doing stent transcatheter therapies for sinus venosus ASD, and our pediatric cardiologist attempted with somebody came from outside, I guess, some mentor there, but that sinus venosus stent did not struck through, and then patient had to be taken for emergency surgery. So people are doing that, but still not very.
What sort of device you used that came out? Yeah, what was the size of the ASD?
I was not there, but it's a stent, sir. It's a sinus venosus stent.
It was 10 millimeter.
It's a stent there which covers the defect, and they go from the sinus venosus.
Sometimes it can get
superior
dislodged.
vena cava.
Yeah. Sometimes the device can get dislodged, no
Yes,
problem.
from superior vena cava it went to the RA and was actually obstructing the tricuspid valve. So that patient has to be taken to the
With
surgery.
this amount of pulmonary hypertension, what you suggested, severe degree of pulmonary hypertension.
Yes, sir, that's what I said. We were very careful.
What benefits do you expect in such cases post-operatively?
That's what I said, sir. We were very careful because this patient was naive. She was not on diuretics when I did the test. So we put her on diuretics, we put her on pulmonary vasodilators, then the pressures came down, then we did the cath study, then only.
So this you just concealed.
Yes, sir. It's a rare case, we'll just go quickly. 32-year-old man, again diagnosed as bronchial asthma, symptoms deteriorated, then somebody suspected, okay, this is heart failure, echo was done, and the diagnosis of rheumatic heart disease with severe mitral regurgitation was made. So he was referred to a CTVS for mitral valve replacement. We did the echo, we found something is not fitting, mitral regurgitation was there, but As we can see that the myocardium, we can see both apex, the left ventricular apex and right ventricular apex was obliterated. And mitral regurgitation seems to be a, the posterior mitral leaflet was definitely involved, but it doesn't seem to be rheumatic. So, and he had grade 3 restrictive pattern, what we call, so it was a restrictive heart disease, and 3D echo also confirmed that. Then we double checked his old papers and we looked at the CBC. He had 63% eosinophils. Mitral valve replacement was cancelled. A diagnosis of Loeffler's endocarditis was made. He was referred to pulmonology. Again, ANCA and CNCA, PNCA, everything was normal. Stool test was negative for parasitic infection. So this ruled out the secondary cause for eosinophilia. So this was a primary eosinophilic syndrome, and it may be idiopathic, but our pulmonologist, he is a very intelligent Dr. Saket, he sent the gene study for him, for this patient, and it came out to be positive for a PDGFRA gene, which actually which increases the tyrosine kinase activity. So imatinib acts on it. So he was started on imatinib, and the eosinophil decreased drastically to less than 1% in a month. So this was a patient of Loeffler's endocarditis, and he improved on imatinib.
Very good. Thank you very much. I think the time is over.
Yes, sir.
So.
Cardiac MRI we do for, whenever we screen these kind of patients on echo, we do MRI for them. Any suspicion on strain study, or if we find that the LVH is not, there is a hypertrophy, which is not, you know, there is a discrepancy there, we do it then. All the dilated cardiomyopathy, we try to do it.
No, thank you very much. And many take-home messages and points were there, and that a very well performed echo differs the cardiac MRI. Yes, that is one. Yes. Secondly, patients who are having COPD or bronchial asthmas, particularly recurrent breathlessness, they must be looked for RA-RV dilatation, and if at all it is there, you should be very cautious about it, that what could be the cause. Try to reach a cardiac cause. Other than that, so thank you very much.
Function is not normal.
Oh yes, certainly, yes. So thank you. Over to Vikas.
Thank you so much, Dr. Shraddha. All of those cases that you showed to us, those have some take-home messages, and as sir rightly pointed out, a very well done echo can solve many of the problems bedside. And just one take-home message, don't hesitate in going ahead with a transesophageal echo if your images are not clear on transthoracic echo. Instead of writing anything that you are seeing on transthoracic, go one step ahead and go for a transesophageal echo, like the one case that you showed of severe AR. Thank you so much.
Thank you, organizers. Now over to the... आपका भी है क्या? अरे तो आइए ना जल्दी से, हमको क्या पता है कितना मिनट, 7, 8, 9, 10, 5 मिनट, ओके 5 मिनट लगाना, 5 minutes, ओके, थैंक यू.
So
तब तक इधर अरेंज करा लो.
Good evening, everyone. Yeah, so the hidden diagnosis is diastolic heart failure. This is what I want to highlight.
It is not mid-range, I suppose.
Yeah, and this is, you see what has happened in over years. Over the years, the systolic heart failure has come down, and diastolic, the blue one, has gone up. So we are how to move it here. So I call it Chupa Rustam. Why? Because, yeah, so 1/3 of heart failure with preserved ejection fraction will have normal resting RA and pulmonary capillary wedge pressure. And how can you find out that? Make the person exercise. Dr. Sharma, I know that you are very intelligent. Listen to me or comment. You are most welcome. So maybe very symptomatic, usually no edema, no normal JVP, clear lungs, normal BNP level, normal chest X-ray, So what to do? The doctor will easily, the patient will say that, you know, that I don't have anything except dyspnea. And finally, nothing wrong with the heart. This is the reply of a doctor, physician generally. So just because of being old or maybe overweight.
Oh, after finding that the patient is not overweight, patient is not that old, if we can take up the exercises, no osteoarthritis, then one will normally go for a TMT evaluation.
Yes, that's what I'm coming to. So all those obese patients, they are very likely to have a diastolic dysfunction, diastolic heart failure. That is what I want to convey. And another one is atrial fibrillation is diastolic failure equivalent. In fact, this is diastolic heart failure. So that is another one. And third, what Dr. Hemant was telling is, Hemshankarji was telling, is exercise, make them exercise. And this we started long time ago. We started exercising patient, and then we would see what happens to the diastolic parameters in echo. And surprisingly, we found that a lot of them had diastolic dysfunction. This is about the classical algorithm of diastolic heart failure, which everybody knows. And this is grade 1, grade 2, and finally grade 3. So, second thing I wanted to highlight is that all the LVH are not because of hypertension. There can be many caveats what Shraddha has shown. So hypertrophic cardiomyopathy, of late we have been finding out a lot. And three of our, this is the publication which I did recently, that Stop Dreaming Mavacamten is here to help us. And couple of patients, 3-4 patients are on mavacamten. They have done tremendously well. The gradient has come down from 60s, 70s to 30s. This is a patient, one of our patients, who's on beta blocker and mavacamten, and the gradient fell down from 87 to 37. A recent patient, 3-4 months back. So it can be a hypertensive heart disease, it can be a hypertrophic cardiomyopathy, it can be CKD as well, or it can be amyloidosis. We have picked up several amyloidosis recently. So this is classical amyloidosis, apical sparing, what we call cherry on top. Sometime, 50% of hypertrophic cardiomyopathy will not have any obstruction. And then atrial fibrillation. Again, we have been cardioverting these patients very often, and results are pretty good. Echo has helped us, and we follow up those patients by doing a LA strain and transesophageal echocardiography. Just to highlight that mitral incompetence can be only because of atrial disease. That is the message I want to give you. So managing the heart failure with preserved ejection fraction, avoid inertia, and this is very funny kind of picture. The doctor, the heart failure specialist, out of which heart failure with preserved ejection fraction. And this is depicts that how much is the number of heart failure with preserved ejection fraction. Thank you.
Thank you, sir. Thank you, Dr. Sinha, for nice presentation. I think the time is short,
So we are going to conclude the session. Thank you.
Over to Shaibal.
K Singh sir, please come over. Dr. Gagan, Mithunjay. Sir, निकले. Hello. With the permission of Founder Chairman and the Chairman Bihar Jharkhand CCDSI, Dr. K Singh sir, we will start with the proceedings of GBM. First, we should condole for any members whom we have departed in the last. Any condolences? Any colleagues of any department whom we have lost in the last 1 year? Yes, right. So, next is announcement of the new team. Proceedings. We will now confirm the proceedings of the last meeting which was held. Confirmed by voice vote. You can. And seconded by Dr. Mithunjay, right. So we confirm the proceedings of the last meeting. And Dr. Taskin, yes. Next is the announcement of the new team. The new team will be headed by Dr. Gagan Gunjan, the chairman-elect. The new secretary would be Dr. Taskin. Chairman-elect would be Dr. Rajkamal Chaudhary. Rajkamal sir, are you here? No. Chairman-elect would be Dr. Rajkamal Chaudhary. The first vice chairman is Dr. Sudhir Chandra Jha. Is not here. The second vice chairman is Dr. Satish Prasad from Jamshedpur. Yeah, and the third vice chairman, new chairman is Dr. P.K. Agarwal. Dr. Gagan Gunjan and others will form the new team, and it will be announced in due course, right? And what would you announce the venue for the next conference?
Yeah, the next state conference of CCDSI will be at Ranchi. We will announce the dates in the next few months as we have our next meeting. And that's all. Thank you from my side.
I really thanks all of you for supporting me for the last 1 year, and I really appreciate your contribution. And everyone has contributed his role in this conference and throughout the year. So thank you very much for being giving me opportunity to serve CCDSI as chairman of Bihar and Jharkhand. Thank you very much. Now we request Mrityunjay Kumar Singh to vote of thanks. Okay. No problem. Thank you very much.
That concludes the GBM. Thank you so much. We'll be starting the inaugural function now, and music and dinner is planned outside. So you are most welcome to join that after the inaugural function. Umesh sir and Dr. Ajay Sinha sir. Ajay sir, this way, at the memento press, please, because you will receive it tomorrow. उनको भेजिए फोटो to grace the dais. Sir has started this society in 2015, and this is the 10th annual conference of the Bihar and Jharkhand chapter. Next, I will call on dais our chief guest, Dr. Professor Binde Kumar. Sir is the director of Indira Gandhi Institute of Medical Sciences, Patna, but now has also taken over as the Vice Chancellor of Bihar Medical University. Sir, please. Next on dais, I would like to request Dr. K Singh, sir, who is the chairman of CCDSI Bihar and Jharkhand. Dr. Gagan Gunjan, the chairman-elect Bihar Jharkhand CCDSI, please come on the dais. I would like to call upon the stage Dr. Shyam Narayan Prasad, he is the chairman of the reception committee. Sir, please come on the dais. And I, being the secretary, will join them as well. I'd like to request Dr. Dharmender and Dr. Vijay to felicitate the person sitting on the dais. Dr. Vijay? Dr. Sujit, please. Aye. हाँ, इधर से आगे से चलिए, उधर से निकल जाइए. To Dr. Binde Kumar, sir. Dr. N. Rai, sir. Next, Dr. Sujit. हाँ, शॉल भी साथ में लेंगे. ठीक, 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 ठीक. तुम इधर इसको लेते आओ, इन लोग ऊपर ही रहेंगे, पास कर दीजिए. हाँ, एक शॉल और एक ये लेते हैं, उधर दीजिए. हाँ, Dr. Sujit to present the shawl and the bouquet to Dr. Binde Kumar, sir. Dr. Dharmender to felicitate Dr. K Singh, sir. Dr. Sujit to felicitate Dr. Gagan Gunjan. आप अनाउंस कर दीजिए. आपका अनाउंस कर दीजिए. आप तुम अनाउंस करो.
Next secretary, sir.
I'll request all the dignitaries to join for lighting the lamp. Lamp ऊपर कर. Thank you. उसको उतार लीजिए. I will now request Dr. Shyamnarayan Prasad sir to come on the podium. And welcome the guests to the gathering.
ठीक है सर. Respected chief guest, Professor Binde, the founder of CCDI, the father of medicine as far as Bihar state goes, Professor N. Rai sir, dignitaries on the dais, off the dais, ladies and gentlemen. Welcome to the place of Lord Buddha, Lord Mahavira, and what not. If you are a nature lover, Rajgir is probably far ahead to any other place. If you are a religious person, here is the amalgamation of all the religion on this earth. We Sufism, Jainism, Buddhism, Hinduism, Christianity, you call on naming all everything. Right now, Rajgir is booming. It's not an old city. It's not the old glory only. The ancient Nalanda University has come up in a nice way, and that is probably one of its kind. You have some time, if you can visit that place, that campus, self-sustained campus, Nalanda University, that is one of its kind. Recently we had organized Asia Cup hockey. So there is a very good sports complex here. So Rajgir is a versatile place. You cannot ignore this place. So welcome this place, and I am from this place. So thank you all for coming here, and hopefully you will enjoy the place. Thank you.
Thank you, sir. I, Dr. Shaibal Guha, will now present the Secretary's report. At the outset, I would like to put in a disclaimer that the last year we all has been busy in our state with the National API conference. So all other activities were somewhat subdued as compared to other years. Still, we were able to do some of the academic work and with starting in August, we did a CME in nearby Bodh Gaya, which was very successful. It was a 2-day CME. We did it on 17th of August. Then we did a online CME on 29th September, which was also very nicely attended by more than 100 participants. Then we had another CME in Patna, which was done on screening and prevention of diabetes as well as diabetic complications, that we had done on 25th of September. We had organized a midterm conference of CCDSI Bihar and Jharkhand in Netarhat and on 22nd and 23rd of November last year. Different chapters of the society were nicely celebrated the World Diabetes Day, and more especially in the Gaya chapter, the Purnia chapter under Dr. R.K. Modi, the Patna chapter under Dr. Sudhir, and the Chaivasa chapter under Dr. Soumya Sengupta did it very nicely. And recently, Dr. Gagan Gunjan also had organized a obesity update in Ranchi in February. So we were able to do various academic activities in bits and pieces, but as I said earlier, it was not so active because we were all very busy with the National Epicon Conference. But we plan to restart our activities from this month in the subsequent academic year. Thank you for the opportunity given to me as a secretaryship. And now I will call upon the podium Dr. K Singh, who is the outgoing chairman, for his chairman's speech.
Thank you, Shaibal. And सर्वप्रथम मैं इस महान धरती को नमन करता हूँ। मगध सम्राट, प्राचीन मगध साम्राज्य की राजधानी, जो 3 यूनिवर्सिटीज थे एंशिएंट, नालंदा यही है। तो जो एक महान साम्राज्य और इसके साथ जो उसकी शैक्षणिक क्षमता थी, और कहा जाता था कि नालंदा यूनिवर्सिटी के अगर दरबान के क्वेश्चन को भी आप आंसर कर दिए तो आप बहुत बड़े बुद्धिमान समझे जाते थे। तो वैसी धरती पर आकर के चेयरमैन स्पीच देना मेरे लिए गौरवगन की बात है, और मैं इस धरती को नमन करता हूँ, नमस्कार करता हूँ, और आप सबों का स्वागत, नमस्कार, नमन करता हूँ। आज से 2017 में और उससे पहले 2017 में पहली बार इसी मगध धरती की कर्मभूमि में रहने वाले डॉक्टर एन राय साहब ने ऐसी सोच जागृत की जिसमें कि दोनों ही मेटाबॉलिक पोर्शन, जो कार्डियक और एंडोक्राइनोलॉजी है, डायबिटीज, उसको एक साथ समाहित करके क्लिनिकल ओरिएंटेड संस्था का निर्माण किया जाए। और मुझे याद है कि संभवतः उस समय मौर्य होटल थी और हम लोग ऊपर वाले चैम्बर में बैठ करके इसकी संरचना कर रहे थे। वो दिन और आज, बिहार चैप्टर की बात छोड़ दीजिए, करीब करीब 16 चैप्टर पूरे इंडिया में हैं। और अभी ताली बजाने का अवसर नहीं आया, अभी और ये है कि यूके में भी एक इंटरनेशनल हम लोग का चैप्टर खुल रहा है, और अब ताली बजाना है। माननीय चीफ गेस्ट महोदय बिंदे जी, इनके बारे में क्या कहा सकता है। दो बिहार हेल्थ यूनिवर्सिटी के वाइस चांसलर के चार्ज में, प्रेस्टीजियस इंदिरा गांधी इंस्टीट्यूट ऑफ मेडिकल साइंसेस के डायरेक्टर के रूप में मैंने इतनी हम्बल व्यक्तित्व नहीं देखा। मुझे याद है कोविड के ज़माने में हमारे मित्र डॉक्टर प्रेम कुमार की बेटी की शादी हो रही थी और बिंदे जी अलाव जला करके हम लोग का स्वागत कर रहे थे। तो ऐसे व्यक्तित्व के लिए जोरदार तालियां बजाइए, कम है, जोरदार। श्याम नारायण जी हमारे इस बिहार शरीफ को अगर जाना जाता है डॉक्टर के फील्ड में, किसी फिजिशियन के फील्ड में, और श्याम नारायण जी का नाम ना आए, ऐसा संभव ही नहीं। और गगन गुंजन हमारा छोटा भाई है, रिम्स में है, आज मैं उसे प्रभार दूंगा। और शैबाल खूबसूरत व्यक्तित्व का मालिक और सेक्रेटरी, इसके लिए तो कम से कम तालियां बजाइए जरूर। तो मैं जब जर्नी हम लोगों ने शुरू की थी, मैं अपनी बात 2 मिनट सर समय लूँगा, अपनी बात कहना चाहता हूँ कि जर्नी जब शुरू की थी CCDSI की, तो कुछ और ऑर्गेनाइजेशन की जिम्मेदारियां भी मेरे पास थी। संभवतः मैं उस काम में उतना खरा नहीं उतर पाया हूँ जितना कि मैं सोचता हूँ, या जितने लोग हमसे हो सकता है एक्सपेक्ट करते हों शायद। लेकिन मैंने कोशिश की, और सभी लोगों ने, चाहे डॉक्टर शैबाल हों, डॉक्टर धर्मेंद्र हों, डॉक्टर सुजीत हों, ऑल पूरे जो CCDSI के मेंबर्स हैं, मृत्युंजय हैं, सभी लोगों ने जो सपोर्ट किया है, और विगत 1 महीना में हम लोगों ने जो काम किया है इस कॉन्फ्रेंस को सक्सेसफुल बनाने के लिए, उसके लिए 2 लाइन कहूँगा कि वो पथ क्या पथिक कुशलता क्या जिस पथ पर बिखरे सूल न हो। वो पथ किस काम का जिस पथ पर बिखरे सूल न हो। नाविक की धैर्य परीक्षा क्या जब धाराएं प्रतिकूल न हो। तो धाराएं प्रतिकूल होगी तभी आप काम कर पाएंगे। और जब तक कहता है कि जब तक कोई चीज़ की कमी ना हो तब तक इनोवेशन नहीं होता है। और इस कमी में ही हम लोगों ने इस इनोवेशन को खोजा और उसको जागृत करने का प्रयास किया। संभवतः यही मेरी सफलता है और हम सब की सफलता है। तो मैं ज़्यादा समय नहीं लेते हुए मैं सभी लोगों का एक बार पुनः धन्यवाद देता हूँ। यहाँ जो लोग बैठे हुए हैं और उन नारी शक्तियों के लिए जिसकी 8 मार्च को नारी दिवस मतलब इंटरनेशनल वुमेन्स डे थी, और उन लोग के कंट्रीब्यूशन को कोई भी भूल नहीं सकता है। 11 बजे 12 बजे जब शैबाल को, चाहे RK मोदी को या किसी को भी फ़ोन करे, सुधीर को, तो नमस्ता फैमिली के लोग भी निश्चित रूप से इरिटेट होते होंगे और उस इरिटेशन को भी उन लोगों ने समाहित किया आपके डेवलपमेंट के लिए। तो उन नारी शक्तियों को भी नमन मैं करता हूँ। और लेकिन नारी शक्ति के लिए जोरदार तालियां होनी चाहिए। लेकिन तो इन सब बातों के कहने के बाद मैं अंतिम ये कहना चाहता हूँ कि आप सबों का बहुत बहुत प्यार मिला है। धन्यवाद आप सबों का। सुमन साहब की एक कविता है, मैं उसको कहते हुए अपनी वाणी को विराम दूंगा कि जिस में पथ पर स्नेह मिला उस राही को धन्यवाद। दाएं बाएं सुख दुख चलते हैं सम्मुख चलता पथ का प्रमाद। जिस से पथ पर स्नेह मिला उस राही को धन्यवाद।
Thank you, sir. Now comes the time for handover and change of guard. So I would request Dr. K Singh and Dr. Gagan Gunjan to stand in front of the dais. हाँ, वो वाला सामने पेपर इधर राइट पेपर रखते हुए I would now invite Dr. Gagan, the incoming chairman, to address the audience.
Distinguished guest Dr. Binde Kumar, our founder president Dr. A.N. Rai, Dr. Syam Narayan, organizing chairperson of this conference Dr. K Singh, organizing secretary Dr. Shaibal Guha, other delegates, faculties and fellows in this hall. Good evening to all of you. Today I stand before you with a deep sense of gratitude and responsibility as the incoming chair of the CCDSI, Bihar and Jharkhand. I am deeply honored with this sense of responsibility that has been conferred on me, and I take this charge of this honored society at the state level. No doubt we are doing well at national level too, and we are soon going to open our international branch in UK, whose travel plan is scheduled in the coming May of this year. I would like to thank my predecessor for setting such a high benchmark and for all the exceptional work that has been done in the past and his exemplary vision, which is going to be a great challenge for me. But then I accept this challenge and I will try to do better than what has been done in the past. And for this, I would incorporate 2 pillars as my support. That would be interdisciplinary collaboration and mentoring and nurturing of the younger generation that is coming into clinical practice. But then any society does or thrives, but then it is not possible for me to do it alone. And any society thrives on its members. And I would definitely need support, ideas, and help from all the members of this society. I take a pledge to take CCDSI to make CCDSI as a beacon of innovation and integrity. With this, I end my words and thank you for honoring me so much.
Thank you. Thank you, Gagan. I'll now request all the dignitaries to release the conference souvenir. Thank you. I'll now request Founder President, Dr. A.N. Rai sir, to bless the gathering.
Dignitaries on the dais, esteemed colleagues, press and media, at the outset, I would like to congratulate organizing team for arranging such an excellent conference. Though we were all busy in the EPICON, but in spite of shortcoming, we have managed to hold such a great conference. We had excellent scientific program and good hospitality. So what more we want? These two are the things. Scientific program should be good, hospitality should be good, and accommodation is always there. Tomorrow we are going to visit those who have not seen. We have come, we are the locals. So for those who have come from outside, they can visit. And as Dr. Shamnaran said, it is a historical place, many places to visit. As far as CCDSI is concerned, we started our journey to 2016, and it was formed on World Diabetic Day, and we had our first conference in 2017 at Bodh Gaya. Bodh Gaya was the first, so it is, and now it is the 10th. It is Rajgir, both related to, as I told yesterday, it is both related to famous for Lord Buddha. So this is, we must follow the preaching of Lord Buddha. We serve the society. The aim of CCDSI is to serve the society, and the main aim of society is, our chief guest was saying, what was the reason we decided to form this? Our main aim was that, as you are aware, non-communicable diseases, lifestyle diseases are increasing in number. And by 2050, more than 2/3 patients will be having these diseases. And good thing about these diseases are, they can be prevented, because the two risk factors for this lifestyle diseases are genetic predisposition and lifestyle. So genetic predisposition is beyond our control. It is the lifestyle which we can manage. So this can be managed, and by regular CMEs in periphery and conferences, we can train our doctor, we can update our junior doctors, and eventually for this, once they are updated, our rural masses will be benefited. and we will do regular, the other aim is to do regular screening camp. In such a short journey of 10 years, till now we have got confirmed 10 chapter, 5 are in pipeline, that is Madhya Pradesh, Jharkhand, not Jharkhand, Madhya Pradesh, Chhattisgarh, then Gujarat, Maharashtra and Hyderabad. But 10 chapters are already established chapter. And as you have heard, we are going to open the overseas chapter in UK. In all probability, it is all settled. It is just paperwork. And there are many between comes or leaves. If there is some problem occurs, we may not succeed. Everything is okay. Everything has been arranged. But the paperwork at UK is there is a problem. So I hope it will be sorted out. Once it is sorted out, we are going in June. With this, I once again thanks everybody for their cooperation. Thank you very much.
We are proud to have Dr. Binde Kumar as our chief guest now. So before I call him, I'll just introduce him to the august audience. Sir has done his undergraduate and post-graduation from Patna Medical College, and after that he did his MCH in pediatric surgery from PGI Chandigarh. After that he did his DNB and FRCS, and he also had a postgraduate diploma in hospital management done from New Delhi. After that he has further medical training from a WHO fellowship from Sydney, a fellowship in pediatric urology in Texas, training in advanced lap surgery at Strasbourg, France, and he was trained in pediatric urology in London. After that, when he started his career, he joined Maulana Medical College, and then finally he joined IJMS Patna as professor and head of pediatric surgery. After his stint at IJMS, he joined All India Institute of Medical Sciences Patna in 2013 as professor and head of pediatric surgery. He joined a few years back as director Indira Gandhi Institute of Medical Sciences, and recently he has also taken charge as the vice chancellor of the prestigious Medical University of Bihar. So my association with Sir dates back to 1999, when I was fortunate to work as a junior colleague under him at Indira Gandhi Institute. He is primarily a clinician, a top-notch surgeon, but now he has turned into an administrator, and that is taking most of his time now. So over to you, sir. Please address the gathering.
Very good evening. On the dais, I'm sitting beside one of the stalwarts in medicine, Professor A.N. Rai. We know Bodh Gaya, one by the Vishnupad Mandir and Buddha's temple, and another by the name of A.N. Rai. Sir, I'm just telling you the fact. In 1981, when I joined Patna Medical College, we have a glimpses at which place which physicians and surgeons are doing it. And you know the stalwarts are there. Being in Gaya, you have the reputation and the aura. The people have not made even in Patna, Darbhanga and Ranchi. At that time, it was combined Bihar. So that was a great thing, and I am very much lucky to be sitting with him on the dais besides him. So I'm very much thankful. My elder brother, Shyam Narayan sir, if we talk about the practitioners in the periphery, the one name came is Shyam Narayan sir. आप श्याम नारायण साहब से अधिक practice करते हो. He was this, but actually he was a landmark. Sir, it is your humbleness. We know many of your friends are our friends, common friends, and we have seen it. K Singh sir, the great friend of my bosom friend, my pal, Professor Prem Kumar, and I have known him, practicing in Aurangabad, nearby place is Sasaram, where I belong that place. Sir, Dr. Prem has all high words for you. Dr. Gagan from Rims Ranchi and Shaibal Guha, when he asked me 2 days before, कि सर आप राजगीर आ सकते हो, हम बोले कि हमको राजगीर आने में कोई दिक्कत नहीं, राजगीर the second home. I have a déjà vu feeling sitting and addressing these guardians. Many times I have come in the surgical forum when I was the treasurer, I was the secretary, and later on I was the board of governor member of ASI. and have gathering like here. And people of Nalanda, especially Bihar, sir, were very warm. And we are having Bihar and Jharkhand combined together, and I cannot see what feeling I have when I'm seeing the faces in the audience. My elder brother and the great cardiologist, Professor Ajay Kumar, Madam Ranjana, Bikasji, he's busy there, and many more, Ravi Kirti, all the friends of AIMS and IGMS, Dr. Sudhir, sitting there, Professor Hem Shankar Sharma. I have many interactions as Vice Chancellor. He was principal at that time, and he always had the excuse, Binde, humko chhod do yaar. Humse hi mat kaam karwao. And I have always respect and spared him for whatever work was there. So it was a very nice thing, and I am very much humbled and very overwhelmed by the way you have invited me, and I'm just standing in front of you. It gives me immense pleasure. The cardiology and the diabetes, the two great killers, were being treated in the silos. I salute the vision. I was discussing with Professor A.N. Rai sir, who has given this idea, these two great killers who are being treated by two sub-specialties in a way, and now the physicians have come in the way to bridge that gap. That is a great idea, and that will not help in early detection, prevention, and virtually mastering the techniques of how to deal with at peripheral level to this patient and to do justice, because our healthcare is still fragmented. We are having specialized services at some places, and most of the places the physicians are there, the first person to be encountered. So training and giving them what are the problems with the cardiology and diabetes and associated all the allied things which is coming in the way, lipid and many things we are going with and dealing with. I think the conceptualization of this forum is something which is worth, and those who have conceptualized, I salute him. The one thing I want to say and tell you in the context of the 40 years I've spent as a doctor and later on for a few years as an administrator. The clinicians and the physicians here are, from the day I have seen the days of Patna Medical College, and later on when I was working with even an IGIMS for 17 years and for 10 years at AIMS Patna, they are excellent. Their skills, their dealing with the patients, and the management, which is one which can compete with anywhere in the world. So the great work you people are doing, we are proud of, sir, and we always salute you for those works. I will not take much time. I think that the whole day you have deliberated and next day is there. So I will just tell you, I feel honored in standing in front of you. Thank you very much.
Thank you, sir, for your kind words. Now I'll request Dr. Mrityunjay, who is the National Secretary of CCDSI, to come over and deliver the vote of thanks.
Good evening and pranam to all of you, respected dignitaries on the dais and off the dais. It is an immense pleasure for me that I have been chosen to propose the vote of thanks for this conference. We are deeply grateful to our esteemed speakers for sharing their vision, invaluable research and expertise in their specialty. We would also like to thank all the chairpersons, panelists, and all the dignitaries who have attended this seminar. I would also like to thank the sponsors for this conference like Alchem, Aristo, USB, namely, and others also. I would also like to thank the delegates for their active participation and insightful questions that made the session interactive. Thank you to the technical team, audio-visual team, and hospitality staff for ensuring the seamless operation of the event. And at last, I would like to thank the organizing team under the chairmanship of Dr. K Singh sir, the organizing scientific chairman who has very beautifully crafted the program, Dr. Gagan Gunjan, Dr. Shaibal Guha sir, Dr. Sudhir sir, Dr. Dharmender, Dr. Sujit, and all others who have cooperated us for the last 15 to 20 days so that we can have this conference. So thank you to all of you once again. Kindly join us for the dinner.
I will now request all of you to stand up for the national anthem.
भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड़ उत्कल बंग विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंग तव शुभ नामे जागे तव शुभ आशीष मागे गाहे तव जय गाथा जनगण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे.
Thank you, everybody. I will now invite all of you for some music and dinner. It's in the field outside. And we are assembling tomorrow morning at 8:30. The first talk will start at 9.